Good afternoon, everyone. On behalf of the organizing committee of 42nd Annual Conference of AOGD and First E-Conference, it's my privilege to start the second day's scientific proceedings. I invite the chairpersons of the first session, presidential session. Our chairpersons for this session is Dr. Archana Verma. Madam is Vice President-elect Foxy, Senior Obstetrician Gynecologist from Ghaziabad, a very charming personality. Our second chairperson is Dr. Rekha Mehra. She is the Director, Mehra Nursing Home, Tilak Nagar, past President IMA Janakpuri. We have honor to have the presence of Dr. Neera Agarwal. Madam is Director and Head Obstetrics and Gynecology Department, Max Super Speciality Hospital, Paparganj. Madam has been Senior Professor and Head UCMS and GTB Hospital. Madam has so many years of teaching experience and she is very popular with her students. Our chairperson, Dr. Anjali Tempe, Madam has been the Director Professor of Maulana Azad Medical College and LNJP Hospital. She had been ex-HOD of the Department of Obs and Gynae at Maulana Azad Medical College. Again, Madam is also very popular with her students. I hand over the proceedings to doctors, chairpersons to carry on the proceedings.
So, very good morning. Myself, Dr. Archana, it's my proud privilege to introduce our the most popular and very senior doctor, Dr. Sudha Prasad. And we all know her that she is a vice president of Foxy, and she has done wonderful work as in the infertility, and she has received many awards, and she was in chairperson infertility committee AOGD also, and she is today she'll be speaking as first opening second day, and because e-conference of AOGD, and many congratulations to Dr. Mala Arora and Dr. Mamta and all my respected seniors and everybody present here and my co-chairpersons. So welcome, Dr. Sudha, madam.
This is, I want to extend my thanks to Dr. Mala and her team for this wonderful conference. It is in this pandemic, it has shown a wonderful experience to everybody to work with digital and to have a better presentation and better meeting each other. At this outset, I want to take the advantage to speak about my ever waiting Indian Fertility Society Congress, Fertivision, and this time we have another big feather of the first virtual global Congress of Indian Fertility Society. There is a special offer. I would like that all of you should have an experience of this conference, which is going to have on 4th to 6th December. And we have 10 workshops on 29th of November, all about infertility. My topic is IUI failures. What to be done next? We all know the definition of infertility. The 1 year of well-timed and unprotected coitus without conception should come, and we should investigate both of them, and we should try to manage. But in all cases, no. When there will be a age is 40, or if chances are there that only the 10% of the menstrual cycle, 10% of the pregnancy can happen in this patient. So they should be investigated not after 1 year, they should be investigated after 6 months. If the cycle is not regular, or if the male partner has the fertility problem, they should be also taken care early. When we talk about the assisted reproductive technology, that is, if it is a vaginal intercourse, then it is a normal conception. But other than vaginal intercourse, all are coming under the head of the ART, intrauterine insemination, IVF, ET, ICSI. But IUI is the first line of procedure over IVF because it is less stressful, less expensive, and less invasive. It is a very simple, but IUI alone in a natural cycle without stimulation, if somebody is doing, chances of pregnancy does not improve. Always with the mild ovarian stimulation, it should be done. How it helps? It allows the sperm-ovum contact close to the date and time of ovulation by bringing the sperm very close to the fertilization site, bypassing the cervical factor. And of course, always the semen preparation has to be done, and prepared semen has to be pushed inside at the time of IUI. Why? Because it separates from seminal plasma a concentrated pellet of motile, and normal morphological sperms free of dead spermatozoa, leukocyte, immature germ cell, debris, everything is separated. Only the normal morphological sperms are available to be done for the IUI. What is the rationale? It has been seen after 1 hour of normal intercourse, only 0.1% of the spermatozoa are placed in upper vagina. But here in IUI, we are increasing the gamete density at the site of fertilization. So chances are definitely better for the pregnancy. But here are the few prerequisites. In India, in our country, the genital tuberculosis incidence rate is quite high. So always one endometrial aspiration has to be done before we start the investigating patients and before we do the hysterosalpingogram, because we need that the tube should be patent, at least one tube should be patent, uterus should be absolutely normal, and the semen analysis, when we do, at the time of insemination, the count should be more than 1 million. The sperm morphological, what we take, the criteria should be more than 4%. And per ejaculate, total motile sperm count should be 5 to 10 million for IUI. This is very important. And the motile sperm should be more than 30%. And of course, when we are doing the follicular monitoring, the follicle should be ruptured. So we have to look that also, because many times follicle is not ruptured, maybe due to the PID or endometriosis or thick zona. So we have to look at that also. And again, I'm telling the patent tube should be there. HSG has to be done, or sonosalpingography, whatever the method is applied, it has to be done, because without seeing the tubes, we are going to do in such kind of tube, we are going to do the IUI. What are the predictors of success? If we have taken the good patient, age is less than 35, duration of infertility is less than 5 years, and etiology, if it is anovulation, total motile count is more than 5 to 10 million, and there are 2 to 3 follicles which are recruited by your ovarian induction, then chances are far better. Timing of IUI can be 12 hours, 24 hours, 34 hours, that we have to judge when we are giving the HCG injection. Question comes, how many cycles of IUI are enough? It has been seen per cycle, IUI result success in only with the stimulation is only 11 to 16% only. So a very good study was done by the European, it was published in European Journal, that they have done in a multiparous patient and the nulliparous group, they have done 1 cycle and the 2nd cycle. Once they have judged, when they reach to 3rd cycle, chances of success rate decreases in both the groups. So the question comes, how many cycle has to be done? They suggested at least 2 cycles of IUI should be offered to the patient, after, of course, individualizing them, beyond which the utility of IUI becomes questionable. So minimum 2 cycles of IUI has to be done. What can be the reason of failure for IUI? We all know, if we are not concentrating on the sperm parameter, the male factor is the big reason, big cause. So you have to look male. If ovarian reserve is less, naturally the oocyte quality will be poor, and the poor embryo quality will be there. In IUI, we cannot see whether the fertilization is occurring or not, implantation is occurring or not, and the luteal phase defects are there or not. So you have to look all these parameters before we start IUI in a patient, because the patient has come with great hope. And if there is a male factor, because we have seen that the male factor can be of 12% in all couple, but it can rise up to 60% also. So if there is a male factor, we have to take the referral from reproductive urologist or endocrinologist, because there are can be many reasons that it can be oligospermia, there can be a leukocytospermia, and we are doing repeatedly IUI and there will be a failures. So before doing so many IUIs, we have to consult endocrinologist or urologist. This is 2010 semen analysis, which gives that 15 million is the per ml should be the count, and morphology should be the 4%. And sperm washing has to be done. The motile sperms comes here, and these are the motile pellet, which can be done very easily. So total motile sperm count is very much important, because it can it suggests that which method, what is the diagnosis in this patient, and which treatment of male infertility has to be applied. If the count is more than 5 to 10, definitely IUI, but if it is less, then we have to further proceed for assisted reproduction. According to the semen parameter, this is very stated one. Please do not do, if the count is less than 5 million, please don't do the IUI. It is 5 to 10, which gives a very good result of IUI if all parameters are normal. And if it is 1 to 5 million, IVF has to be done. And you counsel the patient. If the count is less than 1 million, patient has to go through intracytoplasmic sperm injection. When we do the IUI, very gently the cuscos, not to touch with the cervix, and simple catheter, very gently without struggling, it should be pushed just above the internal os, and the washed sperms are pushed inside. So the successful of IUI, maximum 3 follicles should be there more than 18 mm. If you do ET, then E2, then the E2 level should be 150 picogram per ml. And endometrial thickness is another good parameter. If the parameter is of more than 8 millimeter, 999, it will give the best result of success of IUI. But if the chances of follicles grown more than 4, and E2 is more than 1500, then we have to think over, because chances of hyperstimulation, multiple pregnancy increases. So these patient has to be shifted from IUI to IVF. If you see closely the indication of ART like IUI or IVF, they are often not dissimilar to those for IVF. But of course, they are few are interchangeable. Here one can see that the unexplained infertility, where we do not know whether the fertilization is occurring or implantation is occurring, but here at least in IVF we will see the fertilization has occurred. So unexplained infertility is common in both. Endometriosis mild, one can do IUI, but if we are not successful, immediately it has to be shifted for IVF. Male factor mild can be done. Male factor mild can be for the IUI, but if it is moderate to severe, IVF has to be done. Ovulation induction disorders will be there, then chances are there that it can be offered. So patient to be offered,
1 minute to go, please. 1 minute to go.
Yes, patient to be offered for IVF if she is more than 40, poor ovarian reserve. If a ovarian reserve is less, like AMH is less than 1.5, and IUI more than 4 cycles given, failure, or IUI unexplained infertility, endometriosis, these are the causes for patient to be shifted. We all know for the IVF, the success rate is 20 to 40%. So carry home message, IUI to be stopped and offer IVF. Women age more than 40, poor ovarian reserve, AMH less, IUI not to be done more than 4 cycle, and failed IUI can be there in unexplained infertility, endometriosis, male factor ovulatory disorder. Again, I take the opportunity to invite all of you for Fertivision, which is going to be happening on 4th to 6th of December. Thank you so much for giving me time for talk.
It was really very nice, madam. 1 minute conclude ko time mil raha hai na. It was very nice because we all know that IUI is one of the first step treatment offered to every infertile woman. It is cheap and simple, and patient prefer it also. But we must know when to stop and what are the predictors for successful IUI, and of course when to refer to a proper IVF specialist. Thank you, madam. You did the wonderful job. Thank you.
Thank you so much. Thank you.
Thank you, ma'am, for the basics. So now this is the time to introduce one of the speaker, Dr. Sharda Jain. She is the director of the Life Care Center and IVF Center. And this very, very informative achievements she had in her life, but the best achievement now she is having, I know that her hidden talent, that is music. And most of the time she is singing bhajans. So in a way, it is to connect with God. So we are very much inspired by you, Dr. Sharda Jain. And we keep counting the days when we meet you in the bhajan sandhya. So please welcome Dr. Sharda Jain. He'll be speaking on how to make the effective presentation. Never discussed before.
Respected chairpersons, my colleagues and friends. I'm an old teacher, and today I'm not going to talk on any topic related to obstetric and gynecology. I'm going to focus on something very basic, how to make effective presentation. Public speaking scares most of us, but that is something, nothing is impossible these days. We can definitely train ourselves. It's a fact that we talk too much. This respected person had said, people like men of few words. And the doctors also like short and crisp presentations with clear messages. Secondly, we all must know our audience. Kinse baat karni hai? Unki kya need hai? Because the talk should always be audience focused. What do they want from me? 98% of people who come to attend conferences are ordinary doctors. Only 2% people are professor types. So most of us need short and engaging presentation with clear messages, less data intensive, few clinical tips, and in take-home messages should be like customer feedback type. And that is why we are here to learn what to talk, how to talk, and whom to talk. Now, when it comes to topic, pick up a small topic for yourself, which you wish to highlight, and not the whole book. 80% people who come for conferences already know about the topic. What they're looking for latest Cochrane review, the latest guidelines by the respected bodies, and something new, few tips. And then finally, the sum up should be like key opinion leaders summing up. So how do I talk? I must talk precise, I must talk quick, and my talk should be emotional. This has helped me, this should help you too. Deliver in such a way that everything is imprinted on the mind. They don't have to refer back to the notes. You're not born orator, but you can be groomed. As far as I'm concerned, I did take part in schools in debates. Lady Harding gave me the command of 2 languages and made my basics clear, but my main grooming was done at PGI Chandigarh. They made me good salesman. I can sell anything. I was also told, practice makes you perfect. That's why you need to rehearse, rehearse, and rehearse. Learn to time it. I remember very well when I made the first presentation as postgraduate, my mentor, Professor P.K. Devi said, child, you need to rehearse 100 times. You will never falter. And I think that's a message of mine to you too. Dress code, as far as we are presenting in India, everybody appreciates sari. Your hair should be also well groomed. There's scientific study now which shows that the text of your presentation is only 7%. Your voice, where you emphasize, makes about 38%, and the body language is the rest. So be 100% comfortable. Your eye contact with your audience should be there all the time. And if you can use your hands, it'll be absolutely great. In your presentation, there should be 3 to 5 clear messages. Do not paste the book when it comes to slides. Never-ending text nobody can read. Most of it called this also a crowded slide. So you ask your closest friend, once everything is ready, what is her perception? If she says it's boring, if she says it's confusing, her word are the last words. Delete extra text. Keep it simple. Talk in a very simple language. Time it. And 1 picture is better than 1,000 words. So make more and more visuals you should use in your presentation. The attention span of this fish is 9 seconds. The humans are worse than this. It is less than that. And that is why AOGD in this particular conference has given 10 minutes, irrespective of who are you, just 10 minutes of your presentation. There's a purpose behind that. So in the end, the talk should be personal, it should be short, more of visuals, and it should be impactful. It has helped me, it should help you too. Coming to the first example. AUB has replaced the old term DUB. The FIGO has coined the etiology and summed up as palm coin. Mirena is dominating as far as the treatment strategies are concerned because it improves the quality of life as well as it reduces the mean blood loss. So when it comes to presentation, finally, you need to individualize and strategize your things in a problem-oriented way. Mirena is great. Medical therapy has a place. Surgery is the last resort. Coming to the second example, if you have to talk right in terms of safety and efficacy of HPV vaccination. This quadrivalent vaccine has been there with us for the last 15 years since the time it has been approved by the US FDA. As for the data is concerned, of its effectiveness in adolescent, in young woman, in adult woman, the efficacy is undoubted. Zero breakthrough. Beside that, it does not require any booster so far because of sustained immunogenicity over the last 15 years. And the vaccine is safe and well tolerated. So in the end, I can say power of presentation is in your hands. If you want to make, you can make it awesome. If you want, you can make it boring. Thank you very much for listening.
Thank you very much, Dr. Sharda. As usual, I think your presentation was very good. It was not at all boring. It had given very important tips that you have to rehearse, rehearse, and rehearse. As always, we were looking forward for such a good presentation. And I again, lovely presentation. Now, I also thank the organizers, particularly Dr. Mala, for giving me the opportunity to introduce the most energetic personality, Dr. Ragini Agarwal. Dr. Ragini, we all know her very well. She is the vice president of FOXI in 2020. She has a lot of contribution towards the FOXI, as that she established, or she was the founder president of Haryana Obstetrics and Gynecology Society. She has also developed the Society of Gurgaon Obstetrics Gynecology, but her main interest has been in aesthetic and regenerative medicine, and she is the president-elect of that society. She is also the president of Indian Academy of Cosmetic Dermatology and Gynecology. She is speaking today not on the routine obstetrics and gynecology topic, but she has selected to talk on a very important and very different type of topic, and that is the women's intimate health. Let's talk about it. Dr. Ragini, please. Dr. Ragini Agarwal, please. Hello. Where is Dr. Ragini?
Ma'am, we can't hear you.
Hello, Dr. Ragini. We can't hear you. There is something wrong with her mic, I think.
Ma'am, can we go to the next speaker then, so the time we check with Dr. Ragini Agarwal?
Yeah, I think we can invite the next speaker.
Okay, shall I do that, madam? Yes. Okay. So may I now invite, for the time being, till Ragini comes on, may I now invite Dr. Mandakini Megh. I'm sure you all know her. She's a chairperson of ICOG FOXI, and she has been doing a lot of work in family planning and ultrasound and ECPNDT, and she is vice president of so many things like international vice president, Central Asia, vice president of Central Council, national vice president FOXI, and so on and so forth. She has to her credit a lot of books and publications, I'm sure. And she worked in Kama, so she comes from Mumbai. And Dr. Mandakini is going to talk on abortion care in this present scenario. You all know that we are all facing the problems of COVID and isolation and depression and so many things, and what happens to our patients in this vitally important abortion when they need it. Let us hear what Dr. Mandakini has to say about these things. Abortion care and family planning, probably. Dr. Mandakini, please. Over to Dr. Mandakini.
Good afternoon, everyone. Can you hear me, please?
Yes, yeah. We can hear you.
Okay. So at the outset, I'd like to thank Dr. Mala for this, wonderful conference with all her organizing committee and all the, scientific people. She has put up a beautiful program, a much needed program, and the theme is so apt for the present time. So thank you, Mala, for inviting me. And second thing, apologies to Dr. Sharda Jain, because whatever she has told, my presentation is just opposite it. And from next time, Dr. Sharda, I'll try to make it. आपने थोड़ा 2 दिन पहले बता दिया तो अच्छा होता. So no problem, but it is not that boring also. I promise you. So let me share and I'm going to talk on a very important subject of the abortions in this clinical challenging time, and very important, because everybody is all OBGYN, we are all facing this problem, and we must know what are the recent guidelines and things. So I'm going to share my screen. Can you see it, Madam Chairman? Is it visible?
Yes,
We just have to do
Yes.
a
Okay.
correction.
Okay.
do
Okay.
it screen.
Yeah. I'll do that.
Full screen.
Abortion care in the current challenging time we all are facing. And I start with the FIGO statement that COVID-19 crisis has created this unprecedented strain on the healthcare system, including inpatient, outpatient, emergency surgical services. Regardless of the constraint, women must have this sexual and reproductive health care, access to the safe abortion, and decision about the preventing pregnancy, whatever may be the situation in the country and in the world. The FIGO statement here I'd like to mention that FIGO has given a great appreciation to the Indian abortion law, that is MTP Act 1971, and also we are at the verge of amendment, where the other countries' reproductive and sexual rights, they are actually struggling to give a basic services also. So women should always need abortion and should be accessible, affordable, and should be given with the dignity to the women. That is most important. Globally, around 15 lakhs pregnancy end in abortion every day, and COVID pandemic continues the spread. Medical services, health systems are all stretched. So provision of safe abortion is extremely time sensitive, essential health services that cannot be forgotten. The key facts are between 2015 and 2019, around 73.3% million induced abortions were occurred worldwide. And what figure I'm going to give you just next is, now this post-pandemic, the family planning services are severely affected, about which 36, 21%, 15% reduction in the COC distribution of the contraceptive pills distribution, 23% less distribution of the condoms, and also I couldn't put it here, 28% abortion rate has increased. So this is a figure of the official figures of the this NGO of the sexual and health reproductive area working. So in any case, we have to give safe abortion must be provided and supported by a trained staff, because in India, we have requirement of a trained staff, and the qualifications are given as a MBBS and the trained personnel. Now, as per the Government of India guidelines, Mrs. Vandana Gurnani, Joint Secretary, Health and Family Affairs, has clearly mentioned that contraceptive around 13.9 crore, this is pre-COVID, 13.9 crore, we are using the modern method of contraception, by which we could actually prevent 18.2 lakhs unsafe abortion. This was pre-COVID. And you can see here unintended pregnancy. See the number, 5.44 crores. So when there is around 20% contraceptive is not being given, you can imagine what is the situation of, unsafe abortion and unintended pregnancy. That is how this topic is so important. Now, as per the Government of India guidelines in the National Health Mission, the provision of comprehensive abortion care, that is CAC, has to be provided to all the walk-in beneficiaries and to those who are designated CAC comprehensive abortion care facilities has to be provided. Abortion is essential and reproductive health cannot be put on the hold. And strategies are very, very important. So I'm going to just give you, as per Madam Sharda Jain's, guidance. Now I'm going to give only the highlights and not going to read everything. Madam, please take my private tuitions. Hospitals to continue to provide any time sensitive, so hospital will provide time sensitive reproductive health care that must be performed in the hospital setting and also in the private, which I'm going to come to later. As per the Niti Aayog, in a recent publication, it has said that telemedicine practice, friends, it is very important for all of us that Government of India is authorizing or approving the telemedicine practices which can prevent the transmission of the infection and reducing the risk to the healthcare workers and the patient. And the abortion services, telemedicine for abortion has multiple advantages. It's an official statement. So we all can actually use it and there will not be any kind of more legal problems. It can allow a woman to access the expert advice from the safety and privacy of their home. According to Ministry of Health and Family Welfare, abortion care and contraception are essential services. You cannot stop it. Should be continued whatever the situation it may come. Now I'm going to divide my small talk into three main components. We will have the international guidelines, which is our basis of our practicing OBGYN, government doctors, policymaker, everybody, RCOG. Then we have Indian guidelines, GOI, FOXY, and NGOs like Family Planning Association, IPAS, all the NGOs who are, proactive into the family welfare services and the abortion services. I'm just going to talk about it. As per the RCOG guidelines, which is most important, is that if women requires abortion, we have to first offer her the remote consultation by video or telephone, and give the via email and link, give her the prior information. After the remote consultation, which is very, very high quality, like a face-to-face consultation, you have to see her history and everything, and then provide her the services of the medical abortion. And medical abortion, they actually are saying that it can be you have to post the mifepristone tablet, abortion medication, other, analgesic, everything to be posted into their, basically in the UK, offer remote or self-assessment using the low sensitivity pregnancy test 14 days after medical abortion. So these are the basic. On these basics only, in India also, we are almost following the same kinds of guidelines. We should provide ultrasound only when there is unable to provide LMP, or you are thinking that patient is having a history of ectopic or pain in abdomen or intrauterine devices in the situ. All this contraindication has to be kept in mind. Then only you can go ahead with the, and all other things are given in detail. Pathways to minimize the COVID exposure. We have to organize medical abortion services by video and teleconferencing and postal delivery. This is what is the main method, whether you are in the government, whether you are in the private, but it is more applicable to the private practitioners. Then self-referral, patient will not have a referral key or slip. It will be self-referral and is recommended by the NICE and can be done remotely. So all the guidelines, RCOG, NICE, everybody is recommending that early abortion or the medical abortion can be provided by telemedicine. Consent, here again they are saying consent does not have to be a written signature, but only entry has to be there, so that you are legally safe, that you have informed her and you have taken a proper precaution. Other pathways, nursing staff and other things has to be properly trained in all these things. Now, if you look in the India, these were the RCOG guidelines. Look, come to the India, FOXY, advisory and other things. It should be approved. In the MTP law, it is given that those who are approved doctors or approved practitioner only can do the MTP. So we have to follow. We cannot ask anybody who is not actually authorized to give the MTP pills. There are many challenges. Maintaining social distancing, we all know what is happening to the social distancing, availability of providers. So many people were refusing in the initially March, April, May, June. Many people refuse. Now everybody started doing the routine MTPs, ensuring availability of drugs also again a problem, ensuring follow-up is a problem. So all these are the things. Then you have to have the pre-abortion counseling in very, very detail. Already RCOG guidelines has given it. This doctor's number, phone number, everything should be accessible. And after that, contraception awareness, availability, uses, etc. Everything should be known. And you have to supposed to pick up the pregnancy at early gestational age before the 9 weeks. Otherwise it will become a surgical abortion. ASHA, ANM, etc. has to be utilized to provide the contraceptive and emergency pills. So what are the methods actually? Suppose I am a private practitioner, I want to do, so I have to choose from, it should be effective, minimal complication, less restricted, not required GA, simple and easy are the method. And these method are medical method and MVA. Medical method, we are all aware that, and now in RCOG guidelines, it is said that they have changed the policy temporarily so that you can give the mifepristone and misoprostol at the home only. The temporary policy is changed. When there will be regular, again the policy will be reversed. So we can actually give the tablets on the tele consultation. Then paracervical block, not GA. And clinical clinicians approach should be very, very proper. The detailed history on phone, video, and rule out topic, and etc. And if she is COVID, testing should be done. If she has got the fever and other things, then you have to follow the protocol completely. And these are the on the visit, one should be taking all the precaution. And if she is visiting, then you have to take consent in the form C as per the MTP Act. You cannot say that now she was teleconsulting because she's physically coming to you. Please take the consent in the form C. These are the visits. Before starting the procedure, you must do the corona test, and corona sampling has to be done if the patient is visiting. And post-abortion care in ERA, contraceptions, follow-up, ANM, all should be done. Contraceptions in corona pandemic, as I have said, there are 28% less supply. So now it has to be restored. Otherwise, we will have many, cases of unintended pregnancy. Now, the last component of my few slides. Now, the very reputed NGOs like FPI, IPAS, other who are into the thick of the abortion services, they are sharing the experience in the Southeast Asia, that is use of telemedicine. Though by their registered medical practitioner, they are using the telemedicine. Then the medicine is done by the video consultation, mobile phones, social media. They are putting their information on the social media, sharing where the services are available, doctor's name, everybody's name, so that women are, finding it quite easy to access, and hotline numbers are there. And the quality of services are maintained by the telemedicine service provider because they are trained people, and the training is a continuous part of their protocols. Then records has to be taken properly, maintaining the history, new and registered clients. And telemedicine aspects of the comprehensive abortion care, India, only registered medical practitioner can do it. Now, very important point here I want to say that medically advisory panel has approved the administration of misoprostol at the home, which is very important for all of us, all the practitioner, and there is nothing illegal if you prescribe and follow the patient. And standard operating procedure to support the provisions of CAC services through telemedicine. So clear written instruction has to be given by the SMS or the WhatsApp. And challenges are very important because so many times LMP is not known. So you have to provide the ultrasound services also. So quality of care, confidentiality, because in our forms when we fill, the confidential is all the time maintained. So here also you are supposed to maintain the confidentiality. Data collection is basically done by the CMIS. and telecounseling, teleconsultation, telefollow-up, and COVID telescreening are the methods of abortion care in the COVID times. And last slide, very important, some MTP activists, because MTP beyond 20 weeks in JJ and Kama Hospital, we are getting many patients who are, pregnancies after rape, assaulted, sexual assault, and the continue of the pregnancy. And with this court order, it is said that there is a medical board. The medical board is active in all the formed in all the medical colleges, and this medical board cannot refuse any kind of pregnancies which are given the orders by the court. So this is a one last but very important slide, the MTP beyond 20 weeks. So in conclusion, I'd like to say that women's health is a top priority for providing safe abortion services in challenging times, and very important, crucial for us as a OBGYN. As per RCOG guidelines, GOI, early abortion services are key to the success. So you have to find out that as soon as possible, you must try to give the early abortion services. So we can do the teleconsultation as a telemedicine, teleconsultation, and telecounseling. They are the mode of treatments are approved by the government and all the agencies. Minimum risk to the patient and staff exposure is less. Post-abortion contraception service play a very crucial role in further management of the abortion services to the women. So no woman can call herself free who does not control her body. Abortion is the health care, and abortion is a right of the woman. So thank you very much for your patient listening.
Thank you, Dr. Mandakini. The message is quite clear that till 9 weeks, we can give telemedicine referral, telemedicine advice to all couples, and they can undergo abortions, medical abortions. However, there are quite a few complicated situations like heart disease or hypertension or other disorders complicating pregnancy. One must be aware of these things. Secondly, the need of contraception cannot be emphasized more, particularly when we hear that this COVID period is going to produce more and more babies which are unwanted. So your message is very clear, and thank you very much for the.
And I want to say my thanks to Dr. Sharda Jain, madam. Thank you. And I tried to give my message very clear as my respected chairperson is saying. And thank you for everyone for this great opportunity for me to speak on this very, very important topic. Thanks a lot.
One comment on my mentor and teacher, Dr. Sharda Jain, she would have liked me to say. And madam, as usual, you were fantastic and wonderful and crisp. And thank you very much for your message. Dr. Mandakini immediately has been on defensive, which he should not have. It's okay. Once in a while, you do have.
This is a humor in presentation.
Yeah.
Sharda madam has said, so I follow Sharda madam's humor. So thank you very much. Yeah.
Ragini, Dr. Neera, please let us know she's ready or not. Dr. Neera, please take over.
I'm ready. I'm ready, Dr. Anjali.
I've already introduced her before. She's very well known to all of us, and she's the vice president of FOXI in 2020. She has a lot of contribution towards the FOXI as well as our federation, because she was the founder president of Haryana Obstetrics and Gynecology. She has been she has started Obstetric Gynecology Society in Gurgaon. Her main interest has been the aesthetic and the reconstructive surgery, and therefore she is also the president-elect of that society. And she will be speaking on a very different topic today, and that is the women's intimacy. Let's talk about it. Dr. Ragini Agrawal, please.
Thank you, madam. Thank you, madam, for your kind words. And I'm extremely sorry for the glitches. It's my really proud privilege to speak in front of Sharda madam, who is my mentor and inspiration, and she has a big force behind my entry in the cosmetic field. And thank you, Mala, for giving me this opportunity to speak a topic which is very close to my heart. And congratulations for this wonderful.
You are muted, madam.
So when we talk about this particular topic, women's intimate health,
मत करो फोन.
So the most automatic thing about us is our capacity to create, to overcome, to endure, to transform, to love, and to be greater than our suffering. So many women do not talk about their health problems or disclose them to a health professional, often because they have not heard of anyone else suffering from similar problem, because nobody talks about it. So as if puberty and childbirth not enough for the all problems, vagina and vulval area are in for many more changes as women get older, especially after menopause strikes. Sadly, these changes are not of discussed topic, meaning most of women typically uninformed and woefully unprepared for the realities of the aging. So from puberty to menopause, women had many issues which we cannot discuss, only suffer silently. So what are the issues of the intimate health which we are going to discuss? It will start very much from the menstruation, which is a taboo to discuss, dysmenorrhea, vaginal infections, vulval itching and disorder, gender discrimination, sexual violence, sexual dysfunction, labial hypertrophy, vaginal laxity, incontinence, and GSM. And many women struggle in silence, not even knowing that they have treatment for it. So for why she suffers? It is a taboo to talk about these problems, embarrassment, ignorance, or no one will bother about my treatment. There is a vicious cycle. There's a constant struggle with symptom, the battle for an accurate diagnosis, delays in referral and poor support, leading to avoiding social events and managing negative impacts on work, and hiding symptoms for fear of negative judgment, again leading to a struggle. And this will go on and go on. So coming to the first thing, menstruation, we know that from ancient ages, the menstruation, please move your slide. Ancient time, your next slide, it related to the magic, sorcery, and even today in India, it is a taboo. Yes, people are coming out of box and talking about the menstrual hygiene and everything, but more or less situation is that. Next slide, please. Next slide, please. So coming to the dysmenorrhea. Dysmenorrhea is something, next slide, next slide, next slide, next slide. So dysmenorrhea, women suffer from menarche to even menopause, and most common cause is the endometriosis. Next slide. We know that dysmenorrhea is primary dysmenorrhea and secondary dysmenorrhea unless we take a history examination and investigate and properly treat it, women will suffer. Many times, nobody will listen. Coming to endometriosis, it is a very, very common complaint. So many women are unhappy. They lose work time, they lose productivity, they lose their jobs because of this disease. So it is our duty to putting end to this treatment. Coming to the vaginal infection, we all know that vaginal infection is somewhere it become a recurrent and patient has a nuisance in her life and not get a proper treatment for this. And this busy slide is specifically, I want to show you that when a patient of the vulval itching and disorder comes to you, she might be suffering from so many problems. Next slide. I will not read this slide. This slide is only to show the vulvitis, vulval itching. Patient can have anything, not only a cream of the for the itching is sufficient. So whenever the patient come with the vulval itching, we have to go beyond that. Gender discrimination, I will take only one thing is the chronic pain, abdominal pain. Women suffer more than men, and all thing is related, and all treatment is related to the main more. Coming to the sexual violence, rape is not only that one thing. She is molested, she is harassed daily, and there's a lots of effect on her. Victims of the sexual harassment often experience emotional and physical symptoms for years to come. Then, next slide, there's a sexual dysfunction. Nobody talk about the female dysfunction. She does not talk about the female dysfunction. 40% of the women struggle with dysfunction, and it actually affects the lives of 30 to 50%. And there's a multifactorial aspect for this female sexual disorder, and contrary to what contemporary social trends regarding sexuality would lead us to believe, women's sex goes way beyond simple physical stimulation. And despite a decade-long fight for feminism, whose goal was the general emancipation of the woman, it seems that not all women succeed in finding fulfillment on the sexual level. Next slide, please. Coming to the labial hypertrophy. Yes, it is not a Barbie doll making. It is not something only for the beautification. Yes, with the labial hypertrophy, also these girls or these women, they suffer. With very big labia, it causes chafing, it causes pain during cycling, during exercise, during tight jeans, and they suffer unnecessary considering it is only a cosmetic procedure or there is no answer to this labial atrophy. Next slide, please. Vaginal laxity. Yes, we should talk about it because since ages woman is suffering, the most common cause is a childbirth. We all know that the vaginal walls, much like the rest of the body's skin and fibrous material and collagen, that gives its flexibility and strength. And a woman goes to the vaginal delivery stress of the childbirth, and this overstressed vagina leads to a vaginal laxity. Next slide. And it is not only the childbirth, there's other reason also which causes vaginal laxity. And it is an issue for women who struggle with the decrease in the sexual satisfaction due to lack of the friction during intercourse. And many times the partner is not satisfied and woman lands with a low self-esteem and lots of the marital problem. Next slide, please. Now the two things I want to focus little bit in detail. One is the urinary incontinence. Next slide, please. Almost 1 in 4 women over 18 experiences the episode of the leaking urine, and over 23% of the women over 60 have a deal with the urinary incontinence. The market of the diaper increasing like anything. Next slide, please. We all know the major causes. The one is the childbirth and another is a menopause and aging, which is an eternal truth in the woman's life. And next slide. So we all know about the continence mechanism, how the incontinence occurs. Next slide. So it is very necessary to find out with the evaluation of the disease, the type of incontinence, and give a proper treatment to whether woman is having stress incontinence, urge incontinence, overflow incontinence. Next slide. So when we coming to the management, there might be a non-surgical or surgical. Before jumping to the surgical treatment, we have to go for the non-surgical treatment like lifestyle management. Pelvic floor muscle training is very, very important. There are devices, bladder drill, biofeed mechanism, and today we have a energy-based devices which are of a great help to these women. Yes, finally we have all surgical thing in our kitty to go ahead with the Calpo suspension, sling procedure, anterior Calpo patient is suffering from the stress incontinence. Even the neuromodulation is something very good for the urgent incontinence. So if so many women are dealing with incontinence, why have you never heard women talk about it? To talk about it, even their friends, their physician or the family. Next slide. Bladder leakage or urinary leakage is common. If you struggle with bladder leakage, you are not alone. So don't shy, ask why. Next slide. Coming to the next thing, that is the GSM, genitourinary syndrome of the menopause. So it is nothing. It is the old wine in a new bottle. All three problems of the menopause, genital symptoms, sexual symptoms, and the next slide, please. Is slide. So, am I audible? Hello.
Yes, ma'am, you're audible, but
Hello?
signal is going
Yes.
in between.
So
You're audible,
we have
but signal is going in between.
health as women ages, and we have to talk to them, and so they can voice their concern. And mostly women think this is a part of aging, so they don't talk about, don't let it go, let it get worse, because all this is treatable, very much treatable. Next slide. We all know that menopause is an eternal truth, and there's a lots of changes in the hair, changes in the vulva, changes in the vagina. Next slide. And not only this, the chances of the infection is increases because of the decrease in the urovaginal epithelium, which is because of the estrogen it lacks. There's a flora become more of the pathological variety. Next slide. So what happened? That this is a underdiagnosed, undertreated condition. Basically, they believe it is just a natural part of aging, uncomfortable talking about it, unaware there is a treatment of the syndrome, time constraint, and they think the healthcare provider will not ready to talk about it. Next slide, please. So we all know that the vaginal discomfort has the negative effect on the sexual function. Among women with vulvovaginal symptom, 40% has reported overall sexual dysfunction. Next slide, please. So management of GSM must ideally be tailored to the individual patient, medical history, potential risk, benefit of the exogenously administered estrogen therapy, and the patient lifestyle. We all know that the estrogen is the most effective therapy for the moderate or the severe condition. Next slide, please. Other they are available. There's a laser therapy which is coming in a new way, which increase the elasticity, vascularity, and the epithelial proliferation. Pelvic floor therapy. I will say, next slide, please. It is a very, very important thing when we talk about the pelvic floor therapy for any type of the pelvic floor dysfunction, and it gives a very much difference, especially in the SUI, even in the GSM also. So consider changing the regular medication also in these women, and if possible, send these women to the sexual therapist. Next slide, please. So 2 slides about the treatment using the energy-based devices. Next slide, please. It is a widely used or fractional microablative carbon dioxide laser, non-ablative photothermal erbium laser, or radio frequency based energy devices. What they do, next slide, they are all heating the connective tissue from the 40 degree to 42 degree centigrade, leads to the collagen contraction, neocollagenesis, vascularization, and the growth factor infiltration that ultimately revitalizes the and restore the elasticity and the moisture of the vaginal mucosa. And proposed mechanic is the activation of the heat shock protein and tissue growth factors to stimulate new collagen synthesis and the epithelial remodeling. Next slide, please. So this laser therapy is even important when the patient has a post-cancer treated GSM. So patient doesn't want to take in the hormone sensitive cases any estrogen. Here it is very important that we can offer this laser therapy to these women. Next slide, please, and click it for 3 times. So what happened when we do the collagen remodeling? Click it, please click it, and again click it. So new collagen forms. Next slide, please. So coming to conclusion, especially this laser therapy is a coffee time procedure. Patient come, done it and go out. There's no downtime, no pain. 3 passes is required with 1 month interval, and there's a memory session after 1 years to 1.5 years according to the patient need and treatment. So to conclude, women intimate health from menarche to menopause is directly proportional to their quality of life and self-esteem. It is a duty of as a primary physician of the woman to see about these things. We should think, only then we can change, and should be out of the closet, and they should be empowered to voice their concern. Healthcare providers should ask the direct question. Only the talking can make a major difference. Next slide, please. You were born with the wings. Why prefer to crawl through life? With this, I thank you all for my patient hearing, and I'm very sorry for in between the interruption. thank you, Mala, for giving me this opportunity to speak on this topic. Thank you so much.
Thank you very much, Dr. Ragini, for such a wonderful presentation and highlighting how important it is to ask the questions from the patient, because sometimes they are not very comfortable in talking about their problems. And if we find out, we can give the treatment, and also highlighting the importance of laser treatment. I thank you again for your presentation, as well as telling us many important things. Thank you very much.
Madam, thank you so much.
Thank
I'm honored
persons,
by your
the
presence.
speakers who have conducted this session so well. We move on to the second session of the day. The second session is Foxy Oration. To chair this Foxy Oration session, I invite the chairpersons. Dr. Harsha Khullar, Madam is the Vice Chairperson, Institute of Obs and Gynae, Sir Gangaram Hospital, and she has been advisor to AOGD and Scientific Committee of this conference. It's my pleasure to invite Dr. Shalini Rajaram. Madam is Professor, Division of Gynae Oncology, All India Institute of Medical Sciences, Rishikesh. She is Director Professor, Obs and Gynae, UCMS and GTB Hospital. Madam has been President of AOGD and AGOI. It's my pleasure also to invite Dr. Ashok Kumar. Sir is Director Professor, Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences and Research and RML Hospital. I invite Dr. Renu Arora. Madam is the Professor and Consultant, ex-Head VMMC and Safdarjung Hospital. Over to you.
Good afternoon, everyone, my seniors, my colleagues, and dear delegates. In this afternoon, we have oration from the Foxy President, and I invite Dr. Alpesh Gandhi. He is the President Foxy. He was Vice President Foxy and Governing Council of ICOG and Foxy also. He's from Ahmedabad. He was President and Secretary of Ahmedabad Society also. He is a great motivator, great leader, and he has keen interest in establishing HDUs and emergency obstetric care in India, in the country. And he is involved in many social activities as a Foxy President, and has a very keen interest in the academics. He's promoting PG activities also. And he is a very dynamic person, Foxy President now. And I invite him. He will be delivering his oration on the topic of women's health crisis during COVID-19 pandemic. So I invite Dr. Alpesh Gandhi, sir. Thank you.
Thank you very much, Dr. Ashok Kumar, for the kind words, kind introduction. My friend, Vice President Foxy, Dr. Ragini, ICOG Chairperson, Dr. Mandakini Megh Madam, Dr. Mala Srivatsav, President AOGD, Dr. Kamal Bakshi Madam, Dr. Sarda Jain Madam, incoming Vice President Dr. Archana Verma, respected chairpersons, Dr. Ashok, Dr. Salini, Dr. Renuji, and AOGD office bearers, Dr. Mamta, Dr. Kanika, esteemed faculties, and dear friends. A very good afternoon to all of you. First of all, I would like to congratulate all the members of AOGD for the good work for continuing essential health services during this difficult time of COVID-19. I salute all of you. You all are Corona warriors, because 70% of the COVID infected women are asymptomatic. We do not know when and how we will come across them. So I consider all of you a great Corona warriors, and I salute you all. I congratulate AOGD, Team AOGD, for continuing this academic work in this difficult time, in this unprecedented time, in this uncertain time of the biggest health challenge, COVID-19, and regularly updating knowledge and skill of our members. I am thankful to Dr. Malaji and all the office bearers of AOGD for this honor, for awarding me this oration, inviting me to speak on a topic which is very relevant to the more present time and present situation. Routinely, usually I am speaking on a topic which is practical or very clinical or management oriented. But this time I selected this topic. I hope you also will like this topic, because we also should know what is going on in the world, and we should also update ourselves with the data and surveys and studies regarding this COVID-19. So I am trying to speak on a topic, something new, which usually I am not speaking. A women's health crisis in COVID-19 pandemic. January 30th of January 2020, the coronavirus disease was declared as a public health emergency of international concern. And on 11th March, it was declared pandemic. The biggest impact, no doubt, will be a need to reassess priorities in health and how we assess and deliver healthcare. It is believed that males are more infected than female with coronavirus. And these are the data. Total cases till 31st October in the world. 4.5 crore people are already infected. And in India, we have more than 80 lakhs. Out of these, 1,21,000 people already died. As here we can see the ratio across the world. This data provided by WHO, 113 countries has provided this data till 18th of the April. And as per this study, as per this data, male-female ratio was 1.03 to 1.
Dr. Alpesh, we can't see your slides.
Okay.
Can others see the slides?
1 minute, please. Okay. Can you see now?
Yes, thank you.
Okay, sorry.
Can you make it full screen, Dr. Alpesh?
Yes, I'm making.
Yes, thank you.
So as per the WHO, 18th April, male-female ratio across the world is 1.03 to 1. And the important thing is the ratio is conversely the lowest sex ratio in male and female between 20 to 29 years. And here females are more infected than males, 0.85 versus 1. So these all are the young women. So this is really alarming ratio and alarming figure. It is routinely said males are infected more, but between 20 to 29 years and above 80 years, the data suggests that females are affected more. Women's health crisis in COVID-19 pandemic happened because of three reasons: because of the direct effect of COVID-19 on women's health, because of the fear of getting COVID-19 infection, they are not reaching to the open health facilities, and because of the measures taken to combat COVID-19 pandemic like lockdown. The world had experienced that during Ebola and Zika virus outbreak, women did not have autonomy over their sexual and reproductive lives, which was compounded by their inadequate access to healthcare and insufficient financial resources to travel to hospitals. And because of this, an estimated 3,600 maternal, neonatal, and stillbirth deaths have been reported during this Ebola virus outbreak, which was equal to the number of deaths directly caused by the Ebola virus. Women's healthcare affected during this COVID-19 in different care like maternity care, contraceptive care, abortion care, gynec surgeries, including laparoscopy, oncogynec care, mental health, and domestic violence. In maternity care, it has been observed that mortality rate increase, ICU admission increase, there are more preterm deliveries, more stillbirths, more incidents of cesarean section, there are few cases of vertical transmission, and so many other things. We'll go one by one. First, COVID-19 related maternal deaths from December 2019 to July 1st, 2020. The total number of reported maternal deaths was in a study was published in Obstetric and Gynecological Journal, in which 6 countries were considered, 3 high-income countries and 3 middle-income countries. High-income countries were France, UK, and US, and middle-income countries were Brazil, Iran, and Mexico. And in these 6 countries, total reported maternal deaths was 160. 22 maternal deaths were documented in high-income countries, means France, UK, and US, whereas 138 in middle-income countries, Brazil, Iran, and Mexico. It is assumed that worldwide figures of maternal deaths due to COVID-19 are even higher, as it did not identify published cases from low-income countries and many other countries. These are the data of only 6 countries. So the number of deaths overall and COVID-19 in the obstetric population is still rising in some of the countries. And as it is rising, of course, the maternal deaths incidence is also rising. Coming to the intensive care requirement, admission in ICU, and of course, maternal mortality related to it. Hantoz Zahed has studied 7 cases of Iran. Out of these, 5 had no underlying health issues, which suggests that pregnancy could put women at higher risk of consequences from COVID-19. They also obtained familial cohort data in all 9 cases, and in each instant, maternal outcomes were more severe compared with the outcomes of their other family members. Another study published, and as per the Brazilian Ministry of Health, as on May 7, 2020, 20 COVID-19 related maternal deaths were reported, and out of these, 16 during the postpartum period, 3 in the first half of pregnancy, and 1 at 22 weeks. But important thing is there were 9 pregnant women with no risk factor and 9 were having only 1 comorbidity. There are many unreported maternal deaths because of home delivery due to fear of getting COVID-19. Women are not reaching to hospital. Refusal of admission to a pregnant woman with labor pain, because during lockdown and after then also some of the private setups and institutes were closed. And during shifting from one hospital to another hospital because of COVID and non-COVID designation, confusion between these 2 designation, and not available beds in some of the hospitals. And because of these, Some patients even may die on the road. So there are so many other reasons and so many other unreported maternal deaths. 8 pregnant women out of 700 total pregnant women with COVID-19 died at Nair Hospital, Mumbai, together with their fetuses. 7 of the women were in the 3rd trimester and they reached to the hospital very late and went into acute respiratory distress while undergoing treatment. As per the FOXIS National Registry, as per the interim data, till the end of August, 10 mothers died out of 989. It's sorry, here it is mentioned 971, but it is 989 out of 989 COVID-19 positive pregnant women reported to FOXIS National Registry in the month of August. Till the month of August, 10 mothers died. Coming to the intensive care requirement, initial reports from United States are consistent with those from China. 8% of pregnant or postpartum women with COVID-19 have severe disease and approximately 1% are critically ill. As per the analysis of 8,207 cases by Centers for Disease Control and Prevention, it has reported a higher risk of ICU admission and mechanical ventilation requirement compared to non-pregnant women. As per the Al-Zafi et al. Study, they highlighted that 17 out of 385 positive pregnant women required intensive care requirement treatment, means 4.41% require ICU admission. These are the mothers with COVID-19 may likely need intensive care when mother's age is more than 45 years, when there is obesity, when they have history of severe anemia, when they have comorbidities, when they have uncontrolled high-grade fever with high CRP, or tachypnea more than 30 per minute, or hypoxia when SpO2 is less than 93%, when imaging showing more than 50% of lung involvement, when NL ratio is more than 3.13, when age is more than 45 years, and when there is increased IL-6, increased D-dimer, increased serum ferritin. These are the mothers may require ICU admission, or in future they may become critically ill and they may require intensive care. So these are the mothers we should be watchful. We should try to identify the risk factor, whether she is having anemia or not, whether she is obese or not, or whether she is having the comorbidities or not. So identifying risk factor is again one important thing. 86% of the deaths in New York State in the ongoing COVID-19 global pandemic have occurred in people with comorbid non-communicable diseases, may it be diabetes or hypertension or obesity or cardiovascular disease or maybe COPD, asthma. UNICEF has estimated that the forecast birth in the 9-month span dating from when COVID-19 was declared a pandemic, the countries with the highest numbers of forecast births, India was the first among them, and it is forecasted that 20.1 million births will be there during these 9 months. There is a big unmet need of family planning services and abortion services in India and many parts of the world, mainly in the SAFOC countries and Asia Pacific region. And a study article was published of the effect of family planning and abortion services in Asia Pacific, 14 countries of Asia Pacific region. And it was mentioned that there will be 20 to 50% further decline in the use of family planning and abortion services. If we consider the best case scenario as per the 20% decline, then there will be 25,493 additional maternal deaths will occur during this year. In worst case scenario, if there is a 50% decline in the use of family planning and abortion services, then it will lead to 68,422 maternal deaths, extra maternal deaths. Situational analysis of 670 private pediatric and obstetric facilities in providing services during COVID-19 pandemic in Gujarat was conducted by FOXI, IAP and UNICEF. This was a study conducted in small private hospitals, and it was found that 57.8% has continued immunization as per the routine schedule, whereas 17.7% has suspended the vaccination services and 4.4% were providing services only at fixed time. So nearly 21 to 22% patients' mothers' vaccination services was affected. Similarly, if you look at the incidence of cesarean section, then the initial reports of pregnancy outcomes from Wuhan city, they reported 93% of women underwent cesarean section. A recent systemic review from Bologna, Italy, found that 90.2% women underwent cesarean section. A systemic review including 538 pregnant COVID-19 patients reported that 20% delivered before 37 weeks and cesarean section rate was 85%. In a prospective cohort study of 427 pregnant women in UK, 27% delivered preterm and 59% delivered by cesarean section. And in a prospective cohort of 241 pregnant women hospitalized with confirmed COVID-19 in New York City, the singleton preterm birth rate was 15% and 52% of the cesarean section rate with severe infection, severe disease, and 92% with critical disease. So if we look at the incidence of cesarean section across the world, it is somewhere between 56 to 93%, and the incidence of preterm delivery is across world. In most of the studies, it is more than 20%. Several studies have published, and it has shown that the incidence of stillbirth is also increasing. In a prospective cohort, in the UK, stillbirth rate among infected women was almost 3 times the national rate, 11.5 versus 4.1 per 1,000 total births. Although these results are negatively skewed because severely ill women often delivered. Over 95% of the newborns have been in good condition at birth, and neonatal complications have largely been related to preterm birth and to adverse uterine environment resulting from critical maternal disease. In one of the studies published in JAMA, stillbirths have been higher during the pandemic period than prior period, and the comparison was 9.31 per 1,000 births during pandemic period and 2.38 per 1,000 births prior to pandemic period. An increase in stillbirth during the pandemic was noted in large British hospital London, but surprisingly none occurred among women with documented COVID-19. Investigators assess rates of stillbirth and preterm delivery among 1,681 births during the 4 months immediately before February 1st during pre-pandemic period, and they compared with 1,718 births from February 1st to June 14 during the pandemic period, and they found that stillbirth rates were 1.2 versus 7%. So again, there is a significantly increase in stillbirth. And again, in this study, all women with stillbirth were asymptomatic, and none of the stillbirth occurred in women with COVID-19. Several reasons for the large difference in stillbirth incidence are given, but the one of the most likely reason they may include maybe because of a fewer prenatal visits, because of fear and because of hesitance to visit healthcare facilities. They all must be having a fear of getting COVID-19 and or those facilities are closed. So less prenatal visits may be the responsible factor so that the fetuses who are at stress could not be identified, like severe oligohydramnios or many other such conditions were not identified, and ultimately they turn into stillbirth. The likelihood of newborn acquiring SARS-CoV-2 from infected mothers has raised concern among families and clinicians worldwide. Systematic reviews and meta-analysis until 23rd May 2020, where 17 studies were included, and 9 of 330 newborns tested positive. The average pooled incidence of vertical transmission was 16 per 1,000 newborns. The current evidence shows that the risk of vertical transmission is low. In a systematic review of infants born to 936 COVID-19 infected mothers. Neonatal viral RNA testing was positive in 27 in 30 neonates, and in study of Nair Hospital, more than 40 babies out of 700 deliveries. At Nair Hospital, Mumbai, fewer than 10% of total also tested positive for the virus a few days after they were born, but they don't know whether it was transmitted in utero or from contact with their mothers after the birth. Most neonatal infections are thought to result from respiratory droplets when neonates are exposed after delivery to mothers or the caregivers who are infected with COVID-19. Abortion and family planning, as we have discussed already, that there's a great big unmet need, and COVID-19 pandemic added fuel on it. As per the pandemic spread, many countries implemented tough lockdowns and travel restriction in a bid to slow the transmission. In India, lockdown was introduced on 24th March. Many private clinics had shut down because of transport restrictions, provider unavailability of staff, less number of patients, lack of PPE kits, and there was a disruption in supply chain of drugs for medical abortions. UNFPA predicts there could be up to 7 million unintended pregnancies worldwide. The Foundation of Reproductive Health Services India estimated 2.3 million unintended pregnancies and over 8 lakhs unsafe abortions in India. IPAS has estimated 1.85 million abortions is likely to be compromised. And because of all this, there will be 5 implications. Now, there will be increase in the incidence of surgical abortion in place of medical abortion. There will be increase in the second trimester abortion. There will be increase in illegal abortion. There will be increase in unsafe abortions. And there will be increase in continuation of unintended, unwanted pregnancies. And this situation adds additional responsibility on the health system to offer safe and remedial options to these women. The disruption in global supply chains for contraception could result in more sexually transmitted infections, including HIV. The risk of sexually transmitted infections, in particularly HIV, going in the wrong direction, and it could be catastrophic. We were doing okay. We still needed to accelerate our progress, but now here you have a situation where we could actually go backward. It's unacceptable. Several countries, different countries have taken several actions. In Australia, telehealth consultations for early medical abortions have increased by 25%. In Ethiopia, they have approved a pilot scheme for nurses to provide medical abortion in homes. In Nepal, changes in national guidelines stipulate that medical abortions can be delivered outside the healthcare facilities. And in India, government has issued telemedicine guidelines that do not rule out medical abortion. If everything is okay, one can prescribe it. And FOXI was very active. FOXI is very active, proactively working, and FOXI has foreseen all these conditions in very early stage. So in our country, lockdown was introduced on 24th March. Within 3 days, FOXI has published a short-term advisory on 27th March, and FOXI has guided our members to continue an essential services, time-sensitive services of health, sexual and reproductive health. Afterwards, Government of India published similar advisory on 13th April to continue an essential service of sexual and reproductive health. I'm happy to share that FOXI was the first among all SAFOC countries and Asia Pacific countries to publish such advisory. In March, WHO issued guidance which advised to prioritize services related to reproductive health. We were working in this direction very proactively from the second week of March. So immediately within 3-4 days, we have published this advisory. Not only that, on 29th March, we have our first version of GCPR. And again, it was the first among the all SAFOC countries and in India also. We also started our national registry of COVID pregnancy with COVID-19, and we were the first to start such registry in India. So FOXI has taken actions very proactively and comprehensively. Healthcare is becoming a part of in-person technology. We advocate and promote use of telemedicine. We can provide many services with telemedicine like health education, counseling, prescribing drugs for medical abortions, follow-up after delivery, abortion and surgery, prescribing medicines which are allowed on telemedicine. So many things can be done, and we can reduce the visits of patients to hospitals. There is a consensus among all national, international surgical societies that all elective surgeries to be avoided. Only emergency, life-threatening and selected semi-emergency cases should be posted for surgery in order to utilize the staff and resources in a more efficient way. This also protects patient and frontline healthcare provider to unnecessary viral exposure. And whenever possible, a non-operative management should be considered. Now, alternative management and other route of surgery can also be considered whenever it is possible. Laparoscopy nowadays remains the preferred surgical approach for most of the surgical indications, but the risk of transmission is usually increased with aerosol generating procedures like laryngoscopy, bronchoscopy, endoscopy. There is theoretical possibility of generation of aerosol containing with COVID-19 from leaked carbon dioxide and smoke generation after energy device use. European Society and Indian Association of Gynec Endoscopy in India have advised for RT-PCR test in every patient before surgery. Most OT have positive pressure ventilation, which makes the spread of aerosol faster. Now it is advised for port site incision should be made, just allow the port to pass to prevent leak. Insufficient pressure for carbon dioxide should be kept to minimum. All surgical societies across the world, including IAG India, agree that there should be a minimum use of energy devices whenever possible. Because of all this leads to postponing of gynec surgeries and changing of the preferred route of surgeries. And so women continue to suffering from problems for a longer time. While dealing with the crisis of COVID-19, we cannot ignore patients with gynecological emergencies who experience serious consequences like tubal pregnancy, torsion of the ovarian, spontaneous rupture of ovarian cyst, trophoblastic tumor rupture, and at the same time, the possibility that they might be infected with SARS-CoV-2 cannot be excluded, but we have to provide services for all gynecological emergencies. The sad part is gender-based violence. There is a skyrocketing of gender-based violence during the pandemic. It is a pandemic within a pandemic. There is also growing anxiety about the dramatic surge in the cases of violence against girls and women. In Colombia, they have reported during this lockdown, it was increased by 175%. Gender-based violence has distinguished the pandemic because of the restrict of contact, restrict of movement, and people being trapped in abusive situations. Before the pandemic, it was estimated 1 in 3 women experiences violence during their lifetime. Many of these women are now trapped in homes with their abusers. Violence against women is increasing as it combines with economic and social stresses. Crowded homes, substance abuse, limited access to services, and reduced peer support are exacerbating these conditions. In some countries, they reported the incidents have doubled. While it is too early for comprehensive data, but it has across the world, minimum 20% increase has been reported in many countries. A survey conducted in New South Wales, Australia revealed that 40% of the frontline workers have reported increased requests for help by survivor of gender-based violence during outbreak. Domestic violence shelters are deemed essential services and must remain open 24 hours during this pandemic. Again, a serious concern is about maternal health crisis. Physical distancing and stay at home have had larger implications for women in every sphere of their lives. There has been an exponential increase in unpaid work with school closures, burden of increased household responsibility, and burden of heightened care needs for the family members. A single parent is facing significant difficulty in supporting themselves. There is increase in the vulnerability to domestic violence and partner abuse. Economic stress during the outbreak expose them to increased risk of exploitation, violence, and abuse. And there is threatened complications if they report and if they are going to seek help. There is diminished community support because of the social distance and lockdown and transport restrictions. There is disconnection from social networks and inability to seek temporary refuge outside. Women are experiencing chronic distress and experiencing various mental health concerns, including depression, anxiety, and trauma. Symptoms: they may have negative self-perception, may have persistent low erratic mood, inability to experience pleasure. They may have difficulty with attention, memory, changes in appetite and sleep. They may have fatigue, bodily pain, and thought of self-harm. And these all are reported in different parts of the world. We need a strong and impactful strategies. There is a need to increase awareness and advocacy campaigns for mental health during this COVID-19. There is a need for helpline number working for 24 hours. There is a need for designate domestic violence shelters as essential services and designate safe spaces to report abuse, like example, grocery stores, pharmacies, which are easily available and reachable. And there is a requirement for the online services and create social network for the survivors. And there is a need for prioritize sexual and reproductive health care services. There is need to provide them psychological counseling, support and treatment, and there is need to provide legal aid to all the survivors. So in conclusion, during the pandemic COVID-19 time, women are affected from different, from maternity health to mental health. COVID-19 may not be harmful than not getting healthcare due to fear of getting it. Consider all pregnant women is infected. Take due precautions, but continue the care. Maternity care is an essential healthcare. Accessibility of quality, respectful and in-time maternity care is a right of every pregnant woman, irrespective of COVID-19 health crisis. COVID-19 is not the indication for cesarean section. It is not the indication for the induction of labor. Prevent the preventable. Preterm delivery, vaccination, stillbirths, unsafe abortions, mental health, all these are the preventable. Prevent the preventable crisis. Antenatal checkup care, delivery, postnatal care may be the only opportunities women have to access contraception, and counseling and LARC are more effective and reduce visits. Self-care family planning methods should be promoted and supplied. We need to anticipate supply chains needs and assure the supply of drugs for medical abortion. Women are avoiding health systems for fear of COVID-19. So the role of midwifery, the role of community health worker, and the role of telemedicine, ability of someone to receive care at their places where they reside is absolutely essential, and policymakers and has to think on it. And telemedicine services can improve access. It removes fear of infection and can ease pressure on struggling health systems. Provide 24 hours helpline number, online support system, designated domestic violence reporting centers, care shelters and legal aid, start psychological support and care centers for women's mental health crisis, enabling delivery of essential and time-sensitive COVID-19 health services, non-COVID-19 health services during COVID-19 outbreak is very, very essential, providing safe and effective care to already affected women. Most importantly, the global infection rate of medical staff has reached a critical level. Healthcare provider must be provided adequate PPE kits, adequate testing, good quality care, and insurance. WHO recognizing the need to include women in decision making for outbreak preparedness and response for COVID-19. This is the time to include them in the decision making. And the unknown is not what to be afraid of. It's only when the unknown becomes known that you can decide whether to be afraid or not. Until then, considering the above discussion, it is wise to use adequate preventive measures. We did not come to fear the future. We came here to shape it. Once the past President Barack Obama, America, has declared this, by failing to prepare, you are preparing to fail. And a big section of society in our country is still unreached and underprivileged, deprived of benefits. It is our moral duty to provide the services and to reach to them. At the end, my tribute to all Corona warriors who lost their lives. Unfortunately, Foxy has lost 10 great Foxy. Dr. Parag Patil from Mumbai, Dr. Ellen Chauhan from Vadodara, Dr. Rajesh Shah from Ahmedabad, Dr. Mindal from Mumbai, Dr. Sanjay Sen from Kolkata, Dr. S.N. Bera from West Bengal, Dr. Mary Bara from Rourkela, Dr. Divya Prakash from Agra, Dr. Shrita from Hubli, and Dr. Ivo from Imphal.
Can Neeti Tiwari please mute herself?
Tribute to those who sacrificed their lives while serving the mankind. We pray for all those who have COVID-19 infection and on treatment at home. And at the end, the last slide, 87,000 healthcare workers are infected with COVID-19. Amnesty International analysis reveals more than 7,000 healthcare workers have already died. Up to 3rd September 2020, 1,320 healthcare workers are confirmed to have died in Mexico alone. Second highest in USA, 1,077, Brazil 634, and in India 573. But as per IMA, and now it is said that it is more than 800 healthcare workers already died in India. So it is, please take care of yourself while serving the mothers, the women suffering from COVID-19, or whether it is a non-COVID also. Please consider all the patients are having COVID-19, and please take care of yourself. Foxy wishes safety to all of you. Let us work together for women's health care during and after COVID-19 pandemic. Thank you very much for giving me this honor, giving me this opportunity to share my views with all of you regarding the women's health crisis during this pandemic period. Thank you. Thanks a lot for the patience.
Thank you, Dr. Alpesh Gandhi. That was certainly a presidential oration. It was very, very well researched, very well delivered. The slides were beautiful, and he covered every aspect of maternal health. He has covered fetal health, maternal health, mental stress. He talked about gynecological complications. He gave us so much of data and information. I think that was a truly presidential delivery of the oration. We thank AOGD, thanks Dr. Alpesh Gandhi, President Foxy, for that wonderful oration. I'm sure everybody sat enthralled, and there was so much of data, so much of information. I didn't even know that LSCS rate was as high as 93% or 94%. And I think, like Dr. Alpesh said, we should not do LSCS just because she's COVID positive. And also towards the end, he mentioned that how all healthcare workers have to take care of themselves, because we are the force that everybody looks to during this pandemic. And I thank Dr. Alpesh once again on behalf of AOGD, on behalf of all our members, for that wonderful oration.
Can I take 1 more minute?
Yes, sir.
I request all of you to please provide data. We have our national registry of COVID-19 with pregnancy with COVID-19, and with the support from all the institutes across India. We have more than 2,300 cases, which may be the we may have the second or third highest registry cases in the registry in the world. So please share the data. It will be helpful to our Indian women. We can come out with some certain data. As I have mentioned, up to 989, there were 10 mortalities in our FOXI registry. Similarly, we have in first 1,060 women require ICU admissions. We have 131 preterm delivery in first 1,000 deliveries. So it was 13%. And in the study, our cesarean section rate is quite less than the world. So we can come out with some very, very good data to the world. So please share your cases with the FOXIS National Registry. Thank you. And one last, sorry, yesterday I could not join. I was the chief guest, but yes, I am a DICOR obstetrician, and I was stuck up with one complications after delivery, so I could not join. Patient is fine, but sorry, I could not join yesterday. Particularly, Dr. Mala has rang me so many times. So Dr. Mala Srivatsav, I'm sorry, I could not join yesterday. Thank you.
Thank you, sir. Can we hand over the proceedings to Dr. Harsha now? Dr. Harsha, can you unmute yourself?
I think citation.
I think, yeah, that's what I was coming to.
Okay, Dr. Renu is going to present the citation. Sorry, Dr. Renu. Yes.
Thank you. Thank you. It is my proud privilege to read this citation for our beloved. Can you all hear me?
Echoing. It is echoing a bit.
I'll sit at a distance. And it is my proud privilege to read this citation for our beloved FOXI President 2020, Dr. Alpesh Gandhi. Dr. Alpesh Gandhi has headed the FOXI during the most tumultuous time and has proved that he can brave any storm calmly and yet emerge the winner. During the most difficult period of March and April 2020, when COVID-19 was foxing everyone, he was quick to lead from the front by formulating FOXI GCPR guidelines. And these guidelines were the first one to be released amongst the Southeast Asian countries. These gave a very important direction to the fellow FOXians. He further established the COVID registry, under which more than 2,300 cases have been registered so far. This resource, which is a combined experience of the whole nation, will go a long way in understanding the disease and thereby establishing guidelines and protocols in our fight against the most powerful enemy. He has had the most illustrious career. His commitment to the women's health and saving lives led to his interest in obstetrical critical care. He became the key resource person for preparing guidelines for establishment of obstetrical HDUs and obstetrical ICU for Government of India, and also operational guidelines for the same. He dedicatedly worked on this goal, and today there are about 300 dedicated obstetrical HDU and ICU which have been established in India. This one initiative has been acknowledged to make the positive impact on the maternal mortality of our country. He was also a national coordinator for emergency obstetrical care program of Government of India and FOXI. He has held many other offices of eminence in his State Society of Ahmedabad and also in the FOXI, which include past President Ahmedabad Obstetric Gynecological Society 2007 to 8, past Secretary Ahmedabad Obstetric Gynecological Society 2003 to 4, Vice President FOXI 2013, Governing Council member both for ICUG 2016 to 2017, and a chairperson Practical Obstetric Committee FOXI for 2 years, that is from 2009. Under his able leadership, several Yuva FOXI conferences, satellite conferences, Vice President conferences, and AICOG conference was conducted most successfully. his book on principles of critical care is in obstetric is available in more than 5,000 world-renowned medical college libraries. And this book has been published by some international publisher and is also translated into Chinese as well as into the Spanish language. He has received many awards, and to name a few: Best Society Award, Best RCH Award, Best RCH Activities Award, and the Best Publication Award from FOXI. He has also been honored with several orations and keynote addresses by many gynecological societies across the country and internationally. RCOG also has recognized his contribution and awarded him honorary FRCOG as recognition of his unprecedented passion and zeal for women health. FOXI, under his secure leadership, has seen unprecedented academic activities and initiation of so many activities for the welfare of women of India and fellow FOXians. I congratulate Dr. Alpesh Gandhi for all these activities and all these women-centered activities. We are indeed honored by his presence here and today, and wish that grit and courage, passion and determination he has shown to handle the women health issues of India will amply be rewarded. Now, can I request everyone who can unmute themselves so that we can give him a big round of applause?
Thank you very much. Thank you very much for this honor.
Thank you. It
for
was
the
our
kind
pleasure.
words and appreciation. Thank you.
It was our pleasure, sir.
Dr. Harsha, unmute yourself.
Yes. Dr. Alpesh, it was a wonderful oration, and at a time when you need to know everything about COVID-19. And just appreciation, we would like to present a plaque to you. I think Mr. Sumit, can you please? Dr. Alpesh, please accept this.
Thank you.
Yeah. So after the citation being read out by Dr. Renu and the plaque being delivered virtually to Dr. Alpesh Gandhi, which will be couriered to him soon, the wonderful oration, I think we can call to a close this session. And I think that was definitely a truly presidential oration, very well covered. I think all aspects of COVID-19 were covered, and we are ever so much more knowledgeable today after your oration. Thank you so much, Dr. Alpesh. Does Dr. Mala want to say anything? Mala or anybody else? Or?
Yes, thank you. Thank you, ma'am. And thank you, Dr. Alpesh, sir, for this excellent oration. And thanks to all the esteemed chairpersons of this session. And we move on to the next session now on keynote lectures. And to chair this session, may I invite our esteemed chairpersons, Dr. Chandra Mansukhani. She is the senior consultant obstetrician and gynecologist at Sir Ganga Ram Hospital and also the scientific chairperson of this conference.
Yeah.
Dr. Achla Batra, Madam is professor in Department of Obstetrics and Gynecology at VMMC and Safdarjung Hospital and also President NARCHI, Delhi. Dr. Sanjeevani Khanna, she is director and head in Department of Obstetrics and Gynecology at Fortis Hospital, Shalimar Bagh, and also ex-professor in Department of Obs and Gynae, LHMC and Sucheta Kriplani Hospital. And she's the chairperson, Delhi Gynecologist Forum, North Delhi. Dr. Indu Chawla Chuk, she is professor and head of the department in Department of Obs and Gynae at Atal Bihari Institute of Medical Sciences and RML Hospital, Delhi. Over to the chairpersons now to introduce the speakers. Is Dr. Achla Batra there? Dr. Achla, ma'am?
Good afternoon. Am I audible?
Yes, you are.
Yeah, you are audible.
Good afternoon. I think it was a wonderful oration, and it's my honor and privilege to invite Dr. Alka Kiplani. She doesn't need any introduction. She's the Padam Shri. She was the past president of Foxy, and you can see on the display all her accomplishment. If I start speaking, her time would be less. So, Dr. Alka, I'd like you to present your presentation on very different topic, laparoscopic management of cesarean complication. Dr. Alka.
Thank you very much for your kind words, Dr. Achla. At the outset, I must thank the organizers, especially Dr. Mala Srivastav and team Gangaram for such an excellent execution of this first AOGD virtual annual conference. Am I audible?
Yes, madam, very clear.
Okay. I'm just coming in. Yeah, screen share. Are my slides बड़ा कैसे करूं? Just give me a second. So I bring you greetings from Paras Hospitals, Gurgaon, where I'm presently working. And the topic is endoscopy. Since I'm a laparoscopic, hysteroscopic surgeon, so I thought, let me deal with cesarean and whatever nice cases we have managed post-cesarean complications endoscopically. So it's just I'm going to show some video clips of these cases. We all know cesarean section is very important. We gynecologists are often accused of high cesarean rates, but I won't go
We
into
can't
the
see your
reasons.
PPT, ma'am. Will you enlarge your PPT? We can't see your PPT.
Why you can't see PPT? कैसे close करूं? कहाँ से? Stop share. But I can see my slides. So share screen. Then यहाँ से share करना है. यहाँ से share करना है. अब आ गई?
Yes, ma'am. Thank you.
So what I was discussing, cesarean is a very, very commonly performed surgery, but it led to some, every surgery has its own share of complications, and cesarean is no exception. So some of the complications which are managed endoscopically, we are going to present.
Just click on the PPT once. Just click on the PPT.
Okay. No, perfect. So there are some early complications, some late complications, and thanks to increasing cesarean rate, we witness more and more complications. So a very common complication of cesarean is nowadays patients present with isthmocele. Now I'm not going to go into theory. Everybody knows isthmocele is when there is a pouching at the level of the cesarean scar. So there are so many reasons to it. We get a lot of referrals from colleagues, especially IVF colleagues, that in the presence of isthmocele, since there is collection of the blood and implantation rates go low, and patients present with post-menstrual bleeding and spotting. So how to manage? There are so many ways of managing, but this is the laparoscopic view. Is the video seen properly? May I ask, is the video clear? My God. Hello?
Yes, yes. Yes, ma'am, it's clear.
Okay.
Yeah, it's clear, ma'am.
Thank you. So this is hysteroscopic view of this huge isthmocele. See, there is an outer ring, there is an inner ring. This is probably the secretory phase of the cycle. And you have to assess at what corner it is, what is the size, what is the thickness. And if the patient is keen to conceive specially, we believe in excising that isthmocele area. Otherwise, it is a foundation, it is a ground for cesarean scar ectopic. So you can see the outer ring, inner ring, and this is the laparoscopic view. And this is the MRI showing in contrast, beautiful huge isthmosyle in this patient. You put a hysteroscope and put the light, even if you are doing it open, and you will be able to localize the exact area and extent of defect. So this really helps, and see how much thinning is there. If she had become pregnant next time with this huge thin isthmosyle wall, definitely, see, I'm just cutting the bladder peritoneum and the uterine musculature is open. And this is a something should be put in so that you can map, you can, guide. And this is what the principle of repair: nice dissection of the bladder, nice dissection of upper segment, excise the isthmosyle, and nice 2-layer repair, so that in next pregnancy you are at ease and the pregnancy goes till term. We always keep a marker here. You can see a catheter, otherwise a hulka, over which you suture. And the secret of success is excise isthmosyle and exclude it in your suturing. So this is a complication which more and more, maybe our referral pattern is such, number of cases we are operating, and with laparoscopy, it is very good. This is added adenomyosis and is being taken care. So isthmosyle is a complication which is increasingly being diagnosed, and this is the end result. So excision of isthmosyle in 3-4 months time, patient is ready to conceive, and logically there should be less risk of scar ectopic. Then comes, we have very, very high referral for these cases, and there is large data. So I have learned with my own mistakes over the years, what are the do's and don'ts, and it is not uncommon. It gets what the eyes cannot see, mind doesn't know. That is, so many times these patients suffer so much, nature takes its course, they bleed so much, one cannot really, so good imaging and index of suspicion helps in correct diagnosis. We all know they are of 2 types. If pregnancy goes inwards or if pregnancy goes outwards, management is different. I won't go into all that because I will finish with my time. What are the reasons? What are the options to manage? And this is our way of managing. Laparoscopically, nowadays we have stopped. I think in the last dozens of cases, we have never opened a case. And this is what a case of caesarean scar ectopic. Often you will find lot of adhesions between the anterior abdominal wall and the bladder with the caesarean scar. This is a kind of exophytic type which grows outside, and there is real risk of hemorrhage. The initial days, we used to ligate because literature was so scary that there is torrential hemorrhage, they bleed. Now with improvement in the technique, I don't think we have required blood transfusion in last so many patients. But this is ligating the uterine artery if you fear that your patient is going to bleed, and to be able to operate in the correct plate is the key to success. So these adhesions have to be broken because we have to reach the caesarean section scar sac. So painstakingly one has to dissect in the correct plane. And colleagues, you may do open, you may do laparoscopic. So this is the sac, huge 8 weeks alive caesarean scar ectopic. So you have to dissect the, and this is the en bloc removal. So see, the live baby will come out in a minute, and this is what. So one has to, if exophytic type, suppose it keeps growing, and if it ruptures, there is torrential hemorrhage. If it doesn't, it leads to placenta accreta. So one has to diagnose right on time to decrease the morbidity. And this is the sac. It was just going to be burrowing into the urinary bladder. And bladder dissection is key to success. So you have to nicely dissect. And a very good way is, since we people and all colleagues who are doing oncology, you can go paravesical on both the sides and then have the boundaries of the bladder and see how big is the scar ectopic has occupied, because it was 8 weeks. And now suturing is a bit difficult in this patient because the thinness of the scar and so much of bladder being so near. But if the patient wants to conceive in future, you have to take care and do nice suturing. So in next pregnancy that holds good. So this is what a cesarean scar ectopic, which is a complication of cesarean section, increasing cesareans, increasing scar ectopics, and can very well be managed laparoscopically or hysteroscopically. Hysteroscopy for endogenic and where patient is not keen for future pregnancy, because otherwise this is the many times we do cystoscopy if it is kind of percreta or MRI says that it was into bladder. In all cases it is not necessary, and this is the end result. Patient goes home in a day. Then there are patients who unfortunately develop abscesses in the pelvis and they really suffer a lot. So we have shifted to managing them laparoscopically. It is a very patient-friendly approach. Only thing, you have to nicely pinpoint where is the abscess, and they should not be multiple. So this is what a patient who after 9 days of cesarean had high fever and was referred to us for pelvic abscess and fever. And the MRI said that the collection is in between the bladder and the lower uterine segment. In a minute, you will see pains. Again, you have to be very gentle. Tissues are like so friable in these patients of pus. So you have to reach the correct area and then drain all the pus. And it is not only draining the pus, one has to open all the adherent areas and drain. If there are multiple pockets, painstakingly dissect. One has to be very gentle, because at this time, it's very easy to injure because there is so much of tissue friability and necrosis. So all this pus is drained. Probably this was a hematoma at the cesarean scar site which got infected, and one has to be careful not to injure the bladder in these patients with your blunt dissection. And this is what, with the help of the suction, a huge abscess cavity is reached. All the adhesions are broken and separated. The drain is inserted for 2 days and patient was relieved and with minimal invasive way. So could go home after 2 days. Otherwise, in these patients with a big laparotomy, there is always risk of wound infection and dehiscence. With laparoscopy, the patient has all the advantages of minimal. See the huge pelvic abscess cavity between the bladder and the lower segment, which is being drained nicely, painstakingly, nice lavage. And these are the sutures of the cesarean, and sometimes non-absorbable sutures if they are there, although in cesarean they are not there. So one has to take out foreign body also. So this is a laparoscopic way after cesarean and putting the drain in the abscess cavity. Then this was a very interesting patient who had cesarean somewhere and her fever was not subsiding and she was constantly bleeding, and MRI said a big, defect with tissue. So what we did on laparoscopy, this was the picture. And when we went into detail, sometimes patients do not give history. There was history of bladder injury at the time of cesarean. It's obvious here. You will see, I don't have to do much. Just separate the bladder from this thing and you will see a big defect, scar, dehiscence area, which nowadays good ultrasound and MRI imaging has become so good. Otherwise, good olden days, colleague will take the patient for DNC and everybody will say you have perforated. It is already open scar. So pre-op exact diagnosis and secret of success is dissecting the bladder nicely away, and you will see so much of placenta. Probably once bladder gets injured, we obstetricians, all attention is towards that only, and part of placenta is left behind. Patient is having very dirty discharge, bleeding, high fever, and this is such a minimally invasive way. Remove all the placenta from the open scar and excise the margins, excise the damage, friable, bad tissue, and then repair it nicely. Always put a hulka or a marker so that you don't go wrong. Always dissect the bladder properly, and then it is an easy ball game. So this is what the lower segment is being dissected. Because the patient was a primate, she will have to conceive again, and you have to give her a strong scar. So this is the, again, many times you will see if you give very low incisions, the scar ectopics and this incidence is higher. So this is what, removing all the remaining placental tissue and then correct, nice 2-layer repair of the scar so that you give her a strong scar and the patient gets all the advantages of minimally invasive surgery. You don't have to cut her open. Then there are further very, very nice cases. These are the learning experience. Time to time, I get patients who after cesarean have hematometra. And see the story of this patient. I think I have to finish on time, so I'll hurry up. This was the patient who somebody did a cesarean, and please never blame colleagues. See the fibroids, multiple fibroids pushing. And what happened? Poor obstetrician, when she was suturing at the time of cesarean, the upper flap of the incision line by mistake was sutured to the posterior wall of uterus. So what happened? Patient developed hematometra. And then somebody tried to dilate, somebody put a copper T, but when the copper T is removed, again hematometra. And I thought this time with laparoscopy, complete removal of all the fibroids, and then nice dissection of bladder with hysteroscopy mapping out, and you might have to revise the scar. But in this patient, with the help of hysteroscopy, we could break the adhesions, and in a minute you will see nice drainage, and then putting some stent like catheter for some time, and the patient resumed her periods with hysteroscopic remaining thick septum part. So hysterolapro approach helped in relieving her of this hematometra, and good outcome. This is all myomectomies at the same sitting. So there are so many ways that is beyond the scope. And placenta accreta, dreaded complication. Again, number of times patients come with residual placenta accreta. And this is one such patient I happened to manage. After missed abortion around 18-20 weeks, she had accreta, and somebody gave methotrexate, this, that, and this was her picture when she was referred to me. So this was the lapro view. And in a minute, you will see majority of time, these fibroids may be the culprit for accreta being there. So we did her myomectomy. I think I'll skip this part of the video. So after myomectomy, then we decided that we have to remove all the placenta which is adherent under laparoscopy guidance. So we started doing hysteroscopy, and without using with our loop, but without using cautery, we removed all the accreta. You see, if scopy is not there, I don't know how these cases will be managed, because with repeated curettage, there are bands of adhesions in their uterus. So you cannot go, and the placental part is beyond these bands. See, I'm doing under lab guidance, and my instrument is coming because there is hardly any myometrium left, as placenta is very deeply embedded into the myometrium. So this patient and patients like her who have accreta residual, hysteroscopy under lab guidance, and this transillumination is, I favor it a lot because it tells you how much you have to go in which direction. And this is what repairing the uterus under direct guidance, doing all the myomas removal, and the patient in 3-4 months time is ready to conceive again, but placenta. And this is the hysteroscopic view, the end view showing near normal cavity and all placental tissue which is burrowing into myometrium out. Otherwise, these patients, they really suffer a lot. And this was the all huge placental tissue removed from the myometrium. Then this is a very interesting patient I'll show. This I operated in Paris only. The patient had cesarean, and she was referred to me that after cesarean, her periods have stopped and she has cyclical pain, and her imaging showed that there is collection of blood in the pouch of Douglas. So this was the laparoscopic view when we went inside, and there are so many reasons this patient also had. This was the view. So whenever there are adhesions to anterior abdominal wall, you see this is all collection of her periods. It is pseudoamenorrhea. She is getting periods, but the blood is not coming out. And this is the hysteroscopic view. So I could find a tiny hole posteriorly in the cervix. Then you go back and ask patient, she gave history of an MTP. So at the time of MTP, a perforation went unrecognized. She started having her periods through that perforation. It started getting collected into the posterior peritoneum, and this led to amenorrhea, and she was referred. I don't know if endoscopy is not there, how I will diagnose and how I will manage these patients. So this is our way of managing such patients. And you see, this is all the collection of her menstrual blood, where poor lady is thinking that she is having, and this is the pouching. A nice pseudo sac has become, and it is increasing with every period. So you have to, with your history and laparoscopy, see where is the hole. This is the hole. And then because it is a mature fistula, you have to excise the edges nicely. And after that, nice correct suturing after excising the fistula margins. And this patient resumed her periods from next cycle on, and she was perfectly fine. So many times these complications, they go unnoticed. Nobody thinks of, and it is not rare. You start doing these cases and so much of referral starts coming. So this is what the patient was relieved just with this laparoscopic approach of treating this peritoneal fistula and finding out the hole and excising the hole, and her periods were resumed, and logically she can go for next pregnancy and deliver. So this was a case of uteroperitoneal fistula managed laparoscopically. Now this is what is Yusuf syndrome. Every colleague must have had the occasion. We had huge data at All India Institute, and we used to do open. Then we started doing it laparoscopically. And this is one such patient who was referred to me after cesarean. She started having menorrhagia, that is periods. And this is her MRI. See, fibroids are the culprits at so many times. So this was her laparoscopic view. Huge cervical fibroid. We blame our colleagues that they have made, but you see this fibroid must be pushing it up and distorting the anatomy. So by mistake, she sutured the lower incision with the bladder. And see, this catheter is not, this is into the urinary bladder. So catheterization, cystoscopy, doing your own, we all are so good in canalization of ostia. So you have to look for and then excise. This is, I'm suturing the cervical fibroid bed posteriorly. Now comes the next step, cystoscopy. We have to see where is the fistula. So in cystoscopy, pass the catheter through the bladder, take it out, it comes out above, and this makes your work in cases of fistula very easy, because the negotiating, see, the moment you open, you see your catheter, and catheter is going from the uterus to the bladder. So just dissect the area enough, as much as that it should be, should be able to suture without tension. So this is the hole in the bladder, this is the hole in the uterus, and with just simple laparoscopy, patient goes home in 2 days time, 1 day time, and you can suture. And we, for years, we are suturing bladder with barb sutures. It makes it so easy. 1 minute. Somebody said something. Somebody saying something, please. And this is what at the end. We have stopped even putting graph, because good suturing leads to always a success. So to increase vascularity, one can put the graph. Please let me finish. So
the voice in the
minimally invasive. Hello, am I audible?
Yes.
So these were some of the cases we showed being managed with endoscopically with the complications of cesarean section. Thank you so much for your patient hearing. And I once again would like to thank the organizers, Dr. Mala Srivastav, Team Gangaram, and all my colleagues.
Thank you, Dr. Alka Kiplani.
Oh, thank you, Chairperson. It's an added bonus to my beautiful friend here.
It is so wonderful always to hear your presentations, and what is most significant and how you are class apart is because you see it is all your experience and your good recording, your illustrations, your creative mind and your approach. And above all, you maintain humility throughout this. You think everybody and anybody who is non-Alka Kriplani can also do everything. So you say you do like that, you do like that. But you are a great teacher, and I thank you very much for your wonderful presentation.
Thank you so much, GV. I call her GV. And people should not think that it is a setting between two friends praising each other.
Somehow,
Thank you.
I have the privilege somehow to speak something for you, and that is my only contribution. Now, I have the great privilege. Thank you, Alka, once again. I have the great privilege of inviting Dr. V.P. Piley for his talk on postpartum hemorrhage, new thoughts on management. Dr. V.P. Piley is the past president of Kerala Foundation of Obstetrics and Gynecology, and he's the state coordinator of Confidential Review of Maternal Deaths, Kerala. He is a consultant at Rajagiri Hospital, Ernakulam district, and his special interests are high-risk pregnancy, endoscopy, pelvic floor, and urogynecology. And while Dr. Piley starts sharing his screen, I think we are really privileged to have you here with us, and we know about postpartum hemorrhage. And I'm sure Dr. Piley will expand our literary horizon, and many innovations and improvisations in postpartum hemorrhage to treat it are not, they do not entail very intensive training or very expensive equipment, or they're not very high in terms of cost. So it's just that we need to be aware of the new thoughts on the management of PPH. Dr. Piley, you may please kindly start illuminating us. Thank you.
Thank you very much. I hope I am audible.
Yes, yes.
Yeah. Thank you very much, Dr. Khanna.
Can you
And
screen, please?
Alka, that beautiful presentation with all your beautiful videos. Thank you very much. Now, I have been asked to talk about some new thoughts which are there on the management of PPH. And what I am going to tell you are our own experience that we have gained auditing maternal deaths in the state of Kerala and developing steps to overcome the problems which ended up in maternal deaths. So this is again what we have gained, and these are not from literature, these are from our own experience. So I hope that you will find it applicable across the country.
Sir, I would request you to do a slideshow or full screen.
My first point is we need a paradigm shift in our approach to PPH. What that paradigm shift, I will elaborate as we go along. The most important thing to recollect and remember is time is the most important parameter that decides outcome. We were told when we were students, there are 2 golden hours to save a patient with PPH. I think that should be thrown out. There are no 2 hours, only few minutes. In a case of real PPH, in few minutes, the patient will collapse and probably go on to metabolic acidosis, DIC, and all that. So that concept that we have 2 hours is the first thing should go out from our thoughts. I thought we'll cover the topics, the few points which I have to cover under these headings. 1, what are the new thinking on prevention of PPH? Second thing, what are the methods available for us to arrest bleeding immediately? I told you time is of the most importance, and arresting the bleeding immediately, promptly is what will make the difference. So what are the new developments in that? We have been always going for the diagnosis of PPH by our impressions, subjectively. But I think now it's time to go objectively to decide which case is a PPH. There are some new thoughts on what we have been for arresting the bleeding or the practices, and that I will suggest what we have decided. And of course, coming to placenta accreta spectrum, where we have made some revolutionary thinking to avoid excess blood loss and maternal death in cases of placenta accreta spectrum. Coming to the first one, prevention. Active management of third stage of labor is the key step to prevent. But when we say active management of third stage of labor, every obstetrician has his own idea about it. So we have crystallized the thoughts and said it should be, first of all, 5 units of oxytocin diluted to 5 ml in saline and give it slowly IV, taking about 5 seconds. At the delivery of the anterior shoulder, or if the baby came out too rapidly, within 1 minute, after making sure that there is no other baby inside. Along with this, we give 10 units of oxytocin intramuscular. This is the oxytocic administration in the active management of third stage of labor. But in addition, because oxytocin gets metabolized very rapidly, we have to continuously supply oxytocic agents in those who have a predilection for that. For that, we add 20 units of oxytocin in 500 ml of saline and give it as a drip at the rate of about 60 drops per minute or about 4 ml per minute. So that's the oxytocic administration in the active management of third stage of labor. Second point is delay the cord clamping to at least about a minute if the baby is okay at birth. Third, remove the placenta by cord traction without waiting for the signs of separation of placenta that we have been taught. Suprapubic bulge, fresh bleeding and all that. After the baby has been cut, the cord has been cut and separated, then make sure the fundus is contracted, push it cranially and give a traction on the cord that will get you the placenta in about 90% of the time. In other words, don't leave the placenta, separated placenta in the lower segment for any longer time. So that's about the third stage management, new concept, which has to be standardized and the message spread across. Second thing is the concept of fourth stage was a little vague. So we have defined and said that 2 hours after delivery of the placenta should be taken. But in that 2 hours, patient has to be monitored closely. When we say monitoring, we say I have multi-parameter monitor. No, pulse, BP are there, of course, to be noted. But more important is check if the uterus is contracted. Check if there is excess bleeding by pushing that contracted uterus down and see whether there is blood appearing between the thighs. This should be done in vaginal delivery. This should be done in cesarean, even if she is in the recovery room with multi-parameter monitor. So that's about the fourth stage new concept. Third, bimanual compression should be the first aid that the obstetrician does as soon as he or she notices that there is excess bleeding. So that is the arrest of bleeding immediately. But that by itself is not enough. We cannot keep on with the bimanual compression for any length of time. So now we have got methods to arrest the bleeding, and that is what we are going to tell you. Transvaginally, we can occlude the uterine arteries on both sides. Transvaginal uterine artery clamp, TVUAC, is what we recommend for that. That's a clamp. It's a long clamp, but the blades are separated like that, and the tips come together. There's a 12-inch long, 1 centimeter gap between blades, and there's the hinge is about 6 inches from the tip, and the bent tip at right angles here. When we apply it like this, as you can see, one blade into the cervical canal, the other blade outside, and when it is pushed above the lateral fornix by about 1.5 centimeters, it will catch the uterine artery where it joins the uterus on the side of the uterus. So that way, when it is applied on both sides, it cuts away the blood supply to the uterus and stops the bleeding. But for that, you have to have retractors, you have to have 2 sponge holders, and you have to have 2 of these clamps. And how to apply that, I'll show you with a clip of video in a minute. So we need to if there's a retractors anteriorly and posteriorly, catch the anterior lip of the cervix, catch the posterior lip of the cervix, and then take the TVUAC and make sure one blade goes into the cervical canal and the other blade goes lateral to the cervix like this. Push it up till it touches the lateral fornix. Once it has touched the lateral fornix, push again up and then clamp it. Do this on the other side as well. so that when both uterine arteries are clamped like this, the blood supply to the uterus is cut off and uterus may go a little flabby. Don't worry. If there is no bleeding, you are not worried. So you should expect the uterus to go flabby like that. So clamp that laterally, clamp it on the other side and leave it like that for about 20 or 30 minutes, and then bleeding would have stopped. You should have a catheter put in. Catheter will tell you whether urine is draining, and after about 20 or 30 minutes, release the clamp first. Don't take it away. If there is no active bleeding, then you take it away. Now of late, what we have found is that we can leave the clamp not just 15 or 20 minutes, but even longer period. You can use it for transferring patients. You should have a catheter with a urometer, which will tell you whether urine is coming, which means you haven't blocked the ureter. Even if you have blocked the ureter, it really doesn't matter because ureter will not be crushed, no damage will be done. At that time, no urine comes into the bladder, that's all. Our colleagues here in Kerala, Samartha Ram and Panikkar, have come out with another device called the suction cannula to stop the atonic PPH. This is what Samartha Ram's cannula is. Multiple holes. This goes into the uterine cavity, and when this end is connected to the suction, that creates such negative pressure so that the uterus collapses onto the cannula, gets rigid, and stops the bleeding. So this is the other first aid we have to stop the bleeding immediately. This also can be left there for even hours together without any worry. The next point is assess the blood loss objectively. Use absorbent mats. You know the pre-use weight of it. You know the post-use weight. And the difference in weight in grams is the number of ml of blood that is lost. To that you add, of course, what is there if there's a suction. So this is applied during cesarean and during vaginal delivery, and that will help us to know how much blood loss rather than just guesstimate or guess how much is the blood loss. This will help us to replace blood loss or to be active. New thoughts on established practices. What we mean is all those procedures like the uterine artery ligation, as you can see here, don't try to just take the uterine artery. You take the lateral aspect of the myometrium at the level of the isthmus, bring it back. So including the side of the uterus, all the vessels, you tie it like that. Rather than, as some of the textbooks show you, rather than going on with tying just the uterine artery, you take the myometrium along with it. To be sure you don't injure the bladder, make sure the bladder is pushed down so that the ureter also will not be in danger. And transillumination will help you to know to avoid puncturing onto vessels. The uterine ovarian anastomosing vessel, as well as the anastomosing branch that comes from the ovarian, can be tied at the cornual region. If you go very close to the tube from front to back and come back on the side, including the myometrium at the corner region. So the vessel which is ascending up, the vessel coming from the side, all of them will be included in the knot rather than just take a tie at the level of the round ligament. So this is the second thing about the procedure that we would like to tell you. Now the brace stitch. We respect B. Lynch because he came out with the idea of the brace stitch, but we usually do not the B. Lynch, but the Hayman's modification. And so again, Hayman's modification has the advantage that it doesn't lead to ischemia. You take the needle from front to back, tie it on the top on both sides like that, and then when you tie it, make sure that the uterus is compressed by the assistant. And when you are tying with the first throw, an assistant should step on it. The indentation on the surface tells you that there is sufficient compression, and then complete the knot on the other side as well. And this is the way. We do not take B. Lynch anymore. We do only Hayman's because B. Lynch has some problems as we know. Now, so B. Lynch, we respect him, but we follow the Hayman's technique for this one. Now, If you have to do internal iliac ligation, we go by the broad ligament approach rather than directly if the uterus is there. So extend the So what you do is you go right up to the pelvic side wall, get to the external iliac artery to guide you, go to the internal iliac, and then you can identify the, see, that's the vessel, that's the external iliac. Retract the ureter medially with the dewer. You can see the external iliac. There is the internal iliac there. And once you have identified and isolated the internal iliac, make sure that you have the right angle clamp going underneath. After bearing the two sides, taking care you don't injure, take the right angle clamp and then have the suture material. Have the suture material come to the around, and you can use any of the usual suture material like 10 Vicryl or linen or catgut, anything. But it's better not to use a non-absorbable suture material. So that is how we will take it like that. Now, the most important thing that we have developed is the aorta clamp. This is for clamping the aorta, lower end of the aorta, for occluding the blood vessels to reach the placental site so that we can operate in a field free of heavily flooded blood there. So it can be used as a first aid to arrest bleeding from uterus for not only placenta accreta, even a tonic PPH. This is the clamp, very simple looking clamp. The important thing is, even when it is closed, there's a gap between the two blades, and the blades inside is very smooth. It doesn't injure the vessel wall, and it has got a long ratchet, so you can occlude the blades only to the level where the blood flow through that has stopped. And so this video will show you how we apply it. Uterus is anteverted, taken out, exteriorized, bowels are packed off, and then you isolate the you identify the common iliac. That is the two common iliac over there. Cranial to that, there is the uterus, lower end of the, cranial to that, there is the aorta, lower end. Hold the aorta with a Babcock. Lift up the aorta. Remember, there is no dissection involved. You are not isolating the vessels by taking the peritoneum around it. You are not going on the inferior surface of the aorta. You are just gently lifting up and applying this clamp straight, including the full thickness of the aorta. Like that. And after you apply it, you palpate the common iliac and make sure that there is no pulsation of that. That is important. And using this, you can also use this for the common iliac. If the aorta is not accessible, you can use the common iliac. And we use the uretery catheters in the beginning, vertical incision on the abdominal wall, vertical incision near the fundus of the uterus without invading the area of the placental attachment. Deliver the baby. Once you have got, apply green Armitage to the edges of the uterine wound. Palpate here the common iliac is being used. Pull up the common iliac as we saw with the other one, avoiding the ureter, and on the left side, avoid the mesosigmoid. Apply the clamp so that beyond that, the common iliac, there is no pulsation, which will take care of the external iliac and the internal iliac. Here, earlier on, we were applying a tourniquet to occlude the blood supply coming from the aorta through the ovarian artery, but now we don't do anymore. We can just go ahead with the clamps if the plan is to do a hysterectomy. But this is what I want to show you. You pull up the uterus, clamp the pedicles at the top. That will take you to the level of the placenta. And once you have taken up to the level of the uterines, that's the peritoneum. This is the extruded placenta here. And you can even infiltrate that area with a little vasopressin. Get the bladder separated like this without disturbing the coagulum on the extruded placenta. The ureter catheter will help you to feel where the ureter is. Apply the clamps closer to the uterus. Then you go across the lower part below the level of the placenta on the cervix. Don't do a total hysterectomy. Do only a subtotal. Leave the cervix below the level of the internal os there. And that is the whole uterus with the placenta delivered. That's the placenta extruded, and make double sure that the stumps are tight. Make sure there are no bleeders on the back, on the posterior surface of the bladder. And that way you leave a drain in the peritoneal cavity and come out. So this is how we apply the principles onto the placenta accreta spectrum. So in conclusion, I would suggest that a new approach to management of PPH is essential. Time is of maximum importance. Arrest the bleeding immediately. And for placenta accreta spectrum, use aorta clamp. I was told the other day that there was some complication of the lumbar artery when somebody tried to clamp the aorta. I doubt whether it was using my clamp. If it is my clamp, there is no reason of dissecting the aorta, no reason to injure. You are just lifting up and applying it. I would like to know if anybody from Delhi, because I was told this happened in Delhi, to know what exactly happened in that situation. But anyway, thank you very much for your attention. Thank you.
Thank you, sir, for such a mesmerizing and making it so simple management of a condition, I mean, which is every obstetrician nightmare, and your innovative thoughts. I know it must have inspired a lot of confidence in juniors that it's a manageable condition. But just one question, sir.
Yeah.
Have you come across ischemic injury of the ureter, and what was the longest duration for which the clamp was used?
Oh, we have applied actually nearly 2 hours in one case recently because it was such a bad percreta going laterally, and no ischemic injuries so far in any of our cases, because our concern is if you keep it longer, what will happen to the lower limb and all that. But remember, the orthopedicians put the tunicae for longer periods. So that is what gave us courage. Second thing is, post-operatively, we give them prophylactic heparin injection. And during the procedure itself, we will have the stockings. That's the precaution that we take. We have used this now in more than 150 cases. And there is no worry about any of the damage, ischemic damage, either to the ureter, but occasionally there will be a problem with the bladder depending on how bad the percreta was.
Okay.
In fact, the case where we had to keep it for 2 hours, what happened was the bladder was so densely invaded that we had bladder injury and it took longer to close it off. That is why we had to keep it that long. Some people suggest you release in between. We don't recommend it.
Okay. So there's no need to release. That's what you feel.
No, if you release in between, the bleeding is so torrential. In 2 minutes, she will exsanguinate.
Thank you again, sir. Sir, covering
Thank
it so beautifully from prevention to management in a simplified way. Thank you, sir. So
Thank
we go to
you.
the next speaker. I have the privilege of introducing next speaker, Dr. Bhaskar Pal. Sir is a very eminent gynecologist. All of us know him, but for the benefit of juniors, sir is senior consultant gynecologist, Apollo Glen Eagles Hospital. He's honorary general secretary IAG 2019-20 and FOGSI representative to CEFOG 2021 to 23. Over to sir. Sir will be elaborating on controversies in management of tubal ectopic pregnancy. Over to sir.
Thank you for the kind introduction. Am I audible now? Hello.
Yes, sir, you're audible. Yes,
Right at the outset, I would like to thank Dr. Mala Srivastav, Dr. Kanika, Dr. Mamta, and the entire AOGD team for inviting me. I must admit, I'm a bit nervous sharing the stage with Dr. Alka Kriplani and Dr. VP Paili. And I also find something interesting that this session is going backwards. We started with cesarean section complications, then we moved on to PPH, and now we move on to tubal ectopic pregnancy. And I looked at the program to see whether we go to infertility next, and I saw no, we next jump onto menopause. Anyway, I bring you, it would have been wonderful if we could meet in person, but I bring you greetings from Calcutta. On the top, you can see the iconic Victoria Memorial, and below is the hospital where I work. Now, why did I choose this topic? I think Dr. Mala is very particular. She wanted to know what controversies I'm going to speak on. And essentially, there are 4 issues I want to highlight. I get extremely disturbed by the fact that we still fail to diagnose ectopic pregnancies in time. That's one. The second issue is the medical management is still extremely underutilized. People get worried when I tell them that, well, why don't you give methotrexate in this patient? The third reason is there are still too many laparotomies happening around the country for ectopic pregnancies. And number 4, many people are not clear whether we should do a salpingectomy or whether we should do a salpingostomy when we have an ectopic pregnancy. Just to set the context, the incidence of ectopic pregnancy is around 1%, and we still lose women because of ectopic pregnancies. Now, early diagnosis is the key because it reduces mortality, morbidity, because we can resort to less invasive therapy. Every year, once in a year, I take a class for our emergency department medical officers, and I teach them one thing, that if there is any woman in the reproductive age group who comes into the unit with abdominal pain, irrespective of what is the site of the pain, and irrespective of what is the sexual or marital history, please do a urine pregnancy test. If there is a patient who's got a positive urinary pregnancy test with an abdominal ultrasound, abdominal pain with a positive urinary pregnancy test, please do an ultrasound. Now, if you see an ectopic, the diagnosis is established. If you do not see an ectopic, that is when you need to do a serum beta ECG. And we all know that the threshold levels for seeing an intrauterine gestational sac these days would be around 1500. For 1500 would be the level of beta ECG where you should see an intrauterine pregnancy on TVS. For transabdominal scan, it is 6000. If in doubt, we do 2 serial serum beta ECGs 48 hours apart. And if the rise is more than 66%, it is likely a viable intrauterine pregnancy. Pseudosac is a transabdominal ultrasound feature on TVS. We should not be seeing a pseudosac. But what is important is that just an empty uterus on TVS is not enough to diagnose an ectopic in today's day and age. We should be able to see an ectopic pregnancy in the adnexa, which could be a live ectopic pregnancy. But the most appropriate TVS criteria is a non-cystic adnexal mass. If we find an empty uterus with a beta ECG of more than 1500, then we need to call it a pregnancy of unknown location. Follow that up. That could be a miscarriage, that could be an ectopic as well, but we cannot stamp it as an ectopic. And a non-cystic adnexal mass has a very good sensitivity, specificity, predictive, positive and negative predictive value. Our teachers taught us that you need to be ectopic minded to diagnose ectopic, and that means a high index of suspicion. And that is exactly what I said, do a urine pregnancy test in all women of reproductive age group with abdominal pain. The second important issue by which we miss ectopic pregnancies is sometimes the patient comes in, gives a history of amenorrhea, a positive pregnancy test, and she says that I bled with, I passed solid bits, and we do a TVS and we find an empty uterus with a thin endometrium. Yes, it is likely to be a complete miscarriage, but it is also possible that it is an ectopic pregnancy with a bit of vaginal bleeding. So the diagnosis of complete miscarriage cannot be made on the basis of a single TVS. You need at least to show a serial fall in beta ECG. I put this slide up to say that we talk of a lot of risk factors. Please don't waste your time looking at risk factors or taking a history, whether this patient has a history of PID or IUCD or a previous cesarean section. Ectopic pregnancy risk stratification does not help. The only risk factor which significantly increases the risk of ectopic pregnancy is a previous history of ectopic pregnancy. And the classic triad of bleeding, amenorrhea, and pain does not exist. By the time that exists, you'll have all your patients who are in rupture. So do not bother about risk factors. And with that, we move on to medical management. Now, at the present moment, when we were students, we were talking of local injections, we're talking of KCL, methotrexate, a lot of things. At the present moment, the world has come down to systemic methotrexate as the medical management of choice for ectopic pregnancy. And if you like the British, you use the single dose. And if you like the Americans, you use the multiple dose. And this is a meta-analysis of single dose methotrexate, and the success rate varies from 70 to 100%. And why does the success rate varies? It depends on how strict you are with your inclusion criteria for medical management. If you set a lower size of ectopic pregnancy, a lower beta ICG level, then obviously your success rate is going to be higher. And this meta-analysis showed that if the ectopic pregnancy is less than 3 centimeters, there is no hemoperitoneum on TVS, then methotrexate injection is successful, but you should not be using it if there is cardiac activity, because it doesn't work very well with live ectopic pregnancies. This is another paper of 58 cases which was published in 2006, which showed that it failed in around 15%, and a second dose after 7 days was needed in another 15%. And the main predictors of treatment failure was a presence of embryo, a day 1 beta ECG of more than 3000, a subchorionic tubal hematoma, and a day 3 follow-up HCG of more than 3500, which means the way we do use methotrexate is that we do a serum beta ECG level. And I will come into the criteria a little later, but we are actually using a beta ECG of less than 3000, an ectopic pregnancy size of less than 3 centimeters, no fetal heartbeat seen. The patient is not overtly symptomatic and is hemodynamically stable, and there is no significant hemoperitoneum. And we give a methotrexate with a dosage of 50 milligram per meter square. If you have difficulty in calculating, roughly it equates to 1 milligram per kg of body weight. We give it in a single intramuscular dose. If the patient compliance is good, the patient does not need to get admitted. And what we do is we repeat the beta ECG on day 4 and day 7. Now, don't be surprised if the beta ECG goes up a little bit on day 4. It can go up to 15%. If it goes above 15%, that's not a good sign. And by day 7, you should see at least a 15% fall from the day 1 beta ECG. And if you do not see that fall, then you can consider giving a second dose of methotrexate. Essentially, your good practice point is that when you are counseling the woman and you've chosen your patient well, and the patient says, what are the chances that I will be fine with methotrexate? It is a 75% chance that the ectopic pregnancy will resolve with single dose. There's a 15% chance that it will resolve with a second dose. And there's a 10% chance that it will not resolve and she'll require a surgical intervention, either because the beta ECG is not going down or she's getting symptomatic or there is hemoperitoneum. There is no extra benefit of giving local methotrexate. The US dosage is 1 milligram per kg of body weight on day 1, day 3, and day 5, with oral folinic acid rescue on day 2, 4, and 6. There is some studies which seem to indicate that if you are giving methotrexate in women who've got a beta ECG of more than 3000 or an ectopic pregnancy of more than 3 centimeters, and we've used that at least in around 4 cases of conjugal ectopic pregnancy, and that is where sometimes it may be logical to go for a multiple dose. Now, which means that the way I have said that you will have to wait for 7 days to know whether this is working or not. Now, this is a study published in 2017 from Hong Kong showed that if you see a 6% drop between the day 1 and day 4 beta ECG, then you can predict with 93 to 94% accuracy that this ectopic pregnancy is going to resolve with methotrexate. So by day 4, if you see a 6% fall from day 1 beta ECG, you can be reasonably assured that this is going to work. And this is again 108 cases, single versus multiple doses. More or less, it's the same. Now, if you look at the NICE guideline, the NICE guideline says that you should give it, if the patient's beta ECG is less than 1500, then you must offer methotrexate. Methotrexate should be your first line. If it is between 1500 to 3000, then your best option, then you should offer her methotrexate and discuss other options as well. Do not give the option of methotrexate to somebody whose compliance is on question, who you do not think will be able to come in if she develops symptoms. So day 1 beta ECG less than 3000, ectopic pregnancy less than 3 centimeters. I've said this before. This is what actually where methotrexate works best. And as I've said, that good counseling points is that 75% will resolve with single dose, another 15% with second dose, 10% will require a surgical treatment. And this is what NICE says, and this is how, and they say that you should offer both surgery and methotrexate if the ECG is between 1500 to 5000. Now, coming into the surgical treatment, let us have no doubt that the laparoscopy is the route of choice. And in the hemodynamically unstable patient, you sometimes need to resort to laparotomy, but absolutely with the experience of the surgeon and with the experience of the anesthetist, you can take more and more patients for laparoscopy. And I will come to the reasons very soon. Question is whether you should do a salpingectomy or salpingotomy. I will go into that, but if you do a salpingotomy, there is a risk of persistent trophoblast, and so you need to follow the patient up with serial beta ECGs. Please remember that there is no difference in the ovarian response for subsequent IVF if the ectopic pregnancy, whether it is treated with methotrexate or salpingectomy. Now, why should we go for a laparoscopy? There are 3 randomized controlled trials containing 228 patients, and which shows that the laparoscopy is associated with less intraoperative blood loss, shorter operating times, shorter hospital stay, lower, I think the conference international team is unmuted. Please mute yourself. Lower analgesic requirements, and there is no difference in subsequent intrauterine pregnancy rates. And there is a trend towards lower future ectopic pregnancy rates if you are doing a laparoscopy. And yes, you can use a harmonic scalpel, but a bipolar is good enough. You need to stay away from the infundibulopelvic ligament. And because sometimes these are associated with PID, please do expect some additions. The other issue is that there is, which I keep telling the anesthetists, that if you are happy for me to go ahead with the laparoscopy, I will guarantee you that I will be able to control the bleeding sooner than I will be able to control it in laparotomy. Because in laparoscopy, you can go ahead and stop the bleeding, and much before, it will take you possibly longer time to open the abdomen, because we all, for ectopic pregnancy, we go by a phalansteal incision. We no longer use a vertical incision. And the more rapid access to abdomen. And what happens is that you have a quicker control of bleeding, and then you take your time to clean the abdominal cavity of blood. Now, how much hemoperitoneum you should be comfortable with? I think sky is the limit. It depends on what you are comfortable with. I remember when we were postgraduate students and Dr. Rakesh Sinha came back from England and took a lecture for us where he said, 2000 ml of blood in the abdomen is an absolute contraindication, and 500 ml, which is blood filling the pelvis, is a relative contraindication for doing a laparoscopy. We've moved away from that. We can clear up to 4 liters, even 4 liters of blood from the abdominal cavity. It takes time, it takes patience. But essentially, if the anesthetist is happy for you to proceed with a laparoscopy, any patient you can do a laparoscopy. It takes time to irrigate the abdomen. Less extensive post-operative additions, faster recovery, lower cost of hospitalization and rehabilitation. Now the issue is salpingectomy or salpingotomy. Now, traditional understanding, logical understanding dictates that if you do a salpingotomy, because you're leaving a disease tube behind, there is a higher risk of subsequent ectopic. And again, common logic says that if you keep 2 tubes behind, possibly there would be a higher chance of intrauterine pregnancy. Now, I will look at 4 cohort studies, 1 recent large cohort study and 2 recent randomized controlled trials, which tells us how we should proceed this. Now, this was the first one published in 1993. This was a retrospective study, and it showed that with salpingectomy and salpingotomy, there was essentially no difference in intrauterine pregnancy rates, but higher recurrent ectopic pregnancy rates with a salpingostomy. Subsequently, 3 more studies, retrospective studies were published, and all of them showed, this is the first one, all of them showed that there was a higher subsequent intrauterine pregnancy rate with salpingotomy followed compared to salpingectomy. That was the first one. This is a cohort of 135 women, and this is the 3rd study. Now, this actually completely confused the situation. And based on this, the Royal College issued a guideline because they liked the first study better. They said that if the contralateral tube is healthy, you should go for salpingectomy, whereas the Americans said that you should always go for a linear salpingotomy. This was the confusion back in 2009, 2010. What happened was that in 2015 in the BMJ, this large retrospective study of 618 patients was published, which had salpingectomy patients with salpingectomy, salpingotomy, as well as with tubal anastomosis in stable patients. And it showed there was the future intrauterine pregnancy rates with salpingectomy and salpingotomy were similar, and the risk of persistent trophoblast was higher with the salpingotomy. And they showed there was no significant difference in the recurrent ectopic risk whether you do a salpingotomy or a salpingectomy. We all know that the flavor of the century is randomized controlled trials, and this randomized controlled trial was published in 2013, and it looked at methotrexate versus salpingotomy versus salpingectomy and showed that the intrauterine pregnancy rates were similar. And this was another one which showed, this is published in Lancet, which showed the after salpingectomy and salpingotomy, the intrauterine pregnancy rates were similar. And since these were the only two randomized controlled trials, it doesn't need a rocket scientist to tell us that the meta-analysis showed that there was no difference in intrauterine pregnancy rates whether you do a salpingectomy or salpingotomy. So what you should be doing, if the contralateral tube is diseased, then you should do a salpingotomy. Unless the patient is determined that she's going for an IVF and would like to take the tube out. If contralateral tube is healthy, then we should do a salpingectomy and not with salpingotomy, as the subsequent intrauterine pregnancy rates are similar. Possibly there is a small increase in subsequent ectopic pregnancy rates with salpingotomy, but definitely there is a risk of persistent trophoblast with salpingotomy, and we need to follow up with beta ECG, serial beta ECG levels till we see that the beta ECG is gone below 5. The other important thing is, please do not attempt a salpingotomy if it is a live ectopic pregnancy, because they're extremely vascular, and we would end up, if we tend to control the bleeding, you'll end up damaging the tube quite a bit. So in conclusion, in all women of reproductive age group who complain of abdominal pain, an ectopic pregnancy has to be ruled out. A TVS should be the initial investigation and not a serum beta ECG. And an empty uterus is not sufficient to diagnose ectopic pregnancy. Methotrexate is an effective treatment in well-selected patients. Laparoscopy is the operative route of choice, except in the extremely unstable patient. I should add the word extremely. But of course, you need to be safe first and operate within your comfort levels. And salpingectomy is preferred if the contralateral tube is healthy. Thank you very much.
Thank you very much, Dr. Bhaskar Pal. You beautifully described all the aspects of the ectopic pregnancy. You nicely covered all the aspects of the diagnosing the ectopic pregnancy and all the aspects of managing the ectopic pregnancy, including with the methotrexate medical management as well as the surgical management. Sir, I would like to ask you, in your routine practice, whether you prefer the single dose methodology for the medical management or variable doses or multiple doses.
I have always used single doses. I'm not a fan of multiple doses. Even in cornual ectopic, where I go beyond the 3000 beta ECG levels. See, we know cornual ectopics take much longer to rupture, so it will give you a little longer time. So I don't think that the rule of 3 centimeters ectopic pregnancy and 3000 beta ECG level would be true for cornual ectopic. In cornual ectopic, we've gone up to 5000, we've gone up to 4.5 centimeters. We do not have so many cases with which we can say, but we use single dose methotrexate, and I would possibly use around 8 to 10 methotrexate for ectopic in a year. And in the past 5 years, only one patient has required a single dose, and a second dose.
Sir, after giving the single dose, whether you allow the patient to go home, or on which day you would prefer to do the beta ECG?
It depends. We do the beta ECG on day 4 and day 7, as I said.
Suppose beta ECG is 3000 and ectopic size is less than 3 centimeter and she's asymptomatic. So after giving the methotrexate, whether you allowed to go the patient to go home?
There is no reason why the patient needs to be in the hospital. It all depends on two things. Number one, whether the patient has transport and help at home who can bring her to the hospital if required. And number two, what is the distance from the hospital? Having said that, all cornual ectopics we keep in the hospital. We do not let them go before day 7 till we see an appreciable fall. Pardon?
And, yes, sir. Sorry.
So if
on which day you prefer to do the beta ECG after giving the single dose?
Day 4 and day 7. And day 4, while it can go up to 15%, by day 4, if you see a 6% fall, then you can happily discharge the patient, because you know 95% chance it's not going to work, not going to have a problem. Again, if you're giving to methotrexate to somebody who's got a beta ECG level of less than 1500, please feel pretty confident about sending the patient home if there's no absolute. So there are two reasons for keeping the patient in the hospital. One is social and one is medical. Medical is especially when there is an cornual ectopic pregnancy or the patient has some vague pain, and the social reason would be the patient stays far from the hospital, or you are unsure whether the patient can reach the hospital quickly if there is a problem.
And suppose there is a cardiac activity, but beta ECG is not very high, less than 5000.
It doesn't.
Would you like to do the
No, not really. If the cardiac activity is there, then it is better to go for a laparoscopy and salpingectomy.
Any beta ECG level?
Irrespective of the beta ECG level. If it's a live ectopic pregnancy, it is much better to go for surgery and salpingectomy rather than wasting your time with methotrexate or with salpingotomy. You might
not salpingotomy.
Not salping. You might succeed in salpingotomy, but the tube will be severely damaged.
Okay. Thank you, sir. Thank you very much,
My
sir.
pleasure.
Thank you all the esteemed speakers and chairpersons of this session. Moving on to the next session, which is a panel discussion on menopause hormone therapy made to order case-based discussion. And to moderate this session, may I invite Dr. Jyoti Unni. Dr. Jyoti Unni is the Director, Department of Obstetrics and Gynecology at Jahangir Hospital, Pune. She is the President, Indian Menopausal Society in 2013 and IMS representative to International Menopause Society 2015-16. She is IMS representative to Asia Pacific Menopause Federation 2019-20 and past chair West Zone Representative Committee of AICC RCOG 2010 to 2015. So over to you, Dr. Jyoti.
Thank you very much, Mamta. I'll just start sharing my screen now. If you can stop screen sharing, please. Okay. So I'll just quickly introduce my panelists. Thank you very much for inviting us to this prestigious AOGD virtual conference. So Dr. Meeta has been the president of Indian Menopause Society in 2012, and she is co-director of Tanveer Hospital, Hyderabad. Dr. Neelam Agarwal has been president of Indian Menopause Society 2019-2020. And she works in the PGI Chandigarh. Dr. Srikantan is an eminent cardiologist from Pune and a very active member of the Menopause Society Pune. Professor Hepzibah, she is now the vice president of the Chennai Menopause Society, and she works at the Stanley Medical College in Chennai. Dr. Anupama Mane is a consultant breast surgeon at the Ruby Hall Clinic, Pune, and has been very active on a lot of our Menopause Society Pune activities. Dr. Parag Biniwale is currently the president of Menopause Society Pune and also the secretary of ICOG and is a senior consultant in Pune. So we'll go on to our panel straight away. So India, as we all know, is the second largest country in the world in terms of number of women over 50. And the age of menopause in Indian women is about 46.2 years by all the data produced by Indian Menopause Society, multicentric, not 51 as it is in many of the Western countries. The postmenopausal women, we anticipate that by 2026, there will be 103 million of them. And the elderly women will largely outnumber the men. And so the problems that all of us will have to face in terms of the geriatric population will largely be the problems of women. So the Menopause Society slogan, which was actually introduced by Dr. Meeta, and we have continued it, is that we want our women to be fit at 40, strong at 60, and independent at 80. And towards that end, let us go on to the case discussions, which will be very practical discussions on what to do in day-to-day practice. So the first case is a 46-year-old, para 2, with hot flashes, night sweats, insomnia since 12 months, so classical vasomotor symptoms. She's had her last menstrual period 2 months ago. And since 1 year, she has been having irregular cycles, which have been lasting for 4 to 5 days, every 40 to 90 days. There's been nothing relevant in her past or family history. So we'll start with Dr. Meeta. How will you proceed with this case? Dr. Meeta? Sorry, okay, can I ask Dr. Parag, please?
Yeah, I'm in Jyoti.
Okay,
I
yeah.
did the mistake what you anticipated that we would do. I didn't unmute. So there you are. A very good evening to everybody, and thank you AOGD and the team for having this menopause panel here today. And it's a very classic case that you have presented, Jyoti, which we would see very commonly in practice. Not yet attained menopause. So first thing that I would do is, in my mind, try to stage this woman, where she falls in, which stage of her reproductive phase, whether she is in the menopausal phase, menopause transition, early transition, or late transition. Obviously, as you said, it is 47 years and she is 46, having irregular cycles. So all the pointers are there that she's heading for her menopause. So she falls into the late menopause transition. And so having staged her and diagnosed, we really don't need any any investigations to diagnose menopause. So we would do the basic investigations for her general health, as well as to tackle the problems that she has come with. You want me to continue, or you want to?
No, we'll go ahead. So now we've done a general examination. So all women, as Meeta has said, we need to do a routine examination before we just jump to what their symptoms are, because many of them would never have come to us after their babies probably. So she had a BMI of 24. Her BP was 150/90. Systemic examination, there was no problem. So Dr. Parag, any investigations you would like to do for this lady?
Okay, thank you, Jyoti. And first of all, when we get such a woman who's approaching her menopause with a lot of symptoms, we would, after examination, we would certainly like to do a transvaginal scan to have a look at the uterus, the endometrium, and the ovaries, along with a pap smear and plus minus HPV testing. For any woman who's approaching menopause, we would certainly get some blood workup done, which would include a hemogram, a thyroid function test, sugar, which could be fasting plus postprandial. Lipid profile is again important in our women, and a urine routine examination. So after all this workup, we will then, if everything is okay, then probably we'll think of offering her some therapy.
Okay, so Hepzibah, would you like to do an FSH for this lady? Dr. Hepzibah? Dr. Neelam, would you like to do an FSH for this lady?
There is actually no need to do an FSH for this lady, because she is symptom wise as well as age wise, she is almost like perimenopausal. So FSH is not going to add much.
Right. So we don't need to do an FSH, as you have heard from the panelists. You don't need to do an FSH just to diagnose menopause. The age group and the symptomatology is essentially enough. Dr. Meeta, can you tell me in which particular women you would like to do an FSH? Not in this particular case, but are there any special circumstances under which we would like to do an FSH to diagnose menopause?
Yeah, there are very few indications where we would want to do an FSH, especially if she's a younger, at a younger age, or even at this age, if she's interested in fertility, then you still think about it. But at a younger age group, you want to rule out, say she comes at an early age with amenorrhea, more than 4 months of amenorrhea, and she is say 40, 41. Then you want to rule out other causes of amenorrhea. That is the reason why you would like to do an FSH. Or if she is also interested in fertility, I think these are the two situations. Rule out other causes of amenorrhea and fertility in a younger age group.
If she is interested in infertility, then I think AMH also would be needed.
And of course, the whole panel, but since she was about FSH,
okay,
it comes
so,
ovarian reserve. Then you talk about ovarian reserve.
Yeah, and
Right.
in a woman who is on E plus P, that also might need FSH to make sure that she's
Right. So probably if there is any form of iatrogenic menopause also, if she has undergone chemotherapy or radiation, or she's had a hysterectomy where we've preserved the ovaries, and then she's developing symptoms, we may want to do an FSH to see. but otherwise routinely we don't need to do an FSH. So all her investigations were normal. Now, Dr. Parag, what would you think would be her management option?
Okay. Now here, the only finding which needs a little more attention is her BP reading of 150/90, which I think it's a good idea for us to get it investigated further more before we offer her any therapy. She's the one who can certainly be given non-hormonal options, which can include a dietary modification, diet which is rich in soya, isoflavones, etc. Would, I mean, it is possible that she may be benefited with the dietary modification. That is number one. Secondly, other things in the lifestyle modification like reducing smoking, alcohol, reducing caffeine intake, many a time helps. As far as medical management of these women is concerned, we can offer them preparations which do contain isoflavones. There are quite a few available with or without calcium. So that is something which we can offer as a primary therapy. Now, as far as her blood pressure reading is concerned, if her subsequent readings are normal and if there's nothing, if there's no cardiological reason for her BP or any, then maybe we can think of considering her for menopausal hormone therapy as well. And if she's not keen on menopausal hormone therapy, we can think of SSRIs and SNRIs for her.
Right. Dr. Srikantan, what would you tell us, what are the current guidelines for the threshold for starting antihypertensives in these women? What should our target blood pressure be?
Thank you, Jyoti, for inviting me to share my views with you all. As a physician, my role would be to support the gynecologist in choosing the right patient and the right time for hormone replacement therapy. There is a situation where you can clearly see two issues that are staring at us from the physician's point of view. One is she's on the borderline for a BMI. She has scope to bring down her weight a little bit. This is a nice time to advise her on exercise management, diet management, and carbohydrate reduction in the long term. Number two, her blood pressure is 150/90, not something, just as Parag said, I wouldn't jump to start medications at this stage. I would introduce non-pharmacological methods of reducing blood pressure. Again, exercise, weight reduction, a little bit of salt reduction in the diet, and watch her blood pressure over a period of time before introducing medicines for blood pressure. What is the threshold for starting treatment? Anything above 160 and 100 diastolic poses a risk for events. So she's not at that level yet. She could help herself by exercises and diet. I'm sure with good motivation, people in this age group can be convinced to change their lifestyle a little bit. And serial blood pressure measurements are more important than one single reading to take a call on therapy. There are today various home monitoring devices. I recommend home monitoring devices to most of my patients because it's the best way to look at blood pressure. Blood pressure readings in the clinic are usually high. I wouldn't go by that for treatment. If home monitoring blood pressure readings show 150/90 or above on a number of readings, yes, she needs some form of therapy. Otherwise, we could wait with non-medical management at this stage.
Right. Thank you. And so as Parag was saying, for the management of hot flushes, loose cotton clothing, we should tell her to avoid warm drinks and hot baths, restrict alcohol, caffeine, smoking cessation, and diet and exercise should be told to all women. And remember that though her BMI is 24, the Asian cutoff for BMI is now 23. So we should not think in terms of 25. We should start talking to them when they're above 23 about action. And we need to treat hypertension if she continues to have slightly high blood pressure. Now she chooses to have menopausal hormone therapy. Dr. Hepzibah, are you there?
Yeah. Yes.
Yeah. So what drug would you like to give her?
Since she has irregular cycles, if there is no contraindication, and to regularize cycle and to look after the vasomotor symptoms, we can use oral receptor.
Sorry, your voice is breaking up.
Can you hear me? Can you hear me?
Yes.
Yeah. Since her cycles are also irregular, in addition, she has vasomotor symptoms also. She can be given a low-dose oral contraceptive tablets with ethinyl estradiol and levonorgestrel or drospirenone or digestrel.
Okay. Meeta, what would you choose and what would your regime be for this woman?
I would, Jyoti, I would rather go for the natural estrogen, the menopausal hormone therapy rather than the ethinyl estradiol. We would try to avoid it, especially in case of hypertension and that mild rise and, a little overweight. And I would definitely regime and the mode of treatment depending upon her cardiovascular risk assessment. It's not just the blood pressure that we would be looking at. Probably we would do a proper cardiovascular risk assessment, whether she falls into the low, moderate or high risk category by, the various tools that we have. And once she falls
in the low risk category,
and what regime? Then there is, if she's in the low risk, then we can straight away give her the options of oral hormone therapy, which would be more helpful. So I would go, my favorite now is either conjugated or 17-beta estradiol, and the progesterone is the dydrogesterone or the plain progesterone. So since we have a combination pill available in India, probably a combination pill is easier for the woman to handle, and we would be giving her a sequential cyclical regime where you give estrogen every single day and the progesterone is given for the 14 days in a month. So, so she has predictable periods. So there are two advantages over here. With her irregular cycles will also get regularized and she will be relieved of the symptoms. But we have to tell her that it may take about 2 to 3 weeks minimum before she starts having a significant response with her hot flushes and her, night sweats and sleep problems.
Right. So we have to counsel her that it will take some time. And because she is perimenopausal, it would be better for us to give her a sequential regime, because otherwise if we try to give her a continuous regime, she'll get a lot of breakthrough bleeding and spotting, which women would not like at this stage. So
and
for perimenopausal women, it's better. Yeah, tell me.
We have to tell her that even though the risk is just 1 to 2%, but she has to take that risk of covering for the contraceptive phase. I mean, she can still conceive 1 to 2% chance. So with this sequential MHT, means this kind of therapy, there is still that risk of contraception being not covered. Is there. That she should know.
Right. So if you are giving her menopausal hormone therapy, we have to tell her to use some other form of protection, and that these hormones are not like the combined pill and will not give her protection. So estrogen, progesterone therapy, sequential, and we can give continuous combined only in postmenopausal women, because otherwise they get breakthrough bleeding, as I've said. Now, Parag, can we use tibolone in this woman?
In this woman, I don't think it's a good idea for us to use tibolone. Typically, we recommend tibolone only after 1 year post-menopausal. So for her, I don't think that's the right drug.
Okay, so same thing with tibolone, that it can cause a lot of breakthrough bleeding if they are perimenopausal. So it's best to wait till they are postmenopausal, at least 1 year before we start tibolone. What about raloxifene, Dr. Neelam?
Raloxifene, Jyoti, is a serum, but raloxifene will increase the hot flushes. So raloxifene is not a good choice here.
Basically for bone health, and not to be given for vasomotor symptoms, because it actually increases vasomotor symptoms, because it is an anti-estrogen and it has anti-estrogenic action as far as the vasomotor symptoms are concerned. So as Meeta has said, there is conjugated equine estrogens or estradiol, and usually we start with a low dose of 0.3 milligrams of CEE or 1 milligram of E2. Earlier we used to start high and bring it down. Now the dictum is to start low and wait for 3 months. If they don't develop, if they don't have enough relief, then we may step it up. But otherwise, most of them do well with low dose. And there is also a transdermal gel available, which can be used. The patches don't work very well, so they're not in the market in India. But if we want to use a transdermal preparation, a gel is available. So, Dr. Hepzibah, when would you choose the transdermal route?
When the patient is having hypertension or dyslipidemia and gallbladder disease and other cases, we can use transdermal route.
Right. So in women who are obese or who have dyslipidemia, who have, and it's good because it avoids the first pass. And so the problems on the coagulation parameters as well as the lipid parameters are not as much as with the oral route. Progestogen, we used to use MPA and NITA, but we are now using either dydrogesterone or micronized progesterone because they are less androgenic, so they have less adverse effects on the lipids. And also it appears as if they have less adverse effects on the breast from all the data which is coming out now. The LNG-IUS system is another fantastic thing to use for women who will agree, because then you can put in the LNG-IUS system and then stop worrying about protecting their endometrium, because they don't have to take a separate pill or stop taking the progesterone because they recognize that they're getting the side effects of progesterone. So that is a good option for women who will agree to have an LNG-IUS system put in. Now, lower hormone therapy doses are chosen nowadays because there's continued efficacy with fewer side effects. There's potential for greater acceptance and there's improved continuous. And the efficacy in prevention of osteoporosis also is not compromised. There's no contraindication for MHT if the BP is well controlled, as we were all talking about. But there is an increase in stroke rate with MHT in women who are hypertensive, and obesity and age further increase this risk. So if they are hypertensive, it's a good idea to control the hypertension before starting the hormones. Now, the next case, this is a 52-year-old, again with vasomotor symptoms, plus she's feeling very low. She's had her last period a couple of months ago. Her BMI is 30, her blood pressure is 150/100. What investigations would you advise in such a woman, Dr. Srikantan?
So here is a lady who is grossly overweight, significant hypertension, and feeling low since 6 months. It's possible that this is the start of perimenopause, but I would be more worried about medical conditions here, especially hypothyroidism is something I would look at very carefully. Number two, I would look at her blood sugar levels. I would look at HbA1c. It's a very useful parameter today to look at diabetes risk.
Right. So her lipid parameters have been done and her triglycerides are high, HbA1c just borderline high, TSH is 4.1. Now, in terms of management options, Srikantan, what would you like to start this woman on? And we'll address her vasomotor symptoms later, but what would you advise her?
So she's overweight, she's hypertensive in a range where treatment is important. She has hypertriglyceridemia, which clearly points towards a high sugar load in her diet. Her HbA1c is on the pre-diabetes range. Her TSH is in the borderline hypothyroid range. Number one, aggressive weight management, good exercise program. Number two, significant carbohydrate reduction in her diet, especially high glycemic carbohydrates like rice, wheat, sugars need to be cut down. This is a stage where I would introduce a very mild diuretic antihypertensive like hydrochlorothiazide or chlorthalidone works wonderfully in this age group, brings down blood pressure gently without too many side effects. I would not rush to start medications for her high cholesterol. I would rather focus on bringing her pre-diabetic stage down and bringing her weight and blood pressure down.
Right. So lifestyle modifications, and as Dr. Srikantan has said, we probably would not start statins yet. What about aspirin, Dr. Srikantan?
Again, aspirin, there is no proof at all to show that aspirin as a preventive medication really helps. I would not use it at this stage.
So now, Parag, you were talking earlier about giving SSRIs or SNRIs to women. So can you tell us a little about what drug you would like to use if we were going to use an SSRI or an SNRI?
I personally have not used it in many patients, probably in just a couple of patients. I have used venlafaxine earlier, and which did give good results. I think Meeta can give a better opinion on this.
I think what Jyoti is probably looking at, the options when she's got the dyslipidemia, fluoxetine is supposed to work better for these kind of patients. So the choice probably would be more in favor of fluoxetine, because I do use fluoxetine as well as gabapentin for the non-hormonal therapy when we choose from. But with this particular patient, probably yes. But I was also wondering, maybe a little out of context, but with the BMI that high, and if she's suffering from severe symptoms, then once you control this blood pressure, and also help her out with the dyslipidemia, probably it's not a bad idea to give her a transdermal hormone therapy, which would work better than the non-hormonal.
Right. So non-hormonal therapy is only basically like if she either declines hormone therapy, or we would prefer her to lose some weight before giving it, because it doesn't work as well as hormone therapy. And if we are choosing hormone therapy, then we should think in terms of a transdermal preparation, which we've already talked that the route of administration should be transdermal. Dr. Neelam, can you tell us a little bit about the window of opportunity in terms of hormone therapy?
Yeah, window of opportunity in terms of hormone therapy is explained as the nearer the patient is from her menopausal time, like just immediately postmenopausal. So that is the time when the blood vessels, endothelium of the blood vessels would respond more positively to the hormones given. So this is the window of opportunity just near the menopausal this thing. And now as the various society guidelines go, so we can start, best period to start hormone therapy in case of symptoms is either within 10 years of menopause or less than 60 years of age, and preferably as nearer to the menopause as much possible. Means earlier we should start after the menopause. Yeah.
Right. So
rather
basically there appears to be estrogen may have a protective role in coronary heart disease prevention in women aged 50 to 59 years. Treating hypertension reduces this risk, and reducing obesity, improving diet and regular exercise are also key measures. This is from the British Menopause Society, but it's very similar from the Indian Menopause Society, International Menopause Society, and all societies, that more and more data is coming that it may have a protective role if it started at this window of opportunity, which is in the early postmenopausal or perimenopausal years, within 10 years of menopause, or in women below 60. And this, though this is not an indication to start for primary prevention, if they have symptoms, they seem to accrue this benefit also. So the next case is a 46-year-old. She is para 2, she is breastfed. She complains of mood changes, loss of libido since 6 months. Her last period was a year ago. She gives history of premenstrual breast pain. Dr. Anupama, what investigation would you like us to do for this woman? Anupama, are you there?
Yeah, yes, ma'am. So basically, this is again a perimenopausal age group, and along with the routine blood investigations, the blood sugar, the thyroid function tests, all that needs to be done. She needs a thorough gynec evaluation as well. And we don't have a mammography screening program as such in India. But if we are discussing menopausal hormone therapy, then a screening mammogram would also be required, though not for these symptoms.
Okay. So her ultrasound shows a breast cyst. So how would you like to now proceed further?
So a breast cyst, if it is only simple, does not really require much of treatment. Only if the breast cyst is complex or complicated, will it require either aspiration or some analgesics. Specific treatment for the breast cyst is not really required.
Right. Okay. So an aspiration was done and it was found to be benign. The treating physician decided to do a mammogram also, and this showed dense breasts. So what are the implications of dense breasts, Anupama, in a 46-year-old?
So dense breasts have two major problems. First of all, on mammography, the malignant lesions may not be picked up well. So there is a chance of false negative results with dense breasts. And secondly, density itself, it is indicative of more amount of glandular tissue, and hence it increases the risk of malignancy in future. So it is a risk factor for breast cancers.
Right. So just having dense breasts is also a risk factor. So we should keep this in mind when we are looking at these women. So Dr. Meeta, would you offer hormone therapy to this woman? She has got mood changes and loss of libido.
Yeah, actually, she wouldn't really fit into a very typical case of severe vasomotor symptoms, because we have to look, because you said that she's got this premenstrual breast pain, so we have to again go back into the history and find out whether she also had this premenstrual syndrome, where she also had this mood changes which were there earlier, or has it just appeared the last when she's going through this transition where she didn't have her flow for a year. So if it is something new which has happened after she has attained menopause, then yes, we would offer her at least a trial of hormone therapy, and and then maybe after 3 months, if she responds, that means the mood changes, and the libido of course may not really respond to estrogens, but then at least you will know that she's feeling better. If she doesn't feel better, then you stop the hormones and investigate her a little more.
Yeah, Meeta, in addition, can I say?
Yes, of course.
Yeah, Neelam.
In addition, I think I would like to screen her for depression also.
Yes,
because
exactly.
the mood changes are just new ones, and there are no hot flashes, night sweats, etc. Then screening for depression also might help us in deciding whether SSRI.
That is why the history, the background history becomes very important in these women, rather than just jumping onto hormone therapy for her.
Yeah.
Right. So she was offered hormone therapy, but she was scared because she said her close friend had breast cancer and she was afraid that her cyst would recur or that she would get cancer. So she declined hormone therapy. So Dr. Hepzibah, what would you like to give her now?
We have to counsel her because she's not in the family history. There is no breast history. There is no family history of breast disease and other things. And I think the risk for breast cancer is very less when we start with a very low dose of estrogen and progesterone. And we have to counsel her.
Jyoti,
right.
Can I make
so
a point?
You would counsel her. Yeah, tell me, Parag.
Yeah, Jyoti, I think here maybe we can counsel this lady and see if she's if Tibolone is acceptable to her, because it will take care of the libido part also. Of course, we have to ask her to keep a regular follow-up with us, and even now the association of Tibolone and breast cancer is still little controversial. So I think after counseling, we can consider Tibolone as one of the options.
Yeah, I think I agree. I agree completely with you, Parag. Actually, Tibolone probably would be a good option. It's only a breast cyst, and that's not a contraindication. So we just have to probably do a little more detailed risk assessment for breast cancer, rather than just go by the history or her fears and then tell her you don't fall into the high risk category for breast cancer. 1 year post-menopause, mood changes, libido. So a trial of Tibolone, when you choose the MHT, probably a trial of Tibolone for 3 months and you know where you stand.
And Tibolone on subsequent breast assessment will not change the mammographic findings.
Breast density.
Yes.
So she was on venlafaxine for 6 months. She was unhappy for the relief. And so she came back, and then everyone has already talked about how they would like to counsel her again and tell her that because, probably hormones would be the best option, and counsel her about it and talk to her about Tibolone, because Tibolone addresses, because it has an androgenic component also in it, it addresses the mood and libido particularly better than estrogens. And Tibolone also does not alter breast density. So continuing to observe her in terms of her breast density would be easier, whereas estrogen increases breast density. So when she already has dense breasts, it would be difficult to do a follow-up for her. So we've talked about which drug and why. So androgenic action, as I told you, 2.5 milligrams is a single daily dose orally. 1.25 milligrams is equally effective, but that preparation is not available to us here. So benign breast disease is not a contraindication to hormone therapy. The risk of breast cancer attributable to hormone therapy is rare. And women who develop breast cancer while on hormone therapy have better survival rates than those who are not on hormone therapy. But the main thing to remember is benign breast disease per se is not a contraindication to hormone therapy. Now, the next case, we'll just go through the rest quickly, please. 31-year-old, para 3, last childbirth 6 years ago, backache, joint pains, dyspareunia since 1 year, history of a total abdominal hysterectomy for white discharge by a general surgeon in the village 5 years ago. How would you like to investigate her, Parag?
I think here comes the role of FSH level to diagnose that she has premature ovarian failure. Now, I should call it, rather than insufficiency, it may be prudent to call it a premature ovarian failure. And here I would certainly like to assess, even though she's 31-year-old, her bone health as well. So I think this is one of the indications where we would think of doing a BMD in a younger patient, because if she has undergone hysterectomy at a very young age, she is the one who's likely to develop osteoporosis in the future. So these are the two important things I think I will consider.
Right. So though she has had just a hysterectomy and her ovaries have been conserved, we all know that ovarian function declines due to the compromise to the blood supply, and perhaps that's why she's developed problems with her backache and joint pains. So her FSH was 44 and her T-score at the lumbar spine was minus 2.8. Hepzibah, what treatment would you offer this woman? Okay, Meeta, what treatment would you offer her?
Yeah, so there is something that I would like to add, I mean, when you talked about dyspareunia, there's a very simple method of diagnosing when she has dyspareunia. When there is no infection in the vagina, when you examine her, a simple pH also will, kind of help you diagnose that she's going in for premature ovarian insufficiency. Is a very simple clinical tip that we can do. And yes, for her, I mean, I'm very clear in my mind that I would start off with standard dose, not low dose, but standard dose of hormone therapy.
Okay, standard dose of hormone therapy and perhaps an orthopedic opinion for all her joint pains and backache and things. Exercise, calcium and vitamin D would be part of a prescription for every woman at this age. And so we would give her calcium. These women require about 1,000 to 1,200 milligrams of calcium, though she is younger. Because she's had a hysterectomy, we are really concerned about her bone health. Vitamin D is very important because though we live in a land of sunshine, because of the melanin pigment. Probably we are not absorbing as much and we are not out in the sun so often. So that is important to give. Hormone therapy, standard dose, Meeta has already said. Hepzibah, which drug would you like to give this woman? Hepzibah, are you there?
Not audible to me.
No, we can't hear you. Okay, Neelam, could you tell us what drug you would like to give her?
I would like to give her estradiol 1 milligram daily, because here there is no uterus, there is no need to add progesterone. And along with MHT for dyspareunia, I will advise her to use local moisturizers, etc.
Right. So just estrogen therapy is enough, as Dr. Neelam has said, because since she doesn't have a uterus, she's already said, why not EPT? Because the hysterectomy has been done. And now we know that breast cancer risk increases due to progesterone. It's not really only the estrogenic component. The progesterone increases the breast cancer risk. So in women who don't require it to protect the uterus, protect the endometrium, we should not just give her progesterone. What about tibolone? Could we use tibolone, Meeta?
Yeah, we can use tibolone, because actually that would work, also because the ovaries are removed, you don't have the androgens which are coming in for there. So tibolone is also a very good option.
Okay, so tibolone is also an option. Parag, what about bisphosphonates?
I think after considering for her, we would first start with the estrogen therapy, and bisphosphonates would come much later, not at this point of time.
Right. So we could reserve the bisphosphonates for much later, because the estrogen therapy itself will help, or tibolone will help her bone health also.
In fact, estrogen therapy is the best for bone health.
Yeah. So in a woman, estrogen therapy is really the best in terms of increasing bone density as well as decreasing her fracture risk. For how long would you give her estrogen therapy, Dr. Hepzibah? Okay. Meeta, how long would you give her estrogen therapy?
I think there was a question on the chat box, and that's what I've answered. Till the natural age of menopause is what we would like to give her estrogen therapy. And there's another added advantage. It's supposed to also help the collagen. So, so this premature aging and this osteoarthritis also may help if you're starting off much before the damage has been done. So
Right.
it's not just
so
the
it's a good
bone,
idea
but also the
to
collagen.
give her estrogens right up to the natural age of menopause. How would you like to follow her up, Parag?
She's the one who she has to report to us first after 3 months after starting therapy. And we would certainly like to follow her up every year, where we would like to do her ultrasound of the breast, because we are going to put her on hormone therapy for a very long time. And I think 2 years is a good time when we repeat her bone density study in order to see how the hormone therapy is helping her.
Okay. So hormone therapy is the first line therapy for women under the age of 60 with increased risk of fracture. On stopping the hormone therapy, the protective effect declines. And after 60, the hormone therapy is second line and should be based on individual risk or benefit. For premature ovarian insufficiency, there is an increased risk of long-term consequences. So systemic hormone therapy should be offered till the natural age of menopause. In this woman, since she doesn't have a uterus, we would like to give her just estrogens. But in other women, we can give them combined oral contraceptive pills or regular doses of hormone therapy, not low dose, as Meeta has brought out. For her dyspareunia, ospemifene is another drug which can be used. It's a third generation SERM. It has an estrogenic agonistic effect on the vagina and approved for the use in dyspareunia. It increases BMD also, and there's no effect on the breast and endometrium. 60 milligrams daily orally is given, but it does as all SERMs do, increase hot flushes and the DVT risk. The next case is a 51-year-old with complaints of recurrent urinary infection 18 months, has gained 5 kgs in the last 6 months, complains of lethargy and fatigue all the time. What would your provisional diagnosis be, Neelam?
Yeah, this is a postmenopausal woman with the recurrent UTI and query hypothyroid. We have to rule out hypothyroidism because she has had a history of weight gain and lethargy and fatigue. And also we need to investigate what is the cause of her recurrent UTI, means any extra pelvic cause of UTI like renal stones, etc. to assess her risk factor of recurrent UTI.
Jyoti, here we would also like to rule out diabetes because, you know, she's one who's put on weight, who's getting recurrent urinary tract infections. So probably we need to find out her sugars and control them if they're not.
Right. So we will need to, so they've already answered. So we keep all these things in mind, not just look at the woman in terms of her gynec health, but the rest of the things also. So her BMI was 28, no problems with general and systemic examination, vagina was atrophic, investigations, they've already said what they wanted to do. So she's frankly diabetic, urine routine and culture shows no growth. So just because the woman says she has UTI, we should not take it that she has actually had recurrent UTI, because often they just with the symptoms of frequency or dysuria, they'll tell you that it's UTI. So we should not jump to giving antibiotics, because it's important for us to restrict antibiotic use to only those which with culture positivity. Her TSH is 16, as all the panelists had brought out, and uterus is normal size with ET of 4. So the treatment is what, Dr. Srikanthan, what would you like to do for this woman?
This is a wonderful situation to start with metformin. It addresses a number of issues. It addresses her weight issue. It brings down the appetite. It brings down the HbA1c very nicely. And this is also a nice time to do her insulin and C-peptide levels to understand whether she's developing early pancreatic insufficiency, which is less likely in this age group. If her reports of C-peptide and insulin are fine, I would just stick with metformin. We are now moving away from sulfonylureas towards drugs which help in not only lowering sugar, but also address weight gain. So there are good drugs today, such as the gliptins also work very well in this age group and with this profile.
Right. So we need to address all her metabolic issues. And as far as her vaginal problems are concerned, her UTI is concerned, recurrent UTI, it may not be an actual infection, but the genitourinary syndrome of menopause, for which local estrogens can be given, and therapeutic lifestyle management for her weight. And of course, we've talked about a physician reference, treating the hypothyroidism as well as the diabetes. So local estrogen therapy is the most effective option for vaginal atrophy. Vaginal estrogen therapy is recommended when hormone therapy is considered solely for this indication. And vaginal estrogen therapy benefits women with urge incontinence and reduces the risk of recurrent UTI. So in a woman who has only genitourinary symptoms, we need not give her systemic hormonal therapy. We can give her just local estrogen therapy. And diabetes mellitus is not a contraindication for MHT. This woman, of course, doesn't require oral because she has only vaginal symptoms, but otherwise MHT reduces fasting glucose and increases insulin sensitivity, reduces abdominal fat, and actually reduces the development in type 2 diabetes in women who are not yet diabetic. The sixth case is a 44-year-old with complaints of hot flushes and insomnia since 12 months. She had her LMP about 16 months ago. She's had a radical mastectomy for CA breast, completed chemo a year ago. Anupama, do you come across this often in your practice?
We do see this in our practice, but it's not very common.
Right.
Why it's not very common? What I feel the reason is that the patients have so much fear of cancer recurrence and all, that all these other symptoms and other complaints, they are sidelined. So they don't really complain too much about this.
Okay. So they don't complain too much about this, but probably we are seeing a few more than before now, because these women are surviving their therapy now, which they didn't earlier. And as we all know, it's younger women compared to the West who get the
advisory board also is to understand from all you doctors that how do we see Buscopan is now a very
some cross.
Sorry, Mamta.
Yeah, backend team to check, please, Sumit. There is some crosstalk. Ma'am, you can continue, Dr. Jyoti.
Yeah. Okay. So if there's one investigation that we want to do here, Dr. Neelam, what would it be?
That in my mind is FSH.
Okay. So her FSH is 62. And how would you like to manage this woman, Meeta?
For her, we would definitely offer her the non-hormonal management, like venlafaxine is the first choice that we would probably give her, because there are studies have been done on venlafaxine. Yes, it does.
Does receptor status matter in your decision to give her any medication?
Not when you're giving the non-hormonal therapy, but for some reason, like, very few select case, if she's willing and if her oncologist is willing, then if she's receptor negative, you can offer her hormone therapy if the flushes are really bad and or her bone health is very bad.
Can I add one thing?
Yes.
Yeah, I think receptor status will matter. Otherwise, also, even if hormone therapy is not to be decided, even if severe symptoms, because in ER positive cases, the woman would be most of the times on tamoxifen. And if she is on tamoxifen, then some SSRIs like paroxetine, which is actually the only approved drug by FDA for hot flushes in non-hormonal therapy. Paroxetine should not be used in tamoxifen in women, should be avoided in women who are on tamoxifen, as paroxetine usually interferes with the metabolism of tamoxifen and reduces the effectivity of tamoxifen.
Right. So we have to be careful, and if you're choosing to use an SNRI, it would be better to give venlafaxine in women who are on tamoxifen, because they share the enzyme which is used, and so that's why it will reduce the efficacy of tamoxifen. So chemotherapy related amenorrhea or premature ovarian insufficiency depends on the age, drugs and dosage. With the older regimes, in women less than 40, it was 40%, and more than 40, it was 75%. And it was reversible in 40 to 50% below 50 and less than 10% over 40. But with the adriamycin and taxane based regimes, this is, this is much better, with only 30 to 40% developing chemotherapy related. And as we've all said, breast cancer survivors should be given a fair trial with alternative therapies, and consider tibolone or androgen in some women whose quality of life is impaired by estrogen deficiency, and the risk of recurrence should be explained to them. Again, lowest effective dose for shortest duration. Mamta, before we conclude, what about other cancers and hormone therapy, Parag?
Now, extragenital cancers, I mean, like if you're dealing with a woman who gives history of something like Hodgkin's lymphoma, etc., hormone therapies can certainly be offered to these women. But women who've had ovarian, breast, or endometrial cancer, then we would certainly not offer them menopausal hormone therapy as a primary modality.
Yeah, add
Right.
something with
In
Jyoti.
ovarian,
Yeah, actually, even there now there are some very nice articles. You don't have the huge database, but whatever data that we have, there are clear is that you should avoid it in the receptor positive, where there is an estrogen receptor positive tumors, even in the ovarian cancer. So actually high-grade serous, except for those endometrioid, low-grade serous ovarian cancers, you can give it to those other cancers, epithelial cancers. They are not a contraindication, except for the
Right.
glandular cell tumors or the, very few ovarian cancers which are estrogen dependent you're avoiding. But the rest, because we do find ovarian cancers in the younger women, and they should not be denied hormone therapy.
Right. And also with borderline cancers, borderline tumors, you can actually give them hormone therapy. So colon cancer, though the risk is reduced, it's not to be given solely for this indication. If you give it to them for their vasomotor symptoms, it does reduce the risk. Ovary, as we have talked, there is only the ER positive, but borderline you can give. Cervix, there's no contraindication. Mamta, do we have 5 more minutes?
We need to conclude, ma'am.
Okay, all right then. So we'll go on to the last few slides, just to say that basically hormone therapy is the most effective therapy for vasomotor symptoms. We should give the lowest effective dose, but for the duration required. Safety depends largely on the age and time since menopause. Vaginal estrogen is the most effective for urogenital atrophy, and hormone therapy may be used for prevention and treatment of osteoporosis, but should be initiated within 10 years of menopause. Hormone therapy should be offered to women with premature ovarian insufficiency till the natural age of menopause. Now, the revised global consensus has also included tibolone and CEE-BZA, which is the TSEC or the tissue selective estrogen complex, as part of hormone therapy for effectivity for vasomotor symptoms. Breast cancer is rare, and MHT, if initiated early in menopause, has no substantial effect on cognition, but may prevent Alzheimer's in later life. About the TSEC, it's bazidoxifin 20 milligrams with conjugated equine estrogen 0.45 milligrams, not yet available in India, but hopefully will come in soon. So our aim should be to help patients make informed choices, individualize the treatment, and offer them the full range of effective choices, and give them both a behavioral and pharmacological approach. Thank you very much to all the panelists for a very interesting discussion, and thank you to the organizers for inviting all of us.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you,
Thank you to the
Thank
panelists.
you, organizers. Thank you so much.
I thank Dr. Jyoti and
Thank you, Dr. Jyoti.
for the
Thank
nice
you.
panel, very informative and very interesting. And I also congratulate Dr. Jyoti Unni to finish the panel in time. We move on to the next panel of the day. The next panel is on COVID-19 in pregnancy. Moderator for this panel is Dr. Reena Vani. Madam is a professor at HPT Medical College and Dr. R.N. Cooper Hospital, Mumbai. And the co-moderator is Dr. Naina Dalvi. Madam is an additional professor, HPT Medical College and Dr. R.N. Cooper Hospital, Municipal General Hospital, Mumbai. It's a pleasure also to introduce the panelists. Dr. Pushpa Malik, Madam is a professor at Department of Pediatrics and Neonatology, TNMC, BYL Nair Hospital, Mumbai. Dr. Pratnya Chanket, Madam, Assistant Professor, Hospital, Mumbai. Our next panelist is Dr. Dr. Mohan Batul, sir, is Professor and Chairman, Department of Clinical Microbiology and Immunology, Sir Gangaram Hospital, New Delhi. Dr. Pratima Mittal, Madam is Honorary FRCOG from Royal College of UK. She has been former HOD Department of Obs and Gynae, VMMC and Subvision Hospital. Madam has been Vice President of FOXI. Our next panelist is Dr. Narayan Jana. He is a professor in Chittaranjan Seva Sadan College of Obstetrics and Gynecology and Child Health, Kolkata, and Dr. Chinmay Ratha, who is the Director, Resolution of Fetal Medicine Center, Navodaya Hospital, and Senior Consultant, Fetal Medicine and OBT, Yashoda Hospital, Secunderabad. Over to you, Madam, for the panel. Over to you, Dr. Reena.
Yes. Thank you very much for the kind invitation to be here with you all today. It's a pleasure and privilege to be part of the 42nd AOGD conference with a very hot topic for the day, which is COVID in pregnancy. While we are just getting the PowerPoint started, I would like to emphasize that this is a topic for the day because in Mumbai, when we talk about
Can't hear you, Reena.
Dr. Sujata Agarwal, she is also one of the panelists and she is a senior consultant practicing in South Delhi.
Some order in this pandemonium by today's discussion, which is going to be done with our esteemed group of panelists. My co-moderator for the panel is Dr. Naina Dalvi, who is actually a very active member of our team who is working with the COVID ICU in Cooper Hospital, and she is additional professor in anesthesia. So friends, with us two moderators, one a gynecologist, one an anesthesiologist, we have this wonderful group of panelists who have already been introduced. But let me tell you, we have a little bit of heavyweight obstetricians who are from across the country. We have Dr. Pratima Mittal, Dr. Narayan Jana from Kolkata, Chinmay Ratha from Secunderabad, Dr. Sujata Agrawal from private practice in Delhi, and my colleague from Sion Hospital, Dr. Pradnya. But we have a very important contribution from Dr. Chand Wattal, who is going to give us an insight into diagnostics, Dr. Neelam Redkar, who is going to talk about the medical and the ICU management, and Dr. Sushma Malik, last but not the least, who will help us to take that healthy baby home, because the aim of obstetrics is to have a healthy mother and newborn. Friends, there are many, many issues which are going to come up in this discussion. So we are going to try to have focused questions. And if there are any more questions during the thing, we request the audience to put them into the chat box and we will try to answer them. Before we go to the questions, I'd like to share that we are not speaking from internet experience. This is just a little bit of data from our own hospital, which is telling you that we have dealt with many COVID patients, and both Dr. Pradnya Changede and myself have actually been patients of COVID and seen it from the other side. So the first question I would like to ask Pradnya, and then maybe some of the other obstetricians would give input. Pradnya, what is the effect of COVID on pregnancy, and could you tell us trimester-wise?
Till now, it was believed that the pregnant as well as the non-pregnant patient have a similar COVID outcome. But with the recent data coming up, which proves that the pregnant patients are more prone to getting severe COVID infections, they are more prone to being hospitalized, they are more prone to be put on mechanical ventilation. Though the mortality rate is the same in pregnant as well as the non-pregnant, however, pregnant women come in the high risk because they can have very severe COVID infections. If we go trimester-wise, it has been proved that COVID doesn't increase the risk of abortions in the first trimester. The outcome of COVID in the organogenesis will come now, because most of the infections that we have seen have been either in the second or the third trimester. But till now, no congenital anomalies have been proven with COVID. Of course, but in the third trimester, these patients can have preterm labor. There are a lot of studies which have shown that these patients have a lot of preterm labor. But whether it is spontaneous preterm or it is due to us doing cesarean sections. Most of them have been induced preterm, wherein cesarean sections have been done. Also, the data in some studies is showing that there is a lot of, most of them have been delivered by cesarean route. But now it has been proven that you should do cesarean section only for obstetric indication. And COVID per se is not an indication to do cesarean section. So
yes, thank you, Pradnya. But Chinmay, as a fetal medicine specialist, what is your opinion about teratogenesis and fetal effects of COVID? Would you like to add something to what Pradnya has said?
Yes, ma'am. Actually, I agree with what Dr. Pragya has said, that as of now, teratogenicity has not been proved. So we have not asked anybody to discontinue pregnancy because they have contracted COVID in the first trimester or in the periconceptional period. Even the drugs that have been used for that have not been teratogenic. There's no data about it. However, like she just said that we will be seeing the effects in terms of growth restriction, in terms of preterm deliveries, and maybe, I mean, if in due course we find some abnormalities, we'll come to know of that. But so far, nothing. We are not.
Thank you, Chinmay. And Dr. Sujata, being a private practitioner, what do you feel that in your experience, and if you can quote the FOXI guidelines on this, we have a FOXI GCPR which has talked about a role of cesarean in COVID. So if Dr. Sujata or Dr. Narayan could comment on this, what is the impact of COVID on cesarean delivery rates? Should it be affected or not?
Thank you. I think we should not do cesarean only for COVID indication. We should do only for obstetric indication. But if patient is in very severe shape, like she's in ICU and we want her to deliver her quickly so that we can give her full medical treatment, then we can go for cesarean. Otherwise, we can do cesarean for other obstetric indication, not only for COVID.
Dr. Narayan?
Yes, namaskar.
Namaskar.
Could I add 2 points here? When we say the effect of COVID on pregnancy, there are 2 important aspects. One is direct effect of the disease on the mother. Another is indirect effect. Direct effect is the medical aspect of the COVID on pregnancy. That's what we discussed. Another indirect effect, the social aspect, the emotional aspect, psychological aspect, the economic aspect, that in turn affect the obstetric outcome. As for example, the stillbirth. If you see worldwide data, the stillbirth rate has increased during COVID period by about 2 to 3 times. It may not be a direct effect of COVID, but an indirect effect of COVID on the perinatal outcome. So these are the things we cannot ignore, because basically we are not only medical scientists, we are a social scientists as well. So that it is an important aspect. Second important aspect is that preterm labor. Preterm labor has increased. Definitely, almost everywhere the preterm labor has increased. Whether it is spontaneous preterm labor or iatrogenic preterm labor, this has to be dismantled.
Yes. Thank you, sir. Pragya had already mentioned about it. So after these inputs from our experts, I think we should move on to the next question. That for antenatal care, how have you adapted? And maybe we should ask Dr. Pratima Mittal, who has been the Vice President FOXI 2018 and is also working with Government of Health and Family Welfare. Can you, madam, give us some input into how antenatal care has been adapted?
Hello, Reena. Thank you very much for asking me this question, and thank you for making me part of this panel. Actually, initially there are 2 things which we have to consider: the number of visits and the type of visits. Quality of the visits, what all should be done. If you look at the number of visits, initially we were saying 4 visits and 8 visits. WHO was recommending 8 visits because of the perinatal mortality and morbidity. But in COVID area, it was mainly that only initial stages we were saying only contacts, telemedicine type of contact, and only if it is really needed, then only the patient should come to the hospital. And the antenatal visits were late, and if the patient has had COVID, then it should not be visiting the hospital at least for 15 days after she contracts COVID. Now the recent guidelines of RCOG and that is of October 14, they clearly says that the visits should not be delayed because of visits. These visits, we have got an increased number of stillbirths in all over the world. Most of the places the stillbirth rate has increased. So now they are saying that the visits should be as planned, and it should be only delayed if patient is having any no complaint and no examination has to be done. Only in those cases it should be delayed and can be done on telephone by telemedicine. But otherwise, patient should be told everything about it, and whenever she needs any help, she has to be assessed for psychologically also, whether she really needs a help or not, and then she should be visiting as following all the protocols in the OPD, that is keeping the distance, hand hygiene, and all these universal precautions should be kept in mind. But otherwise,
thank you very much, madam. And I think FOGSI guidelines, also the GCPR has also mentioned that visits as required should be done. I would hand over to my colleague, Dr. Naina, to carry the questions forward. Naina.
Yeah. My next question is for Dr. Pradnya. She is managing one of the heaviest ANC OPDs in Mumbai. So Pradnya, what is your standard questionnaire for these patients? So if you are in your COVID pandemic, what questions you have added in your questionnaire to see whether the patient is likely to have COVID?
So first of all, we ask the patient for any symptoms of COVID. So which is fever, cough, myalgia, breathlessness. We also, secondly, we ask her for any history of exposure to COVID either in the family or in the locality. We also see whether there is any history of travel to any endemic area, or there is a history of her coming from an area which is a hotspot. Like in the BMC has devised red zone, green zone. So if she comes from a hotspot, if she has a travel positive history, or she's symptomatic, then definitely we need to screen these patients and separate them and do a swab test or an antigen test at the earliest, so that we can avoid infection to the other patients as well as the doctors.
Yes.
Naina, maybe we should also ask Dr. Neelam Redkar, who's from medicine department. Are there any questions which you feel we should add to our patients? Because it has been suggested that triaging of pregnant patients depends on comorbidities. So Neelam, would you like to give your inputs on this?
Thank you, Reena, for this important question. Basically, comorbidity play a very adverse role as long as management of COVID patients are concerned. COVID per se does not cause any adverse outcome in this patient, but those who have pregnancy-induced hypertension, gestational diabetes, who have underlying respiratory diseases, these all patients should be screened actually for the COVID-19 infection, and so that we can manage them at the earliest.
Would you also suggest adding any tests to our antenatal usual basic test outline? Do you think there is anything we should add? Because we are usually hesitant to do imaging in pregnancy. So do you feel that something needs to be added to the routine antenatal thing, or we restrict it only to selected patients?
I think we should restrict it only to selective patients, because there will be definitely risk of exposure, either radiation exposure, either it CT scan or X-ray scanning. But yes, if the patient has some respiratory tract complaints, has dyspnea, definitely we should not be scared of these investigations, because the risk of radiation is very low, and those investigations are going to determine the future line of treatment. So it indicated.
Thank you very much for those inputs. Yes.
So Dr. Chand is there with us. He's a microbiologist. So I would like to ask him, would you test each and every patient who walks in ANC OPD? And what will be the correct time to test them? And do we need to repeat the testing then at regular intervals?
Thank you, madam. Thanks for asking this question and getting me here. Well, I would not actually encourage testing each and every person or every lady walking in for ANC in the first trimester at least, or even in the second trimester. because if they are asymptomatic, we usually do not bother unless you have some other reasons to bother, as an exposure or things like that. If she is herself asymptomatic and has had not had any contact with any of the known positive cases in the family or around, probably I would not recommend that you go in for a testing right away. And now if we say that, okay, fine, she is asymptomatic or she has had a contact, so let us take them one by one. If she is symptomatic, then symptomatics can be tested right away or within 2 days of their illness. And if they have got actually exposed to any person who is a known COVID positive within 5 days of the symptoms of that patient, she should get tested. So basically we go 3 days before and 5 days after symptoms. So anytime between 3 and these 5 days means 8 days before, 3 days and 5 days later, you may choose the timing for testing, because that's the best time when the RT-PCRs you do. I would not recommend the antigen tests actually in the hospital settings or in the antenatal care where the COVID may have some implications, though we will know as we progress in the panel as to what the implications are. But I would certainly bet on the RT-PCR for you to use.
So, sir, I would just like to share with you, this is just a graph of data from our hospital. There has been a lot of change in the ICMR guidelines, which we all tend to follow across the country. And when version 5 came, it did not specify about pregnant women testing, but you can see the graph. One good thing is that the graph is showing a declining trend. And we are catering to a hotspot and other districts, although our number of deliveries has not changed. But it is still hard to say whether COVID is really going to be on the decline or not. And this is just a screenshot of the latest ICMR guideline, which came across on 4th September, after which they have not updated it. And as sir has very nicely pointed out, that we need to go. Sir, what is your opinion about rapid antigen test versus the RT-PCR? Because there's a lot of confusion between these two. And what is the turnaround time for these tests in your settings?
You see, the two cannot be compared. The rapid antigen test, that is the RAT test, is classically for the epidemiological settings or in the hotspot areas. I again say what I said earlier, that in the hospital settings, we do not recommend anything other than RT-PCR, because you will not be able to control the spread in your own healthcare facility to the healthcare workers. So that's a very important responsibility of all of us, that you keep your facility at least without any super spreaders as asymptomatic carriers. So I would put all my money on RT-PCR. That's what we do at Gangaram now. And rapid antigen tests, whatever the graphics that you may be showing over here, I would not go with this right away, unless there is a tearing hurry and you do not want to do a CBNAT assay. That's the rapid test that we have, which is RT-PCR based by way of a GeneXpert or a TrueNat. You want still to do this antigen test, you have to be very circumspect, because the positivity is extremely low. We have seen it in our settings as well. When we would report in hospital based settings, 20%, 15%, 8%, 9%, rapid antigen test would be hardly 1% or 2%. So that would actually put us on guard as to, are we really picking up cases? So that's the reason I said that we shifted to RT-PCR totally for the population getting into the hospitals.
Yes, sir. Thank you very much, because both Dr. Neelam Redkar and Dr. Naina Dalvi and we are working as a team in Cooper, and we have found that we are doing both together, and we find there's often a mismatch where rapid antigen comes negative, but later on the RT-PCR comes positive, which becomes a problem. So in hospital-based settings, when you have RT-PCR, the important message you are giving us that for pregnancy, we have to keep that as the gold standard.
Absolutely.
Yes, Naina.
Reena, can I add something?
Yes.
Reena, can I add something?
Yes, ma'am.
Yeah. Yes, actually, I was part of this, testing strategy when it was being made of ICMR committee, and it is very, very clear that for all patients who are coming to the hospital for delivery or admission, all those patients should be tested. And in that, it was very clearly stated that, and it should be highlighted to all our obstetricians, that on the basis of they're not able to test or test not being done, they should not deny any emergency care, first thing. And second thing is the referral should not be made on the basis of that RT-PCR test has not been done, cannot be done. So for admission, if the referrals cannot be made and this emergency services cannot be deferred, and you have to get for all the hospital patients, all the patients who are being admitted.
Thank you, madam. This is actually a very important point, because often we have found patients have sometimes been turned away, and once in a while patients have delivered on the way in the ambulance or otherwise, because they were going from hospital to hospital. So thank you for highlighting that the guidelines clearly specify that we should not be turning away patients for that. Could we have, Naina, would you like to?
Yeah. Actually, when we have both the tests available, like in our institute, why we do both the tests together is when in emergency patient comes, rapid antigen comes positive, then immediately within 1 hour we can isolate those patients and shift them to COVID positive ward, or if needed ICU. So that's the one advantage of doing rapid antigen along with RT-PCR. So I feel wherever it is available, I think we should send both the swabs simultaneously, what we are doing routinely, where we have large volume and we can do CBNAT in our institute around the clock. And then if it doesn't come negative, definitely we wait for the RT-PCR report.
Okay, great. Would any of the panelists like to respond to this? This is the very important question, that you have a pregnant patient who has come positive. Now the big $1 million question is that, can she do a stay at home, or should she be hospitalized? What is to be done?
Can I take this question, please?
Yes, please.
Okay. So it depends upon whether the patient is symptomatic or she is asymptomatic. If she is asymptomatic, we should assure her properly that please be at home quarantine. We'll guide her on phone. We'll ask her to keep an eye over her fetal movements, take daily temperatures. We'll give her a pulse oximeter to check her oxygen. And if it is less than 94, that is 93, then she should report us. We'll ask her to keep an eye over her respiratory movement, and we'll teach her how to do it. And we'll give her oral chloroquine 200 milligrams thrice a day, and along with azithromycin 500 milligrams daily. And we should give her heavy doses of vitamin C, multivitamins, vitamin D3, and we should reassure her she should have a separate toilet if there is, like she has a toilet in her. Many times the house is so small. Whenever she's moving around, she's opening the door, she should use a mask, and whatever surface she's touching, she should sanitize it with anti-sanitizers. If the patient is symptomatic, like if she's having high grade fever, or there is some other problem like diminished fetal movements or bleeding or some obstetric indications, or her oxygen saturation is less than 93, or she's having tachypnea, tachycardia, or X-ray or auscultation, or CTs showing lungs are involved, or there is history of thromboembolism where she needs Klaxin, then we should admit her, and it should be a multidisciplinary approach. We should consult a physician also. And that
Dr. Sujata, yeah, thank you for pointing out what, and she has actually highlighted the issues which have been discussed in both ICMR and FOXI guidelines. But Chinmay, you are a fetal medicine and ultrasound specialist. Normally the gynecologists need ultrasound very regularly. So how has COVID changed our policy for doing scans? Because we are finding it is very difficult to sometimes get a sonography done because of the COVID time. So what is your input on that, and what is the practical experience as a sonologist you have to do?
Ma'am, what we have done in this case is that if it is an emergency, if the scan has to be done because the woman is unwell and they are suspecting that the fetus is unwell and needs to be delivered, that has to be offered. So in that case, the sonographer dons a PPE and takes all precautions for self-protection, and covers the equipment with, just like we cover it during procedures, we cover the equipment and do the scan. However, if it is a routine scan, for example, she is supposed to have an NT scan and she has contracted COVID in that period and has been advised isolation, then we tell them not to. And can still be solved by structural assessment at a later date. And now there are many other methods of doing aneuploidy assessment also. So we have deferred the ones which are elective scans in a woman who is been advised isolation. Once the isolation period is over, we have scheduled the scan and just reorganized her fetal care thereafter, caught on from whatever we have missed. So it's not difficult to do that. And the guidelines were very clear that we didn't have to deny them in case they had to come for treatment. But if we had an option, we rescheduled that.
So thank you, Chinmay, for highlighting the role and the judicious use of ultrasound and emergency use of ultrasound. It was mentioned about hydroxychloroquine. So can we have any of the medical experts or people dealing with COVID? Because there has been a lot of controversy, and maybe Dr. Mittal, who has been with ICMR, there's been a lot of flip-flop on the role of hydroxychloroquine and azithromycin in treatment of asymptomatic or mildly symptomatic patients in pregnancy. So can the panelists just highlight this for our audience?
Yeah, Reena, in our institution, we do not allow, I mean, we are not giving hydroxychloroquine at all at the moment because the role is very, very controversial, and even ICMR is or not advocating it. As far as the azithromycin is concerned, we are only giving to symptomatic patients. If a patient is asymptomatic, no role of azithromycin. Only if the patient has cough and, then in those cases only we are starting azithromycin. Otherwise, no hydroxychloroquine, no azithromycin.
Madam, I would like to just mention that the Municipal Corporation of Greater Mumbai had, in fact, initially in the COVID lockdown, distributed free hydroxychloroquine to all the gynec departments, and we had all taken it, including myself. I have taken it for 6 to 8 weeks.
It was in the initial phases.
Madam, all of us had taken for 8 weeks.
Yes.
Hydroxychloroquine.
Can we have the medical expert, Dr. Neelam? Can you give us some input on what are you believing and what are you following for hydroxychloroquine and azithromycin in pregnant women? What is your take on this issue?
I agree with Dr. Pratima that I am not using hydroxychloroquine along with azithromycin because it has a lot of side effects. Both the drugs aggravate gastritis, plus both the drugs taken together can can cause prolonged QT interval. We are just giving azithromycin to mildly symptomatic patients and monitoring them for other complications in case they develop. Otherwise, most of our patients are doing well with azithromycin also.
Okay, thank you very much.
Madam, I would like to point out WHO has done a solidarity trial and they released the interim report in which they actually stopped that arm of hydroxychloroquine because they didn't find it to be effective. So they have actually closed down that arm and they have realized that it is actually not, either decreasing the 28-day mortality rate or the in-hospital prognosis. So it is not changing. Thank you.
Dr. Vani,
yes, Dr. Jana, you wanted to say something. Yes.
Dr. Vani, I am also worried about the therapy for malaria now and the atypical pneumonia. You use antimalarials and azithro like water these days. I am really worried about those areas where we are actually using them. So we need to be very circumspect.
So, Dr. Jana, it has actually been said that COVID has actually improved the TB control and maybe perhaps the malaria control because we have used the prophylactic drugs and we are using masks. So we don't know, maybe these issues may also be addressed, but I would like input of our expert panelists. Now we have talked about asymptomatic, mildly symptomatic pregnant women. So how do you triage and decide that if the patient is not in labor, when do you admit her? And the second question is that if we've already talked about effect on pregnancy, what is the effect on labor outcome? So can we have any suggestions from our panelists? When should you decide that now this patient needs to be in the hospital? When she's not in labor, but she's COVID positive. Yes.
Reena, can I answer?
Yes, please. Yes.
Yeah. Most of the patients are asymptomatic, but the patients who have underlying comorbid conditions like uncontrolled pregnancy-induced hypertension, or they have high sugar due to gestational diabetes, although they may not be having severe COVID symptoms, but they should be admitted. Plus,
yes,
the patients who have COVID-19 infection, who are tachypneic, they have high-grade fever for more than 3 days. They have bicytopenia or all cell lines suppressed, respiratory rate is more than 20 minutes per minute, 6-minute walk test is positive, they are feeling breathless. All such patients should be admitted and observed for further complications. And in fact, such patients may require ICU if their oxygen saturation is less than 92% and they are hypotensive, have tachycardia. These may be the signs of early cytokine storm syndrome. So these are the patients who will require admission. and they should be monitored very carefully.
Yes, thank you. And I think Naina and you are the ones managing the COVID ICU. So Naina, maybe you can highlight what is the vigilance signs that, and Neelam mentioned something about cytokine storm. So what would we like to look for in these patients?
Luckily, as we are working as a team in Cooper, and we have realized that in last 7 months, we have not got any patient admitted in ICU. So that has been really a good news. But when saturation starts dropping, they become hypotensive, become breathless, 6-minute walk test come positive, then we shift them to ICU. And in ICU, then we need to start them on higher antibiotics, and along with azithromycin, we probably step up to zone. We start low dose steroid along with that. We need to give Lasix and then monitor their breathing, because what happens many a times, hypoxia is the main problem. So we need to give them oxygen therapy with simple mask. If not, then we have to give high oxygen, sometimes with HFNC, sometimes with BiPAP. And if not, then we have to intubate these patients and put them on controlled ventilation.
So what are the signs of deterioration which we as obstetricians should look for, and decide that this patient cannot be managed by us anymore? So I think you all have already highlighted this, so I think we will not repeat this.
Yeah.
But yes, would you like to go ahead, Naina, with this?
Yes. So basically, in a labor ward, we always advise that you please keep checking their saturation. That is very important, because many a times we call it happy hypoxia. They become hypoxic, but we don't come to know because they don't become breathless. Or otherwise, many a times we attribute that breathlessness to the pregnancy, normal pregnancy. So we don't realize. So we need to monitor the saturation. X-ray, yes, if they are breathless, as Neelam madam rightly said, that we should not hesitate in doing the X-ray test, because that will give a clear picture of early ARDS, and we can definitely act on it fast.
Okay, thank you. And both Neelam and Naina have highlighted this happy hypoxia. And what are the FOXI guidelines? If maybe Sujata or could highlight that, or Pratima ji, aap bata sakte ho, for intrapartum care. What are the guidelines?
Intrapartum care is same as that of a other patient. Only thing is that here we use continuous CTG. That is important, because these patients are more likely to go into fetal distress. Secondly, oxygen saturation, which doctor earlier also mentioned, that oxygen saturation has to be early. We should look for oxygen saturation. Besides that, most of the things are same as that for a non-COVID patient.
Could I add here?
Yes, Dr. Jana. Yes.
Yeah, I think it is ideal to have continuous CTG monitoring.
Yes.
But in a resource constant setting, particularly a government hospital, say in our institution, which is a medical college, we have 4 cardiotocograph. We cannot afford to put continuous CTG in this situation. Then we have nothing but left with intermittent auscultation. And there are a few points one must follow. Stethoscope is out. Here, the monitoring should always be by fetal Doppler, Dopto, not fetal Doppler, with digital display, which is must. And maintain functional distance, not physical distance. Functional distance means once you are monitoring the mother, your face will be away from the mother's face, so that the physical and functional distance is more than what is the standard distance. And third thing is always treat labor room as an OT complex like things. Or that means in this situation, full PP is mandatory, because the mothers are yelling with pain and they are generating lot of aerosols. So these are the 3 points I want to add to. And partogram should be as before. That means as it is done in any other non-COVID condition.
Yes, sir. Thank you very much. And this, I must say that we are insisting on full PPE for our residents and nurses in the labor room for the points which sir has mentioned. And one more point I would like to add is that 95 is the golden figure. Unlike in other cases where you might think in the labor room, the saturation should be 95 or more. And sometimes we may have to apply a vacuum or forceps if the woman is exhausted and cannot push. So now this is just a picture of the orders chart from, in fact, from our own hospital, where there is an entire list of drugs which are from antiviral to anticoagulants. So could we have a little bit of clarification? Dr. Neelam has already mentioned that, and there's a lot of controversy that why do people give antibiotics when COVID is a viral infection? So can we have some input on this? And the second would be on steroids. Yes, please. Neelam?
Yeah. Basically, antibiotics, although it is a viral infection, ideally we should not be giving antibiotics, but azithromycin may take care of other, if at all there is any bacterial infection or so. And as long as steroids are concerned, steroids are indicated only when the patient is requiring oxygen. They are not to be given to patients who are mildly symptomatic, those who are moderate to severe patients who are requiring oxygen or any form of oxygen therapy. These are the patients who will require steroids. And if patient has gestational diabetes or diabetes, we have to see to it that we have to give steroids judiciously, otherwise sugars will go haywire. And as long as other antivirals are concerned, Fabiflu is teratogenic. It is contraindicated in pregnancy with COVID. However, if patient is having moderate to severe infection, remdesivir can be given, but there are no trials of remdesivir in COVID-19 infection in pregnant women. But this drug has been already tried in Ebola virus infection in pregnant women and was found to be effective. So in certain cases where we don't have any choice and patient is very hypoxic, remdesivir can be given. Only a problem with remdesivir is that it can cause rise in liver enzymes. So one needs to monitor these liver enzymes properly. And if there is rise in the liver enzymes, we may have to stop this drug. Otherwise, whatever published data on use of remdesivir in pregnant patient is there. From American Journal of Obstetrics and Gynecology, they have found good results and the patients have recovered. So
thank you, Neelam. Yes, and remdesivir has been used in Cooper, in Sion, and in Nair Hospital. But another drug which is commonly being prescribed or was being prescribed is Tamiflu and ivermectin. So can you just specify about these two drugs in pregnant women also, and what is the current opinion on these two drugs? Tamiflu, which was used for swine flu, 75 milligram twice a day for 5 days, and ivermectin 12 milligram daily orally. So should we use them in our pregnant women, and if so, at what level?
See, earlier Tamiflu is definitely very safe in pregnancy, but earlier we didn't have Fabiflu or Favipiravir, so we had used this drug. But I don't think there is any advantage of using oseltamivir now. If at all we can use remdesivir, and ivermectin should be avoided in pregnant patients. I think rest all we can continue depending upon what patients has.
Reena, just one. I want to say. Actually, in the antenatal care, we have forgot to talk about in vaccination. Now we are advocating even RCOG guidelines of this October 14 are clearly saying that all pregnant women should be vaccinated with influenza vaccine.
Okay, so that thank you, madam, for pointing out that. And before we actually go to the other important aspect of the neonate, I would just like to briefly mention that everything from A to Z, including Ayurveda, homeopathy, has been tried in COVID. And frankly, we don't know what exactly will work. It is the clinician's judgment based on the various aspects. Dr. Sushma Malik, we are sorry we have not been able to focus on you, but these are two very important questions which we would like to direct to you now. That what is your opinion on the delivery time transfer? And you have actually recently been felicitated for the huge amount of work that was done by you at Nair, which is a COVID Care Center. And we congratulate you, madam, on that. And can you just give us your input and perhaps also give us a incidence of what is the transmission which you have noticed in your patients? Please go ahead.
Thank you, Reena. At the outset, I would like to thank both the AOGD as well as Reena to give me this chance to talk over here. Maybe I should first start for the audience that they should know that I'm working in the one and only the first COVID dedicated hospital, that is TNMC and BYL Nair Hospital, which was made as a COVID only hospital with only COVID positive mothers delivering. And to date, till today, from 19th April, when we were, announced as a COVID dedicated hospital, we've had 730 deliveries, successful deliveries. And amongst these, since you asked me how many children or the neonates have become positive, it's been 37. Now, this 37 positivity doesn't mean that they have got transmitted from the mother. We are being very frank that initially we got much higher rates. Perhaps the viral load in the labor room with less of staff, less of healthcare workers, we did get, quite a few positive, and now we are seeing very less. So amongst the 730, there were 729 live births, excluding, and we've had 10 pairs of twins, 1 triplet set, and all these babies that were born and have been positive, fortunately none of them was serious enough to get any other treatment. So out of the 37, 34 had no symptoms at all, and 3 had very mild, where we just gave them symptomatic treatment and nothing really had to be done. So really the transmission is not occurring at the delivery time. There have been no reports, which say, except for one report from Pune, which said that, it has been transmitted vertically. All over the world, there have been only 2 or 3 anecdotal reports which have said so that maybe the transmission is vertically. So far there hasn't been any vertical transmission. It's been horizontal transmission. That's what is about, the delivery. Does the mother to child transmission occur around the delivery time? Now to, yes, Reena?
And thank you. That's a very important message you have given. And in Cooper, we have had actually less than 1% transmission. Of course, we are not a COVID care center. So we have had so far only 3 babies positive. So we absolutely agree with madam that the transmission is very low. But the second question, which is very important, about when to clamp the cord and should we allow skin to skin contact at birth? So what should we do about this? Because this is a question a lot of private practitioners also ask us.
Yeah, so right from day one, we were very clear even at our hospital that we followed the WHO and the UNICEF guidelines. Initially, the guidelines that came by the AAP said that you need to separate the mothers. But we from day one at our center decided that we are going to follow to the T on WHO guidelines, which clearly told us that we must continue with the delayed cord clamping, as well as we should do skin to skin care. Now about the delayed cord clamping, we need to give this advantage specifically for all newborns who otherwise have no contraindication for a delayed cord clamping. That is more than 1 second, 1 minute of delayed cord clamping. It specifically helps, in the preterm babies, as it reduces the incidence of NEC, it reduces the incidence of brain hemorrhages, it decreases the mortality, both the morbidity also, and there is, so these advantages must be kept in mind, and delayed cord clamping must be done unless it is contraindicated for the baby. For example, if the baby has not cried or there is a contraindication from the mother's side, she is bleeding and she has a placenta, she's like bleeding away, antepartum hemorrhage is there. So in those cases, we do not do the delayed cord clamping, which is the usual contraindication for delayed cord clamping, and it's not specific only for COVID negative.
Okay, madam. And what about this rooming in? Because
Skin,
this is,
just to finish, even on the skin to skin care, we are at Nair very diligently following. Of course, nothing was easy to come, as staffs and the healthcare workers were not really willing for all this. And they kept saying it will spread from the mother. The precautions have to be taken, and skin to skin care has to be done to establish good breastfeeding, and it's less stressful for the mother, and the other advantages are easily seen. Regarding rooming in, again, the principle given by WHO was very clear that rooming in, especially in municipal corporation hospitals, where we don't have facilities for having private rooms with private, dedicated staffs and all, we were really short on everything. And so we continued our rooming in, as well as, bedding in, with the policy of what is called as zero separation, so that both the mother and the baby could get the advantages. So this can be followed provided mother is taking respiratory and hand hygiene, as well as cleaning of the surfaces.
Yes, thank you, Sushma ji. This is actually a very important message, which even RCOG guidelines have actually, being a resource poor country relatively, even a resource rich organization like RCOG is also supporting the same statements which madam has just made. And about breast milk being blamed for virus transmission, what is the data or the evidence on this?
Again, there are really no studies, and despite so many studies occurring, even if the virus has been detected, it is just the detection of viral RNA. It doesn't mean that this is a viable virus in it, and it doesn't mean that, this is the infective virus. In fact, the breast milk has the antibodies, the secretory IgAs, all which is going to protect the baby from the COVID infection, provided we follow the strict 3 principles of breastfeeding, which we've been doing at our institute. That is exclusive breastfeeding, wearing a mask, they must wear a mask. That is, if we can give them the medical
yes,
mask,
madam, that is the basic things, and any other points we should
and hand washing, as well as cleaning of surfaces. That's what, and they can continue breastfeeding. If the mother is, do you want me to tell more on the mother?
And I would like to ask actually Pradnya Shangede a question related to breast milk, since she is also a certified lactation consultant. Pradnya, you are also, and Sion is the hospital which had the first human milk bank. So Pradnya, would you like to give some inputs regarding breast milk and what is the role of the milk bank in COVID pregnancies? Pradnya?
So I definitely agree with what Sushma Malik madam said, that we practice rooming in and breastfeeding for all the COVID positive mothers. Until now, we have not got any baby which is seriously infected or transmission has occurred through breast milk. What we advise is, unless the mother is very severely ill that she cannot breastfeed, then we advise direct breastfeeding with all the measures taken, infection control measures. Only if she is very seriously unwell to directly breastfeed, then also we recommend that she gives her express breast milk to the baby, following all the infection control programs.
May I just add over here that if the mother is slightly ill, definitely she can express, and we prefer hand expression rather than giving them dedicated hand pumps. We were short of everything. So the expressed milk can be done by hand expression. Just take the precautions. And if the mother was seriously ill, was in the ICU, I obviously cannot expect her to express. There is where the role of, even we at our center have the human milk bank, and which was of course shut down for collections, but dispensing was still going on from the reserves that we had. So we gave such babies who were born to the critically ill mothers, or when the mother was not having enough to a preterm baby, we gave them the pasteurized donor human milk. And that's what we did, and we were successful, and we are still continuing with that.
So thank you both, our expert lactation consultants. And now this is a question which I feel that maybe we should, my co-moderator, Dr. Naina Dalvi, would you like to go ahead with this? Because you are the expert in managing the ICU patients. Naina?
Yeah, we are managing COVID ICU. So in our ICU for all our patients, we are using low molecular weight heparin because in ICU we have all moderate to severe patients. I think Dr. Neelam madam also can add to this. In pregnancy, in pregnant females, what thromboprophylaxis should be given? I think I would like to ask Dr. Neelam about this, and which one we prefer, and when we give aspirin, when we give Clexane, when we give plain heparin.
Unfractionated heparin 5,000 8-hourly or 12-hourly has also been written in the order sometimes. And so how do we monitor is also a common question asked by the obstetrician. So Neelam, would you like to just elaborate on this, and how do you choose between these two, low molecular weight or unfractionated?
Basically, pregnancy itself is a hypercoagulable state, and COVID infection also causes it. There is COVID infection associated coagulopathy. So there are guidelines that all pregnant patients with COVID-19 infection who are hospitalized and have hypoxia should receive thromboprophylaxis. The choice low molecular weight heparin should be preferred over unfractionated heparin because they have less bleeding problem. But in case it is not available, even our conventional heparin will do. If we are giving it as a prophylaxis, unfractionated heparin is given 12 hourly, and low molecular weight heparin is given once in a day. And if you are giving it for the treatment, like any patient who has pulmonary embolism or any other obvious evidence of thrombosis, then we have to give proper therapeutic dose. Patients who are on heparin, conventional heparin, we need to monitor their APTT, because and that APTT should be in a therapeutic range. If it is more, we have to decrease the dose, and if it is more, patient may have bleeding complications.
And Neelam, one question which is often asked by the gynecologist, we get 0.4 and 0.6 of low molecular weight heparin. And how do we decide the dose in a pregnant woman? Because most of them are going to be 50 kg plus with the baby. So is there any guideline or how?
If the patient is 50 kg, 0.6 mg subcut OD is okay. If the patient is underweight, then we need to give 0.4 mg subcut OD. And one more important thing is D-dimer may not be very helpful in deciding about thromboprophylaxis, because in pregnancy itself, D-dimer may be high, and depending upon the trimester in which patient is, there are various reference ranges that are available. So D-dimer should not decide our whether we need to give thromboprophylaxis or no. But any patient, pregnant patient who has hypoxia, we have to start thromboprophylaxis irrespective of the D-dimer level.
Thank you, Neelam. And aspirin is used by gynecologists in severe preeclampsia and other conditions. So can we have one of the obstetricians mention that have they, what is their thought on using aspirin for thromboprophylaxis in COVID positive patient who is far from term or in the postpartum period? Can we have any of the obstetricians comment on this, please? Yes, go ahead.
Reena, actually
yes,
in our hospital, in our hospital, after all the deliveries, vaginal delivery or cesarean, we are giving prophylactic enoxaparin to all the patients, 0.6 milligrams subcutaneously. But as far as aspirin is concerned, we are not using it because, it has been seen that if it may lead to increased chances of bleeding during during delivery. So we are not using aspirin at the moment.
Okay, thank you, madam. And we've already discussed antivirals in pregnancy, so I think we can skip this question. And we've already talked about the postpartum care. Thank you, Dr. Sushma Malik, for giving us the wonderful details. And this is a part of the guidelines which was developed by Dr. Malik along with the other heads of departments from various neonatology departments of municipal corporation. One more question for you, Dr. Malik. That should the baby be tested, and how do you go about it? Because if the COVID positive woman has delivered, this is a question, and this is important in private practice also. The practitioners who have had to deliver want to know the testing protocol for babies. So can you elaborate, please?
Yeah. So initially when the pandemic started, there were conflicting reports, various protocols were being put up. So initially we also at our center followed the NNF Kerala guidelines, which said that you should do the first test after 24 hours of birth and then do the second test after 72 hours. And then came the FOXI and the NNF and the IAP guidelines or the guidance, which was given together, which has again been repeated, and the same with more modifications. And the same thing they told us that, I mean, both the versions were the same. That is, you should test the babies immediately after birth. And that's what we have been doing. So we do collect immediately after birth. Now, even if the mother is not known to be positive, still we are doing, once we get the mother's report, then we do as soon as we get the mother's report. Otherwise, we don't do. And if we get an outborn baby, with a mother who was positive, so when she gets admitted with us, then we do for that baby also. So the guidance as of now is that do the first test immediately after birth. And then,
thank you, madam. This is actually very important because there's a lot of confusion about this. So that is the important message. And about repeating tests,
yes.
Do we repeat or do we not repeat?
No, so again, there is a difference in various protocols, but we are following the FOXI and the NNF and IAP guidelines. So that tells us that if the first test was negative, and this was what the consensus we took at our MCGM hospitals, taking into constraint of what all we have and how much manpower and testing ability we have. So the first test, if it was negative, and if the baby is asymptomatic, you don't have to repeat any test. If the baby is symptomatic and develops symptoms, which are COVID, which cannot be explained by a non-COVID condition, then as soon as this baby develops symptoms, then we repeat again a second test, irrespective of the first.
And maybe Dr. Vattal can also give us some input, because is there any difference in the test positivity or the protocols you use in diagnostics, sir, for in microbiology? Is there any difference in the tests for babies, or are we following same protocols, or is there any change? Yes, sir.
Not really. There are no change in protocols. It's the same test. That's the RT-PCR which is being used, and in the hospital settings, as I said, only the antigen test. If you want to do for any other reason that the RT-PCR is not available, then you try and do that. And then very rightly said that do it as quickly as possible once the baby is born of a COVID positive mother, because there are a few stray reports that if you look at some of the perinatology, American Journal of Perinatology in 2020 June, where they have said that within 16 hours, a baby of delivery was positive with RT-PCR. But that was again $1 million question whether it was a vertical. So the heading of that article was possible vertical transmission. And then the other, Lancet March 20 also said that probably the various fluid samples that were collected, including the breast milk, could not show the presence of the virus over there. So whatever the guidelines you people have framed are absolutely spec clean and are absolutely to be followed, because breastfeeding cannot be denied, roaming in cannot be denied on the basis of COVID.
Sir, and just for our audience, when we are doing a test on breast milk sample or cord blood, is there a difference in the testing modality, or is it again the same test for?
No. This is off-label. Whatever testing we are doing, I am talking of the scientific paper.
That's right.
Yes.
I'm talking of the scientific paper that came from China, Wuhan, in Lancet March 20, where they have tested various samples by culture, and they have found that these samples were not growing the virus. So that is the information that we certainly need to know, and not much change in the literature has happened up till now. Maybe in due course of time, you may get more knowledge.
Yes, sir. Thank you very much for clarifying. So right now, we are still looking at RT-PCR as the gold standard, whether it is for neonate or otherwise. And Madam has already talked beautifully about kangaroo mother care and that it can be practiced. And this is a photograph she has shared from her own hospital, saying that for low birth weight babies, it is to be done. Now we are reaching the end of our time. So now we need to, before we discharge ourselves from the panel, we need to know when to discharge the COVID positive cases. So can we have inputs from our experts regarding this? When should the patient be sent home? once you have finished with the treatment and the delivery.
So can I answer?
Yes, please.
So it depends on the patient was symptomatic or asymptomatic. If the patient was symptomatic, day 10 of the symptoms, you can discharge her. And if the patient was asymptomatic, then when she was diagnosed as COVID positive, from that day you take as day 10. Or if the patient is having no symptoms for the last 3 days in asymptomatic patients. So in those cases, we can discharge the patient.
Yes.
Otherwise, all regulatory, as for normal pregnancy, I mean, after cesarean or whatever the protocol you follow, you have to do that.
So, madam, here, in fact, the similar issues were followed for mother and baby. And I would like to just mention that we had to modify our discharge criteria because our wards were overflowing. So we have level 2 COVID care facilities. So sometimes we had to send them home there. So this is just the summary slides of what our experts have wonderfully portrayed. Before we come to the end, where we will ask the experts to give one take-home message from each panelist. This is just a summary of the WHO guidelines, which has been discussed beautifully by our panelists already. One important point which we hadn't yet discussed, people have talked about negative pressure rooms, single occupancy, and what PPE should be worn. So can we have just a brief comment on this from one of the panelists, or maybe Naina, because you are on the Hospital Infection Control Committee and you have actually done a lot of work on this. Could you just highlight what should be done for this issue?
Yes. Now most of us are working in public hospitals where number matters and we have a lot of workload. So having a negative pressure room is next to impossible. We really do not have any negative pressure rooms because we didn't have that much time and that much space to create those kind of facilities. And even single occupancy room is also a luxury in our hospitals. So basically whatever setup is available and whatever area is available, we have to make maximum of that. So we have to see to it that we encourage social distancing, face mask, surface cleaning by the patients, and wearing appropriate PPE at all the times by all the healthcare workers. If we follow this to the T, then we really avoid all the infection amongst the healthcare workers and from patient to patient. So I think whatever facilities and constraints we have, in that we have to work, and we have to work maximally.
And also, I think sometimes when patients are transported, they have ideally said you should have a disinfection protocol and other things. And so this also should be followed. So coming to the end of our panel discussion, can we have each of the panelists, let us start with the non-gynecologists first. Dr. Chand, Dr. Vattal, can you give one important take-home message which the audience should remember from you?
Yes. The first foremost message that should go that the women are less likely to suffer from COVID infection or very severe COVID infections than men. We know women are a better race. So that is a message, very, very strict. And
thank you, sir.
Do not shun breastfeeding and kangaroo care. COVID will not harm in those cases. That's the single message.
Yes, thank you, sir. And Neelam, would you like to give one important take-home message?
Yeah, actually, COVID-19 infection per se in pregnancy is not that does not have any serious outcome. But one important message as a physician I will give that thromboprophylaxis is must for those patients who are moderate to severe, irrespective of the D-dimer level.
Thank you. That is important because thromboprophylaxis was a neglected area. Sushma ji, can you give one important message?
Yeah, being a lactation consultant plus a neonatologist, my one key message is continue exclusive breastfeeding, continue skin to skin care, delayed cord clamping, and continue KMC, kangaroo mother care.
Yes, thank you. Pradnya, you are also a lactation consultant. So other than what madam has said, anything else you would like to add? Pradnya Changede from Science.
Yes, ma'am. I would like to say that yes, women should definitely continue breastfeeding, and together, if we follow all the infection control measures, together we can definitely defeat COVID.
Sujata ji, being a private practitioner, can you give one important message for people in practice for COVID?
During this pandemic, treat each and every patient as COVID, take proper precautions, and please do not send patients for unnecessary ultrasound. There is no need to for second month ultrasound, send for NT and then level 2, and then later if required.
Yes, thank you, Sujata ji. Important message. And Chinmay, being a sonologist and expert yourself, can you tell us one message from you?
I think the most heartening thing about COVID is that the morbidity and mortality is coming down from COVID. So I would ask the patients not to panic if they get this infection in pregnancy, and hearing all the experts, there's so much expertise available to deal with it. Regarding the fetal effects, there are no proven fetal effects directly by the infection. So I would reassure them, tell them that we can plan their fetal care very easily, not to panic and not to rush to the hospital under unsafe circumstances.
Yes, thank you so much. And now our two senior most obstetricians, can we have it from Dr. Narayan Jana from Kolkata? Sir, one important message from you.
Yes. I will add one information that is not discussed, that is active management of first stage of labor. It must be followed religiously because of the fact that COVID had collateral damage on anemia and hypertension control. We are now observing again some sort of an epidemic of anemia and severe hypertension, which can be much easily tackled by active management of first stage of labor. So therefore, active management of first stage labor to be followed religiously.
Thank you, sir. That's a very important message, and we are sorry we actually, due to shortage of time, rushed through that, so we were not able to touch it. And I think, sir, you also gave that important message of psychological management right at the beginning when you spoke, that we should look at that. So
I will add another point, very simple point. We are in a position, it is a caution for ourselves. That is, as a healthcare worker, we have seen our postgraduate in initial phase, they have anxiety and panic. Now at the moment, after 6 or 8 months, they have a fatigue and defiance. Defiance of using PPE. Yes. They are not using it properly, and they are not following the middle path which has been advocated by Lord Buddha, that use work judiciously. So it is very important that to protect our own workforce.
Thank
so it
you,
is a
sir.
caution for us.
Very important message. And now we'll move to Dr. Mittal. Madam, can you please?
I just want to say one thing, that we should use this opportunity, though it is a bad pandemic. We should use this opportunity to create awareness, especially by the telemedicine, because that is a platform where we can really tell the patients about danger signs and about the regular antenatal checkups and the blood pressure measurement and all those things. So I think we should use that opportunity.
Thank you, madam, for highlighting telemedicine. And this is the FOGSI helpline number, which has been created by our president, Dr. Alpesh Gandhi, which can be used. And this is a list of resources which can be used or accessed for further reading and guidance. And
just
at
one
the
last
end,
thing, can I just add one very quick suggestion? Since we're talking on telemedicine, I want to say that my mother support group from BPNI Maharashtra is doing a lot of consultation regarding breastfeeding and any problems. So
yes, Sushma, thank you. We will now wind up with a message from my co-moderator, Dr. Naina Dalvi. Naina, would you like to just sum up?
Yes. Being an anesthetist, I want to add something. I would really appreciate if all the obstetricians, they involve their anesthetist colleagues early in the management. Because if your COVID positive patients do require any kind of medical management, or we need to identify the signs early, then we can be of help, because we are working together with you all. You may not get your physician available all the times, but you do involve your anesthetist and work together. Reena madam and me, we have been having one-to-one so many sessions since day one of pandemic, and we are very happy with the outcome of our obstetric patients. So that's one thing I would like to say.
I would like to just wind up by saying thank you to all the panelists who have been there, and to Dr. Mala Srivastav and team AOGD for inviting us here to be there for this panel discussion. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, Dr. Reena, and thanks all the esteemed panelists for a very informative panel. We move on to the next session on Expert Speak Now. And to chair this session, may I invite the chairpersons of this session, Dr. Arbinder Dang. Dr. Arbinder Dang, she's a senior consultant at Sant Paramanand Hospital, Delhi. and she is Honorary Secretary AICC RCOG North Zone 2017 to 2020.
अब ये मंजूपुरी का एक लेक्चरर, वो भी कोविड ऑर्गेनाइजेशनल एस्पेक्ट कुछ है.
Rathore, she is Director, Professor and Head Obstetrics and Gynecology at Maulana Azad Medical College, Delhi. Next. Slide change, please. Dr. A.G. Radhika, she is a Senior Consultant at UCMS and GTB Hospital. And as you see, she has several positions and awards to her credit. Next. Dr. Renuka Malik, Madam is Professor and Senior Consultant in RML Hospital and Atal Bihari Vajpayee Institute of Medical Sciences, Delhi. So over to the chairpersons to introduce the speaker.
Yeah, very good evening. Am I audible?
Yes, yes, you are audible.
Yeah. So at the outset, I would like to thank organizing team for making us part of this wonderful conference. The first lecture in this session on Expert Speak is on abnormal placentation and adverse outcomes, screening, diagnosis, and management. We all know placenta accreta spectrum is a nightmare for an obstetrician. And to speak on this important topic, we have Dr. Manisha Kumar. Dr. Manisha is a very well-known person in the area of fetal medicine. She is Professor of Obstetrics at Lady Hardinge Medical College and have many awards to her credit. Without wasting much time on her formal introduction, I invite Dr. Manisha to deliver her lecture. Dr. Manisha, over to you. Is Dr. Manisha around?
Yes, yes. Good evening, ma'am, and thank you so much for the kind words. And I would just share my screen and start my presentation. Yeah, so is my screen visible?
We can see you, we can hear you, Manisha. Your screen is also visible.
Thank you so much. So at the outset, I would like to thank the organizers for giving me this opportunity to present this topic, which is in which I've done some research. And basically, this topic is abnormal placentation and adverse obstetric outcome, screening, diagnosis, and treatment. This topic seems vast, but I would like to concentrate on three important questions. What does abnormal placentation do? The second, what is the latest in screening of preeclampsia? And the third, what do we do after the patient test screens positive? So,
just click on the
okay. So what does abnormal placentation do? So we know that in normal pregnancy, the placental trophoblasts, they invade the uterine wall. And when they breach the veins, they extensively remodel the spiral arterioles. So when this doesn't take place in an abnormal situation, then what happens is I'm not able to, what should I do to proceed for?
Just click on the presentation once.
Okay, that's good. So what happens is in an abnormal situation, the abnormal trophoblastic invasion takes place, and this is not normal. And so by the early second trimester, the placentation becomes abnormal. And later on, with additional pathologic placental processes acting, in the late and early third trimester, we have preeclampsia, or it can lead to severe early FGR, or it can lead to placental abruption or preterm prom. So all these things are interrelated, and so as they can be called as placental syndrome. So basically, our challenge is to find some screening method in the first trimester itself, so as to understand which women are going to have these problems. So not all women are going to have this abnormality. So as long as back in 2010, NICE came up with this maternal factors which predisposes women to abnormal placentation. And in this, we had some major criteria such as preeclampsia in previous pregnancy, chronic hypertension, autoimmune diseases like SLE. So these were considered major. And if there was one major criteria, the women were supposed to be at high risk of preeclampsia. And then it was suggested that if woman has among these minor criteria, any two of them, that the woman is predisposed to preeclampsia. But it was seen that it identifies only 40% of cases of preterm preeclampsia and only 35% of the term preeclampsia. So there has to be some other things also to be added to it. Now for this, we had angiogenic and anti-angiogenic biomarkers. As we have seen in the previous slide, that angiogenicity is very important for good vascularization and for good oxygenation, so that the placenta develops normally. So here we will take 1 minute to understand what these biomarkers are. So we come to PAPE, which was first to be found to be related to preeclampsia. And here you see that what does PAPE do? It brings the insulin-like growth factors up to the receptors. So if it is not there, the insulin-like growth factor remain in blood, they will not come up to the receptors, and there is no growth. Now we come to another marker, which is SFLT. Now this SFLT is actually a receptor on the endothelium. So if it is there on the endothelium, the PLGF and VEGF comes and attaches itself and the growth takes place. But when due to anoxic conditions, the SFLT is too much, it goes into the blood and it combines with PLGF in the blood itself, and all these receptors are empty. So when these receptors are empty, the vascular growth doesn't take place. So actually there is an imbalance between SFLT and PLGF, which leads to development of preeclampsia. So now we have all these markers, the maternal factors, the PAPE, uterine artery PI, which is actually showing how much blood is going to the placenta, and we have PLGF and SFLT PLGF ratio. So this I have taken from an article by Dr. Poon, which has recently been published in American Journal of Obstetrics and Gynecology. And it shows very nicely the timeline, how the screening developed. So from 2009, where the maternal factors, and 2010, where the NICE guidelines came, to 2013, AACOG guidelines, and then around 2014 and 16, we had this PLGF coming into picture. And now in 2018, even the ACOG gave this guideline that PLGF should be used and can be used to screen. And now they have said that there is a special term called triple test by FMF, which says that they say that it has been validated, externally validated also, and it is considered to be a very good marker of early onset preeclampsia, and that we will see in a short time how it works. So Dr. Poon had prediction models were tested, and it was found by a review meta-analysis, and it was shown that medical history, mean arterial pressure, and uterine artery PI were the most commonly used things. And they said that they have added PLGF, and that is called the triple test. But one thing is very clear, that all these factors, they don't act alone, and there has to be integration, because they are low markers if they are used alone. So integration is the key. Now, we also did a study, which was ICMR funded study, and it was done in around 2014, 15 and 16, in which we studied 2,500 women, and we did first trimester screening. And in this we found that again, the markers individually didn't had much sensitivity. And when we combined these markers, we found that the screening was quite good. And the difference was that we used hypertensive disorders of pregnancy and not preeclampsia. So we saw the early onset and late onset, and then keeping the 10% false positive rate, we had this detection. So all this research is very good, the Western data, but tomorrow if we go to our clinic and our hospitals, how can we use them is the important question. So we can always use maternal factors that will give us around 30 to 40% detection rate. We can ask the history, we can see the BMI, and we can see the mean arterial pressure. And if we combine these two, it will give us 50% as a detection rate. And if we add uterine artery Doppler and use 95th centile as a cutoff point, then we can probably increase it to 60%. And then adding PLGF will again make it around 70, 74, and early onset preeclampsia about 90%. Now, FMF has given very nice, software which can be used free. And in this, it's not necessary that we have to enter everything. Whatever we have, we can enter, and we get a good, screening, this thing which can reassure the patient also that they are okay. And it tells us when the patient needs to be again screened. So we can do more use of this. And one thing we are sure now that the screening is possible in all settings. So how can we use this is our third question. So if you're using these combined markers in the first trimester, we can use it for prediction and prevention, and we can treat by giving aspirin. In the second trimester, it aids us in management, it aids in stratification of the risk. We can decide which patient is a high risk, which patient is low risk, and we can divide them, and you can channelize our resources. Now, in the third trimester, we can use them for early delivery and prevention of complication, taking SFLT-PLGF ratio, because it is considered to be a good marker in the later half of pregnancy. Now, about the ASPER trial, it has shown us that yes, prevention is possible, but it has to be taken at the right dose, 150 milligram per day, taken starting at 11 to 16 weeks, no later than 16 weeks. And the use of aspirin has been shown to reduce 62% of preterm preeclampsia and 82% of preeclampsia before 34 weeks. Compliance was very important, because with good compliance, they say that it reduces in more over 90%. But when the compliance was less, it was just 75%. Not only this, the low dose aspirin has shown in Lancet to reduce the preterm labor also. And then it has been shown to affect the and prevent the small for gestational age babies also. And same thing in our study also, we found that Dopplers prevent the FGRs, and it tells us about the FGRs, and PAPE, low PAPE tells us about the stillbirth. So that was also in our papers. Now, I would also like to focus on the study that we are doing now. We are supposed to take 1,000 women, and in which we are starting from the first trimester, and we are going on to the last trimester, looking at the biometry, the biophysical profile, and the biochemical profile. So we are looking at the placenta and doing the 3D volume of the placenta. And we have seen that till now we have done around 550 patients, and we see that the volume is a very important marker that is going to tell us more about the correlation with abnormal outcome. So we are doing PAPE, we are doing SFLT, PLGF, all in all the trimesters. And so we had a little bit of data which I would like to share. And in that, we have done a correlation of placental volume with other parameters. And we found that in the first trimester, the correlation was the best. So the volume correlated with length, breadth, thickness, everything. And it correlated with PAPE in the first trimester, but not with SFLT, PLGF. And it correlated with uterine artery also. And the effective fetal weight on ultrasound correlated in every trimester with volume. And we also found that SFLT, PLGF correlated more in the third trimester. So we found that we have found till now that volume is a very important marker, and we are doing more research on that. Now, to end, the take-home message is that besides preeclampsia, the placental abnormality can lead to other adverse effects, and use of integrated screening with various markers involving maternal factors, PLGF, and uterine artery PI is best in the first trimester. And the FMF software allows risk to be evaluated with any of the available markers, and it is free. And prevention by aspirin can be achieved by good compliance. Compliance is the key here. If the compliance is good, the results are quite good. And these are good for preterm preeclampsia, we have to remember at the most. So, and PLGF is a potent marker. It can be used in all trimesters, not only in the first trimester, but even in second and third. And it has got its relations to FGR also. And maternal history, mean arterial pressure, and BMI are still the best bet in low resource setting. Thank you.
So I think that was a very nice presentation, Manisha, very simply put, and I think it's got a very important take-home message. So now we move on to the next very important, yet another obstetric problem, that is of preterm labor. So we have a very eminent speaker, well-known personality, Dr. Manju Khemani. She's director in the Department of Obs and Gynae, Max Super Specialty Hospital, and she's the ex-professor at the Lady Hardinge Medical College. And she has many important positions to her credit, and we know she's a very experienced person amongst us. So welcome, Dr. Khemani. We are really waiting to hear to you.
Let me start sharing my presentation. Can you see my presentation? Is my presentation visible to all of you?
Not at the present point of time, no.
Okay, but I can see it. How do I make you see it?
You need to basically share the content.
Yeah, I have shared it. I've shared it.
Okay.
Can we play it for you, madam? Can we play it for you?
Yeah, but then will I be able to move it, Sumit?
No, you have to just say next.
No. Just give me 1 second. Then tell me how to do it, because then it will be...
Just click on the share screen button once.
Just give me 1 second again. I'll do that.
Yeah.
The green one.
Yeah, I've done that. Share.
After the moment you do that, there is small windows that must have popped out.
Yes.
Just click on the desktop or.
Yeah, it has come now. I can see this thing. Can you see my presentation?
We cannot see, ma'am.
Why can't you see it?
You do stop share. Whatever you do stop share again.
I do stop sharing. Okay, I'll do stop sharing. 1 second. Can you see it now?
Yes, ma'am. We just need to open your presentation now.
Yeah.
Yes.
How do I have the speaker's view?
Please continue.
So good evening, everybody. Thank you very much, Dr. Radhika. And I'm going to speak on the preterm labor and tocolysis. And at the outset, let me thank the organizer for giving me this opportunity. So let's share few facts. 15 million babies are born every year preterm. It's a leading cause of death. Every year, 1 million children, they die because of this prematurity. Among the top 10 countries, which have the highest number of preterm birth, India tops the list. These babies not only have a high neonatal mortality and infant death, but 25 to 50% of surviving babies, they have a long-term neurological impairment. We all know the definition that preterm birth is defined as birth between 20 weeks and 36 weeks plus 6 days. What I want to highlight here, that 75% of all preterm births, they happen between 34 to 37 weeks and what we call late preterm birth. We all think that my patient has crossed 34 weeks, so the critical period is over. But even these late preterm births, they have a high morbidity and a high mortality. As you can see, the mortality is as high as 25 per 1,000 live births. Not only the mortality, more than the incidence of cerebral palsy is 3 times higher as compared to term pregnancy. Plus these late preterm babies, they have behavior problem, and none of the guidelines say that use tocolysis in these late preterm birth. So how do you diagnose preterm labor? Everybody will say it is so easy. Regular uterine contractions, change in cervical dilatation and effacement. But identifying a woman who will give birth preterm, it is an inexact process. This was considered the best article in 2016. It was written by the Mellon. And what did he write? He said one of the biggest challenge in the management of women who present to the triage with the threatened preterm labor is differentiating 75% of patients who will not actually deliver. Only 25% of patients will deliver prematurely. The other statement says that less than 10% of women with clinical diagnosis of preterm actually will give birth within 7 days, and we are so happy when we use tocolysis. Oh, I've used this medication and it has stopped the preterm labor. So nice guidelines say that if a woman has come at 29 plus 6 weeks of pregnancy, start tocolysis. But if she has come at 30 weeks plus 0 weeks of pregnancy, measure the cervical length. And if the cervical length is more than 15 millimeter, explain to the woman that she is not in a preterm labor, and think of alternative diagnosis like maybe vaginitis or UTI. But if her cervical length is less than 15 millimeter, then she is likely to have the actually preterm labor, and here fetal fibronectin comes to their help. We don't use this test. So do we have any other tests? Now we have two tests available even in India. One is Actim Partus and other is PartoSure. Both the tests are very easy, can be done by obstetrician in the labor room, do not require any support of lab, and instant result you can find out. PartoSure finds out placental alpha macroglobulin, and it has a negative predictive value of 99%. Both these tests are not recommended by ACOG because evidence-based randomized control trials are not available. We should sensitize our patient in the antenatal clinic that anytime she has, period-like pain, pelvic pain, backache, slight blood stain discharge, she should immediately report to the triage. By this, we will be able to reduce the preterm labor. Now, can we predict the risk of preterm labor in asymptomatic patient? Yes. If patient at 20 weeks of scan, the radiologist has told us that cervical length is less than 25 millimeter, this patient is at risk of having preterm birth and sensitivity is as high as 60%. So what should we do? These patients will benefit by the vaginal progestogens. NICE guideline says that any patient who has a previous history of preterm birth, our antenna should be open. Any patient who has a history of previous preterm birth, she has a mid-trimester loss at more than 16 weeks, or on transvaginal ultrasound length is less than 25 millimeter. So here we should start vaginal progestogens, and this should be continued till 34 weeks. Vaginal progesterone also should be given to a twin pregnancy where the cervical length is less than 25 millimeter. Prolonged study has told us that 17-hydroxyprogesterone, if given to a woman who has previous history of preterm delivery, is not better than placebo. So it should not be used. We will saving the patient from the intramuscular injections. Now, if patient has come in active labor, active preterm labor, is there any role of progesterone? Absolutely no. 4P study has told us that in an acute stage, progesterone has got no role. So now we come to tocolysis. The objective of tocolysis is to give us, time to give the corticosteroid or transfer the patient. And these tocolytic therapy generally is effective only for 48 hours, which we need, So when we talk of tocolysis and we talk of beta mimetics, in Europe, it is Ritodrine and Phenodrol. In India, it is only Azoxaprine. When USA, they say beta mimetics, it is Terbutaline. In Cochrane database 2014 has said that these beta mimetics, they are effective as compared to placebo in transferring the patients to the tertiary care center or to give the steroids. So they are effective, but with some adverse effect. What is important that when you are giving Azoxaprine, if the pulse rate is less than 100, it is not working. If it is more than 120, reduce the drip rate. So after the patient has tided over the acute phase, our prescriptions usually have Azoxaprine tablets. ACOG guideline says that the maintenance beta agonist therapy has got absolutely no role and should not be used. The success rate of Azoxaprine depends on the dilatation as well as on the effacement. More is the dilatation, more is the effacement, less is the effect. Now, the ACOG guideline says the first line tocolytic therapy is beta-adrenergic receptor agonist, calcium channel blocker, and NSAID. Which one should you use? It depends on what is your patient's profile, whether she has a heart disease, whether she has a diabetes, and how much do you know about the monitoring. In UK, calcium channel blocker, they are the first line drug, and the loading dose is 30 milligram. The advantage of this drug is that your patient can be given orally. Adverse effect will start if you are giving per day 60 milligram per day. So monitor the dosage, and duration of a single dose of nifedipine is about 6 hours. Its efficacy is as good as beta mimetic, but it has a favorable safety profile. Atosib and oxytocin receptor antagonist, it's a wonderful molecule, no contraindication, no side effect. It's the #1 drug used in the Europe and can be given in a triage because it does not require monitoring. Only thing is it is expensive on the patient's purse, and it is as effective as the intravenous nifedipine. The third thing is cyclooxygenase inhibitor. The drug used is indomethacin. Now, when will you use indomethacin? When patient cannot be given Azoxaprine. So this indomethacin cannot be used if patient has gastric ulcer, if patient has asthma, cannot be used if patient has oligoamnios, and it should not be used for more than 5 days. Plus, ultrasound has to be done. The idea is to give the corticosteroid. So ACOG says give corticosteroid from 24 weeks to 34 weeks. But now they say even in the late preterm, give from 34 to 37 weeks. But to give this, do not delay the labor by giving tocolysis. The optimum time delivery interval is 24 hours. That means delay the delivery for 24 hours and it will work for 7 days. Beyond 14 days, it does not have any benefit. When you are choosing between betamethasone and dexamethasone, and if you are given betamethasone and next step, if you are doing ultrasound, and if the fetal body movements are less, breathing movements are less, don't get worried. This means this is the effect of betamethasone. Now, many times we know patient is about to deliver. We still give one shot of steroid thinking that it will work. Yes, it does work. Even if you know that a patient does not have 24 hours, a single shot also of steroid should be given. Now you have given first shot and patient did not deliver, but after 14 days, she again comes back and she's less than 34 weeks. Here is an indication to give a repeat course of antenatal steroid according to ACOG guidelines. Patients less than 32 weeks, magnesium sulfate should be given for the neuroprotection. There is no role of antibiotics in preterm labor. We all routinely prescribe this thing because we think that cause of preterm labor is infection, but it has actually no role. If you're treating bacterial vaginosis, clindamycin is more effective than Metrogyl because it has an anti-inflammatory property. So take home message is that you give tocolysis when there is an indication, right? And if patient is not responding to tocolysis, it may imply that there's an infection or inflammation, and look for those cases. Thank you very much for the patient here.
Thank you, Dr. Khewani, for such a clear, crisp, and comprehensive talk on preterm labor. You have been my head teacher in Lady Hardinge, and your lectures, as usual, are superb. I think you have covered most of the aspects of preterm labor, and I suppose clindamycin local pessaries are more useful than oral Metrogyl. Now I welcome Dr. Jyotsna Suri for her talk on jaundice in pregnancy, differential diagnosis, and management principles. Dr. Jyotsna Suri is a well-known person. She is professor in VMMC and Safdarjung Hospital. She is in charge of critical care ops in Safdarjung Hospital. Her areas of interest are critical care, high-risk pregnancy, and gynaecology. She is editor NACHI and has numerous papers, publications, and books to her credit. Dr. Jyotsna, please.
Thank you, Dr. Renuka, for the kind words. So I'll just share my screen. Is it visible?
Yes, it is visible.
Yeah, thank you so much. So thank you, Dr. Mala, and the team AOGD to invite me today for this talk, which is not very often spoken in the conferences, but it is a very important subject. Why? Because there is a lot of mortality we see due to the jaundice if we have not made the correct diagnosis and taken the right step at the right time. That is why I feel that this topic is very important for all the obstetricians to be aware, because what the mind knows, the eye will see that. So if we have got an idea about the various conditions, how they present, what is the laboratory derangement with them, we may be able to make the right diagnosis in time and take the right action. So the common hepatic disorders in pregnancy can be either specific to pregnancy, they can be those which will be aggravated by pregnancy, or those which are coincidental to pregnancy. So the important ones which are seen unique in pregnancy are the hyperemesis gravidarum, preeclampsia with severe features, HELLP syndrome, intrahepatic cholestatic jaundice, IHCP, and AFLP. These are the important conditions specific to pregnancy, and very rarely we also see the TTP and the HUS. Now, hepatitis E is one condition which can be aggravated, which is, in pregnancy, it can take the acute fulminant form in more than 25% of the cases, whereas in the general population, most of the time, non-pregnant people, hepatitis E is a very benign condition, and very rarely only it turns into acute fulminant stage. So this is one dreaded thing which all the people, I think obstetricians have seen, and lot of mortalities are there due to this. Coincidental to pregnancy can be the other viral hepatitis, other chronic liver disorders, and of course the hepatitis B, C, and the autoimmune hepatitis. So now I think I will focus more on the the pregnancy unique conditions today. Now coming to interpretation of LFT in pregnancy, as for all other systems, liver also has got, the impact of the physiological changes. So we see that in all the trimesters, the albumin will be lower due to the dilutional effect, and bilirubin also. Whereas the alkaline phosphatase increases in the second and third trimester, mainly because of the contribution of the placental isoenzyme. And the GGT remains, slightly decreased. What is not affected is important is the serum aminotransferases, that is the ALT and AST, and the prothrombin time, as well as the total bile acids. So these are not affected by pregnancy, and they remain the same as in the non-pregnant. Now, when we talk about evaluation of patient with hepatic disorders, so it is very much the same as for other disorders. You have to take a very good history, which is just, you get so many information with the good history that I think half the time you can always zero down on some particular diagnosis with a good history and a good examination. So I talk about, the important features of these different conditions. So one important thing is we have to consider in which trimester this condition is presenting. First trimester, normally the one unique to pregnancy, I said, is hyperemesis gravidarum. It presents with nausea, vomiting. We are all very familiar with this condition. But after 20 weeks, if this persists along with deranged transaminases, we have to think of some other pathology which may also be coexistent. It should not persist beyond the first 20 weeks of pregnancy. Second and third trimester, mainly the third trimester, we have got the intrahepatic cholestasis of pregnancy, which the cardinal symptom being the pruritus, more typically in the night, in the palms and soles. Sometimes it may be accompanied by nausea, and in the later stages by jaundice. And preeclampsia, eclampsia with severe features may also present with upper abdominal pain and jaundice, and HELLP syndrome and TTP, again epigastric pain, jaundice, and nausea, vomiting. So epigastric pain is a very, very significant complaint in both preeclampsia, eclampsia, and HELLP syndrome. And in acute fatty liver of pregnancy, it is mainly the patient will present with non-specific features like malaise, nausea, vomiting, and then there will be very, very sudden deterioration of the patient. It is a very short course. It is one of the most dreaded complications of pregnancy, which we all know has got a very high mortality, and the patient will go into DIC very fast. So coagulopathy and encephalopathy, these are two important features of acute fatty liver of pregnancy. So the clinical features of liver diseases unrelated to pregnancy, I have just highlighted one particular condition, and that is the acute viral hepatitis. Normally will also, along with nausea, vomiting, jaundice, there will be a history of fever, which is very, very important, because this fever should not be there in the other conditions like the acute fatty liver of pregnancy and the HELLP syndrome. Normally the fever history will not be there. Here fever is there, history of fever, so that helps in giving us a guidance that it could be acute viral hepatitis. Now coming to the laboratory values in these different conditions. So hyperemesis gravidarum, bilirubin should not be more than 4 milligram. And here the specific transaminase is ALT. ALT will not be more than 200. See, this is why we have to, keep these in mind, because if the levels are more, we should think of some other chronic liver disorder also. We cannot just take it for granted that it may be due to hyperemesis. And as I said, by 20 weeks, it should come back to normal. IHCP, the bilirubin should not, normally will not cross more than 6 milligram. Here again, ALT is more specific. Rarely it can reach up to 1000, but normally it remains below 300 to 250. And of course, the increased bile acids are the pathognomic feature of IHCP. More than 10, we diagnose. More than 40, it has got a poor prognosis for the fetus. And more than 100, there is a 3 to 4% risk of IUD. So the other condition which presents with pruritus is biliary tract diseases. So here, how do we differentiate by the lab? Here we can differentiate it by the GGT. So in the IHCP, the GGT values are normal. However, in the biliary tract diseases, the GGT will be raised. So this is one subtle difference how we could differentiate between these two. Acute viral hepatitis, bilirubin will rise like anything. It may become 17, 20, 24. And ALT again is the more specific of the two. It will rise. Both the enzymes rise, but ALT rises more as compared to the AST. Now, pre-eclampsia, eclampsia, and HELLP syndrome. So here we have to remember that the AST is the specific marker here, transaminase. So this is because the pathology here is the periportal necrosis. And most of the other liver disorders, it is the ALT which rises. In these conditions, it is the AST. Then HELP will have the other features which we all know, the low platelets and the high LDH more than 600. So it is easy to diagnose once we have got the complete picture. The complete labs are available. And it may be accompanied by hypertension, but in 15 to 20% of the cases, there is no hypertension. So that is also important to remember. The jaundice will be mild again here, not more than 4 to 6 milligram. The bilirubin normally does not cross that. And TTP and HUS, again, TTP, there will be bilirubin is high in most of the cases, but ALT and AST are in the very mild range. They will not be more than 100 to 150. Now coming to acute fatty liver of pregnancy again, here the AST, ALT will be around 500, not more than that. And here the bilirubin will be raised. It can be up to 10, even more sometimes. So we should diagnose it by the Swansea criteria. Here I am showing the Swansea criteria. If 6 or more are present, we can diagnose this condition. And out of these, the important ones we have, I think we all teach our PG students also look for leukocytosis, look for hypoglycemia less than 72 milligram percent, elevated bilirubin, then transaminases are high, creatinine is raised, polydipsia, polyuria, abdominal pain, vomiting. So all these, and of course, very important is elevated ammonia. Coagulopathy is very quick to occur, and the APTT can be more than 34 and PT more than 14. So, and if a ultrasound is done, we may get ascites or a bright liver on the scan. So these are all very, very peculiar features of the AFLP. And it is very important to diagnose it very fast. So here, this is again the same algorithm type of thing I've made, that if it is pruritus, you think of IHCP. And the other differential I told was that biliary tract diseases like the cholangitis and the primary biliary cirrhosis, in which already. And if it presents with nausea, vomiting, epigastric pain, it is acute in onset, it is either HELP or AFLP, and if there is fever, it may be infective hepatitis. So the caution here I put in red, acute liver failure that is presenting with altered sensorium and a coagulopathy with INR more than 1.5. These are very, very important things, which mostly it will be either in AFLP or in acute fulminant hepatitis in the HEV, hepatitis E virus infection. So now coming just 1 or 2 slides about the management. So HELP, severe PE and AFLP. All these I have clubbed together. Why? Because there are very subtle differences in their presentation. All three of them may be, of course, preeclampsia will have high BP. HELP will have high BP in about 85% cases. AFLP will have high BP in 50% cases. So there is a very subtle difference between all of them. Let's not waste time in finding out that what is it, because our management is same. Stabilize the patient. If the BP is high, we give the seizure prophylaxis. start the antihypertensives, and deliver the patient. So there is no role of conservative management in any three of these conditions. And the faster and the earlier we deliver, the better is the prognosis, and we may be able to save the mother. Now coming to IHCP. IHCP, the management we all know, we give the ursodeoxycholic acid at a dose of 10 to 15 milligram per kg body weight, and we can go maximum up to 21 milligram per kg body weight. If this is not sufficient, patient is not responding, second line is the cholestyramine or rifampicin can be used, and of course local calamine lotion and aqueous methanol are also known to have good results. The delivery has to be done here not for the maternal sake but for the baby, because as I told you, the bile acids are cardiotoxic for the fetus. They can cause sudden fetal arrhythmia, and there can be sudden IUD, we all know it, and of course there can be meconium stained liquor and preterm birth. So we have to deliver these mothers for the sake of the baby so that we get good fetal outcomes. And very often we are told to tailor the time of delivery according to the total bile acids, which may not be available to all of us, but that is the recommendation, that if the bile acids are more than 100, try to deliver them by 36 weeks. If the bile acids are between 40 to 100, try to deliver them by 37 weeks. And if the bile acids are less than 40, we can take them even up to 38 weeks. So this is, but by 38 weeks, we should try to deliver all of them. And word about hepatitis E and A, here there is little or no data to support termination of pregnancy to improve maternal outcomes. So there is always a confusion that should we deliver these patients if they are hepatitis E or A and they have come with fulminant hepatitis. So the focus here is to give supportive care and stabilize the mother. As far as the fetus is concerned, yes, sometimes the mother is very sick, fetus is alive, it is nearing term or term. So we have to take the decision to terminate the fetus as per case, from case to case basis. After stabilizing mother, correcting the coagulopathy, we may take the decision. It should be individualized, but per se, it is not going to help the mother to recover faster, is what the evidence says as of now. Acute liver failure, if the patient comes in that, so we have to manage this patient in the HDU or the ICU setting. Hypotension should be corrected with normal saline, and the dextrose can be added if the patient is hypoglycemic. And obviously, if they are not responding, we have to add the vasopressors. Just one important thing here, that prophylactic administration of FFP is not recommended, even in the if the INR is raised, because that is something we all tend to, I have seen so many residents, the minute INR is 2, 2.5, they will give FFP, even when there is no bleeding from any site. Even the recommendations say that if we are going to give FFP, we may harm the patient more, we may cause fluid overload, we may cause the trolley. And besides that, then we don't have an index to monitor the liver function, whether it is improving or not, because INR is a very, very sensitive index. If you do it every day, 2 to 3 times a day, you will know when the liver has started recovering. So this is only if the patient is having an imminent delivery, we should correct it. And if she is bleeding, we should correct it. So the other things, of course, we have to correct all the metabolic abnormalities. And in case the patient is not recovering, early transfer to a liver transplantation center can have good results. There are many case reports where women have been saved by liver transplantation in cases of AFLP, which have not recovered, because spontaneous recovery after acute liver failure is only 40 to 50%. So the key points, jaundice in pregnancy may be due to unique conditions of pregnancy or other conditions which may be aggravated. The most important, I have already said, IHCP, HELP, severe PE and AFLP. And all these have subtle differences in their presentation, but management of these conditions warrant urgent delivery to save the life of the mother. Time should not be wasted in seeking the diagnosis. Risk of recurrence in subsequent pregnancies is also seen in AFLP, IHCP, preeclampsia and HELP. And this is an important counseling point which should be told to the patient if they are embarking on the next pregnancy after they recover. So thank you very much for the patient hearing. And I also take this opportunity to invite all of you for the critical care obstetric workshop on 4th November in the morning, 9:15 to 1:30. Please do join us, all those who practice obstetrics. It is going to be very useful for everyone. So that's all. Thank you very much.
Thank you, Dr. Jyotsna, for an excellent presentation. Thank you, ma'am.
So I think all my friends join in thanking AOGD for inviting us here as chairpersons for the program. So it was a thoroughly enjoyable and it was full of information. Thank you so much.
I thank all the chairpersons and speakers for this session, and I invite the chairpersons for the next session. Experts speak. Our first chairperson is Dr. Aparna Sharma. She is Additional Professor, Division of Maternal Fetal Medicine, Department of Obs and Gynae, AIIMS, New Delhi. Our next chairperson is Dr. Abha Sharma. She is the professor at UCMS and GTB Hospital. Dr. Kanika Jain, who is the Vice President of AOGD and co-chairperson of this annual conference. And Dr. Anjali Dabral, who is the Hero Department, VMMC and Safdarjung Hospital. Over to you, the chairpersons, to conduct this session. Dr. Aparna, are you there?
Yes, ma'am. So a very good evening to all of you. And it is my honor to introduce Dr. Manju Puri. She is the head of the Department of Obstetrics and Gynecology at Lady Hardinge Medical College, and also the chairperson of the Quality Committee of AOGD. She is the most dynamic and charismatic leader who needs no introduction. And the best part about her is that she has internalized the quality improvement movement and disseminated the movement for all. So, ma'am, we look forward to hearing from you. And most of all, I look forward to hearing from you about the quality improvement movement that you have started. And we are all inspired by all that you do in your department and in your life. Thank you so much, and welcome to this platform.
Thank you, Aparna. Thanks for a lovely introduction. And I hope I am able to do justice to the topic which has been given to me. So I'll start sharing my screen. And I hope my screen is visible.
Yes, ma'am, it is.
All right. So in next 10 minutes, I'll be kind of sharing my presentation on restructuring obstetric practices in COVID pandemic, a journey of quality improvement. Obstetric practice in public facility. We all know what it was like in pre-COVID times, that is before March 2020. Crowds everywhere and anywhere was a norm. Social distancing was unheard of. Availability of bed was never an issue. Patients and even their babies shared beds. Most patients presenting to emergency were admitted. Antenatal and gynae patients were often admitted in wards for workup or for observation and stayed there for months. I remember that, patients who would need enoxaparin and could not afford would stay for 2 months, 3 months, 4 months. So beds were not a problem. It was a total comfortable scene for everyone. And then SARS-CoV-2 arrived, and we were face to face with COVID pandemic. And with it, SARS-CoV-2 brought so much of infectivity, and everyone was under so much of stress because each infected patient was supposed to infect at least 4.5 more patients. So it was said that we need to maintain distance, we need to wear mask at all times, and we have to be in proper PPE. And that was the new normal. And for public facilities, it was a daunting task. It was something which we thought is just not possible. So it was a total crisis situation. There was panic all around, whether it was your home front or it was traveling or it was hospital. We really didn't know how to make the ends meet. and there was so much of fear all around. So fear always has two approaches. One is forget everything and run. And the second is face everything and rise. The choice is always yours. And we decided to take the second one. So I'll be sharing my quality improvement journey at LHMC. I think it is the quality improvement methodology, which has actually helped me in leading my department. So basically in this journey, we have a point of care quality improvement 4-step approach, which I have already highlighted a number of times. And we took this 4-step approach to make our facility COVID compatible. First of all, the first part was to identify all my problems, then to analyze and process and line list them, prioritize which one to take up first, and develop a team. And then we developed then the next step is to develop an optimal solution. We implement that solution with the help of the team. Then we study the results and we see whether it needs to be, the solution has to be changed, or it has to be adapted, or it has to be agreed upon. And then we standardize the solution and then move on and pick up the next problem and then move in the same circle over and over again. So the first step was that the team decided that there's nothing which is impossible. We need to make it possible. So we started with the baseline assessment of the facility for its COVID compatibility. And we started doing gap identification. It was a total maze. So we identified the gaps, problems, bottlenecks, and did a line listing. So these were the gaps which we identified. There were no separate areas for COVID suspect and positive admissions. There was overcrowding in the OPDs. There was huge rush in gynae casualty due to patients being turned away from private sector and small public setups. There was overflowing of the wards. The healthcare workers were very fearful that they would carry infection to their elders in the family and to their children. So they were evading work. There was reluctance on the part of consultants to examine patients for the fear of again spreading infection, and that the outcome of this disease was worse in the older people. There was non-availability of PPEs. There was limited testing facility available. There was a long turnaround time for the test results. So we really didn't know where to start from, and there were many more. The role of leadership is to transform the complex situation into small pieces and prioritize them. So that is what was decided, and we decided to lead from the front. The first step was prioritization of our problems. And we focused on, there's no point asking for infrastructure, more wards. So we thought, let's focus on the processes and see how can we do more with whatever is available to us and reduce the waste and try and improve the quality. So our first focus was reorganization of the facility. So we created separate areas from already existing areas. We created separate areas for COVID non-suspect patients, which were green, COVID suspect patients, which were orange areas, and for COVID positive patients, which were red areas. So the facility was restructured, the labor rooms were restructured, the wards were restructured, and finally we added one gray area also, because patients who did not fit into any of these, they were not from the containment zone, they did not have fever, they were not suspects. So we made another gray area, which was considered our holding area, where we would keep them till such time they are actually get their reports and are classified as either green or red. Casualty we had to ultimately turn in orange area, because whatever said and done, all kind of patients were coming there. So we thought that it has to be an orange area. So we shared this on our international forum. We published a paper setting up of COVID-19 suspect obstetric unit at a tertiary care hospital in India, challenges and solutions. And this was shared as a letter to editor in American Journal of Medical Quality. Our next step was preparing standard operating procedures. So we focused at every small thing, how to triage our patients, what test to use for what, what should be the area appropriate PPEs depending upon the availability of PPEs. How was the labor room and OT to be sanitized? Initially, everyone wanted all the places to be fumigated. So, we got away with it. Then how to sanitize the wards? How about sending patient sample for COVID testing? That was also an issue. who will take the samples, then sending histopathological samples from COVID areas. Once, we operated upon an ectopic, and in the morning, the sample was lying there because no one was ready to take. So we arranged for those Ziplocs and all. Then how to do contact tracing, what should be the quarantine policy of the department, what should be the care of COVID suspect and COVID, what should be the care of patients in these areas, what about the emergency duties, and how should the OPDs be managed. And there were a whole lot of things we put in SOPs in place. Then the next step was decentralization of power. So this was our initial setup. So one leader and everyone rest together. So I actually decided on redistribution of administrative control of wards, OPDs, labor rooms for better and efficient administration. So all the names written down below are the marshals. They are the ones who looked after each area, and they looked at the availability of PPE in their area. They looked at the patient flow, whether the patients were tested or not. They troubleshoot all the interpersonal relationship issues in their areas, and they have been managing their areas extremely, extremely well. The next part was communication. Thanks to WhatsApp, I really can't think what we would have done about COVID in case there was no WhatsApp. And we had a whole lot of groups and a lot of communication which goes on the groups, and each ward has its own group. So I think it is a very nice intra-departmental and intra-unit and interdepartmental communication, and messages are going to and fro and very fast. The next step was decongestion. So we need to focus on the decongestion of OPDs, wards, labor rooms, emergency rooms. So what steps did we take? So we started with limiting the number of OPD registrations. That was especially true when the lockdown was there, but then finally we gradually, slowly relaxed it. Then we staggered our OPD registration. We started doing one part in the morning, one part in the afternoon. Not all registrations were done in one go. Then we increased the number of examination rooms. We ensured all doctors, including consultants, reached the OPD in time. The first thing they do is they go to the OPD, finish off with the patients, let not the patients be waiting there. We decreased the frequency of visits of patients, antenatal visits, and dispensed medicines for longer periods, for 2 months in our antenatal patients. We encouraged them to start coming to the telemedicine. We made a stamp, and that stamp was put on the sheet of all the OPD ticket of all, and they were explained that they can show their reports in the telemedicine. We opened a fetal surveillance center in the OPD with an ultrasound and CTG machine there. So all those high-risk patients who were admitted for surveillance, the surveillance was done, they were sent. So it was done on OPD basis. We added a routine growth scan in late 3rd trimester on OPD basis. We found that because of lack of lesser number of visits, some of the stillbirths happened. So we thought, let's put a routine growth scan late in the 3rd trimester. The admissions was mandatorily screened by all consultants and tailored as per bed availability. And after, they were already, that RT-PCR was sent, and then they were admitted. And if it was urgent, they were admitted in gray area. Otherwise, they were asked to come the next day. We started telemedicine and eSanjeevani. And, my consultants have been doing very well as far as this part is concerned. I interacted with HODs for referring hospitals on day-to-day basis to inculcate referral etiquettes. People were pretty unhappy on the training group, but it did work. I am to say, we told them that please send patients only after confirming the availability of bed. We will take your patients. Please do not send the patient, let them not go to and fro. And this is what is the best intervention, daily huddles. So every morning with the, ever since 6th of May, I think me or Dr. Reena have been taking these meetings, 9 to 9:30, we have a meeting every day where we meet the ingoing and outgoing teams of consultants and the residents. So here all the problems are, we do troubleshooting, all problems, they'll bring up their problems. We will fix those problems and put the solutions in place. And the meeting minutes were put on WhatsApp every day. And then I think this was one very important strategy. There was rapid identification and isolation of COVID positives. This was, this is the list of frontline consultants who've done a lot of work in putting all the reports every day. And then every consultant who's in charge of administrative in charge of every ward would look up that whether there are any positive patients or not, and then would put them in the right places. And this dynamic triaging really, really helped us. So we've published this another paper on international forum, and it is the dynamic triaging using QI methodology to prevent admissions of asymptomatic COVID obstetric patients. And then this team of senior faculty members have dedicatedly, worked on, any patient who would come positive, their movement would be made by the duty consultant, and that would be passed on to this team of Dr. Reena, Dr. Kiran, and Dr. Ratna. They would quickly, promptly start looking at who all were posted at what places. They would do the contact tracing and advise quarantine. And then we did a very fast turnover. So 1 bed, 1 patient is the policy which is being followed ever since the COVID has come. There is no sharing of beds, but everyone has to be on the toes. So we keep on, putting on the WhatsApp what beds are available, where, and the consultants are asked to discharge the patients as fast as possible. And we have some ongoing projects also. We are now started rooming in babies with mothers in the COVID suspect areas. It was not possible in a public setup like ours, but it is now taking place. Addressing COVID fatigue in frontline workers. I thought that our residents and our consultants, they all need to have some break. So I feel that everyone after 4 months or 5 months of work needs to take a 1 week break, and they should be allowed to go and visit their families so that they come charged. And also encouraging birth companions of in COVID suspect areas. This is to improve the mental state of the mothers, the workers, and the laboring patients. So these are some glimpses of our new normal. This is our morning, huddle. You can see it is 9:15. So this is where we meet every day. This is our new OPD area, which is, we have expanded it for patients to have social distancing. This is a bed for the babies, and this is mother, this is mother. These are the relatives who keep the babies and give the mothers only when they have to be fed. And this is our fetal surveillance, new OPD fetal surveillance center. So in the middle of every difficulty lies an opportunity. And that's what Albert Einstein said. And adversity always presents opportunities for introspection. And we definitely did introspection. So COVID has left us rich. It is led on to better bonding, better communication, better practices, more organized way of working, more accountability, great team spirit, and better understanding of the importance of every team member. This is, till date, we have managed 1,722 COVID suspects, out of which 288 were positive. Of these 288, 145 normal deliveries we've conducted, and 66 cesareans, and 49 ANC. So this is the breakup. This is what happened. Initially, we had 20% patients who were found positive in the green zone. And by doing QI, methodology, now we have less than 5% which are found in our green zones. And they are also quickly shifted out. Look at the number of positive healthcare workers. Initially, it was, 1733, and then now it has come down, right? So it is not as significant. So the QI journey is ongoing. It is not the end of it. It is ongoing. And I cannot finish my presentation without thanking my team of my consultants, residents, nurses, helpers, and our director, Dr. N.N. Mathur. My special thanks to Dr. Smita and team MAMSI, because in the beginning of the pandemic, we took a call that there is no point, that the patients are put to discomfort. So anyone who was antenatally found positive, all these patients, which I've said 288, have become, they are delivered with us, and then the reports had come. But anyone who comes positive and has got antenatal problem, MAMSI team takes it over from us. And any patient who comes negative there, we take their patient. So this has been a very, very wonderful relationship which has been worked, absolutely smooth. And these are my team members from MAC2. These are nurses and helpers, and these are my residents. So I wish them safety and happiness all through. So this is where we are in the COVID times. One way is that we can look back, keep looking back, and say, I can't wait till this is all over. We can go back to normal. The other is we look the other side on and feel things are, we are changing for the better. And what if we went forward instead? So I think we really need to have this kind of attitude and move forward. So thank you so much for patient hearing.
Thank you, ma'am. Thank you, ma'am, for a very lucid presentation. You faced everything, rose and organized a very doable plan, and with a lot of active management. And now I welcome Dr. Amita Suneja. Madam is a director professor and head of department, University College of Medical Sciences and GTB Hospital. She has always been interested in oncology since her postgraduate days in Safdarjung. And besides many other awards that she has received, she also got the WHO Fellowship in Gynae Oncology in Texas, USA 96, and is currently the chairperson of AOGD Oncology Committee. Madam is going to talk on this difficult topic of recent concepts in vulvar intraepithelial neoplasia. Welcome, ma'am.
Thank you, Anjali, for the kind introduction. And so I thank the organizers for beautifully organizing the conference and giving me the opportunity to speak. And I was given the choice to choose the topic. So kind of them. And the topic I choose is very dear to my heart. And it is because, this entity, vulvar intraepithelial neoplasia, is just let me have the pointer if I can have. Yeah. So this is rare condition.
Ma'am, I would request you to share your screen, please.
Okay. I didn't share it, sorry. Can you see it now?
No, ma'am. You can stop. Yeah, we can see it now. Yeah. Now you just have to do a slideshow. Yeah.
Yeah.
Thank you.
So topic I chose because this is a rare condition, but then it is incidence is increasing. It is more common in 40s, and it is mostly underdiagnosed and undertreated. People are not aware, public is not aware of the vulvar disorders, and even the gynecologists tend to ignore the most easily accessible organ while examining the patients. And it is pre-malignant. Once you get VIN, it has to be treated because over the period of time, it will lead to squamous cell carcinoma. And it is preventable. 90% of these VIN are preventable by HPV vaccination. And in the recent past, there have been many changes in the terminology, in the treatment concept. So I thought I would update during this conference. And the initial terminology coined in 1994 was like CIN, that it is VIN 1, 2, and 3. But then it was realized that there's a lot of difference. It is not analogous to cervix. There's no transformation zone, and HPV lesions are different in vulva as compared to cervical HPV lesions. And VIN1 never progresses to cancer. So in 2004, there was a revised terminology, and they kept the benign condition as separate, like warts and HPV-related disorders. And they said the VIN caused by HPV should be labeled as UVIN, that is VIN usual type. And it can be warty, bacilloid, or mixed in variety. And there's another specific variety, which is called VIN differentiated. It occurs in the pre-existing vulvar dermatosis. Like if the patient has lichen sclerosis, over the years she will have VIN and leading to vulvar cancer. And this is very dangerous. So you can remember, if differentiated is not remembered, remember dangerous VIN, DVIN. In 2015, the International Society of Study of Vulvar Disorders decided that there should be technology for HPV-induced lesions in the lower genital tract, and they introduced the terms LSIL and HICIL for vulvar disorders. And LSIL includes all those benign conditions like condyloma or the vulvar HPV-induced changes, while high-grade SIL was coined to usual VIN. So UVIN, now latest terminology is to call it as SIL, and the differentiated VIN remained as such as it was in the previous classification. Now, if we see how does UVIN differ from DVIN, there's a difference of day and night. One is a sunny day, one is as dark as night. So UVIN is more common. 90% cases of VIN are UVIN. It is associated with HPV. It occurs in younger age group and it has malignant potential, but incidence is only 5%. And it occurs over the period of 4 years. While differentiated VIN is the worst type. It is 10% of the women of VIN will have DVIN, and it is associated with other vulvar dermatosis, and it occurs in older women. The malignancy rate is 30%. The potential is 30% of the cases will have malignancy over a period of 2 years. So even the time interval is less. Now, if we see the symptomatology, the 50% are asymptomatic. So here comes the importance of examining the vulva. Look for any lesions when you do gynecological examination. Even if patient does not have any symptom, she might have a vulvar disorder. So 50% are asymptomatic, rest will have itching, burning, and those vulvar discomfort symptoms. Lesions in the UVIN can be multifocal of different size, shape, and color, and they can be of macules, papules, pigmentation, or condylomata. While in DVIN, you'll find there are white flakes. There's a distortion of the anatomy of vulva. There's a clitoral involvement, and there's a sclerosis of the introitus, the crosses, so-called crosses. And histopathologically, it is not easy to diagnose DVIN. Experienced pathologist is required to diagnose DVIN. Why? Because here whole thickness is not required, not involved. It is only the basal cells which are hyperplastic and atypical. And immunohistochemistry has a great role in diagnosing DVIN. It is positive for P53 and Ki67. While HPV-induced UVIN whole thickness will be involved, and depending upon the thickness, previously it used to be called as 1, 2, and 3. Now there's no such distinction. It is only high-grade cell, and it is positive for P16, which is HPV-related immunohistochemistry. Now, how do we treat them? Both the lesions have to be, best treatment is surgical option, but because there's a risk of occult cancer, 3% of the lesions will have occult cancer. So the surgical excision is the best option. However, sometimes in DVIN, if patient is young, we can go for ablative or by conservative management by imiquimod 5%, which is applied thrice a week for 4 months. This is immunomodulator. And for DVIN, surgery is the only option. You do wide local incision or you do vulvectomy, and margin free. There should be margin of 0 to 0.5 to 1 centimeter all around the lesion, and depth should be at least 2 to 3 millimeter deep to the skin. So we have to even take some amount of subcutaneous fat in this DVIN. Follow-up is very mandatory because there is an increased risk of vulvar cancer throughout the life once they have VIN. So the recurrence is well known, and 3 to 6 months every 2 years, you should do the follow-up and then annual follow-up. Since you have to teach the patient how to do vulvar examination in the front of the mirror. She should lie down, examine her own vulva. Every patient should be, a woman should be aware of their own vulva, and the gynecologist should not ignore this. Now, this was a very interesting case, 29 years para 2, who had persistent vulvar itching for 6 months. And we had given all types of treatment for vaginal discharge, and itching did not improve. Pap smear was no evidence of disease. Wet smear was normal. And the colposcopy revealed, we did for cervix and vulva, and grade 2 lesion. You say it is more towards high grade. And so we did the vulvoscopy also. See, it was a normal looking vulva. There no itching marks, no, absolutely normal. But vulvoscopy is basically a colposcopy of vulva, where we applied 5% acetic acid. It's a gauze piece is dipped in 5% acetic acid, put it over the vulva, open the labia minora, and for 5 minutes, because it's a thick keratinized skin. Then you see the acetowhitening changes here, and there's a sharp border. So how it has taken up the acetowhite stain, and so we can see the lesion very distinctly. So we took a biopsy from the cervix and from the vulva. For the vulva, you have to use the Keys punch biopsy. Cervical punch does not do a job because here we need the depth of the tissue. You know, this depth of the tissue is, so you rotate it clockwise, keep it perpendicular, till you reach the white shoulder of the key sponge. Then rotate this anti-clockwise and you will have the detached tissue, which is quite deep. So with the help of a forceps, you pick it up and cut it with scissors. Now, vulvar biopsy revealed it was HPV-like changes with mild to moderate dysplasia VIN2, and the cervical biopsy was CIN2, again HPV related. Now, still today, the pathologists are labeling VIN as 1, 2, and 3, despite they know the terminology has been changed. And even I'm sure gynecologists are also tuned to this terminology, VIN 1, 2, and 3. So dilemma was how to treat her. She had coexisting CIN2 and VIN2, so-called VIN2. For me, it is high-grade cell. We did thermal, she was young patient, thermal ablation for CIN2, and lesion was not that early looking. So, and even for the, there was least suspicion of occult cancer. It was a smooth lesion in the vulva. So she agreed to use this immunomodulator. We consulted our dermatologist colleagues. Imiquimod is an immunomodulator, 5% for local application, 3 days a week. It causes a denudation of epithelium. Vulva becomes raw. So another 3 days we gave her steroid ointment so that she doesn't get burning. And then we gave the treatment of 14 weeks. We can extend it up to 20 weeks. And she responded beautifully for the VIN. And she's still under follow-up. Patient was very intelligent. She said, I want to be vaccinated. So we told her that this vaccine is not therapeutic vaccine. She will be affected, it will prevent her further infection by different strains. So she completed the course of vaccination, and for this we should not be giving bivalent. Vulvar disorders are caused by 6 and 11, so we had quadrivalent available. So she took quadrivalent. Nanovalent is not available in India, but this is the best vaccine for HPV for vulva. And how can we prevent DVIN? DVIN we can prevent by taking care of the primary lesion. So very potent steroids are used for vulvar dermatosis. So patient should be under supervision by the dermatologist. If she doesn't respond, then biopsy should be taken to rule out VIN. Now, another patient where we did, remove the part of the vulva. And here, this patient was also a very educated Supreme Court advocate, had persistent itching over the vulva. And with acetic acid, you can see there's astro whitening here in the inner ring. And then we thought she will do radical for this, not radical, surgical option. And you give the mark the outer lining, and then with knife, first with the pencil, then define the inner margin. So after you have defined the inner margin, then we have to take out the skin. But here we can go deep. We can go till we can see the fat. There's no need to go much deeper in VIN. It is only the skin. So that has been removed, and beautifully this ring has been taken. We did remove clitoris also because she was symptomatic at the clitoral area. And the report again said VIN2. Actually now new terminology is high-grade cell. So we are following her every year, and she is normal to date. Now another case recently we came across, here you can see this white plaques at the posterior fourchette, and report came as UVIN. And now here I will suspect occult cancer in this, so I will not be happy with the conservative treatment, and we would like to do excision. So here we did the white local excision, and report said that it is VIN high-grade cell, and there was no occult cancer. When we give the treatment, we have to take three things into consideration. That we should make her asymptomatic. Second, we should try to preserve the vulvar anatomy. And third, we should rule out malignancy. So now this is an interesting case, my last case, that is differentiated VIN. This patient was getting treatment from skin for 2 years for lichen planus. And you see the lesion all around the introitus, black pigmented. And there are also satellite areas. And one was here, one was here. So she had high-grade cell on the pap smear. And, the colposcopy was normal. So we thought at the same sitting, and biopsy from the lesion, vulvar lesion revealed VIN. They did not say differentiated, they said high-grade cell. But once it is in the existing dermatosis, it is DVIN. So we thought of doing excision of the lesion, wide excision, along with the conization. So we took her, and under GA, we removed the part of the involved. It was white involved. Even the lateral satellite areas were taken out. This was the confluent area, the satellite areas, and from the left side, then almost skimming vulvectomy was done, keeping the margin around it around 1 centimeter free. And clitoris was spared because that was not involved. And the report said it was VIN3. And from the left satellite area, that showed superficial invasion. That means there was squamous cell carcinoma, which was less than 0.5 millimeter. And cervical cone was normal. So there was a dilemma what to do next. She was operated in December 16. And so we referred her to Delhi State Cancer. We discussed it. And there was a lymph node on the right side. The lesion which came positive was the left side. But we took the biopsy of the right side lymph node. They did not show any malignancy. PET-CT was done. That was normal. So the consensus was, we discussed that we keep her under observation. And so in 2019, she had recurrent itching and lesion on the clitoris, very small lesions. You see the clitoris, and one lesion is here, the other lesion is here. So there were 4 lesions, and she again had itching. So we took biopsy from the 4 lesions, from the clitoris and from the other 3 patchy areas. And the clitoral lesion again revealed VIN, and otherwise all 3 biopsies showed there's a fibrosis and sclerosis. So dilemma is what next? So now after that, there was a lockdown. We had decided to do clitoral biopsy, and we excise the whole area with the lesion over the clitoris. We'll do clitoridectomy. And then if that shows invasion, she goes for radical vulvectomy and bilateral inguinal lymphadenectomy. But if that is only VIN, I think again we can observe her. But there are so many options, and we can discuss it later. But finally, we have to discuss it with the patient. She is yet to come. Thank you very much.
Thank you, Amita, for a wonderful presentation, excellent presentation on a topic which is very uncommon yet very important. And now it's time now for a video presentation by Plus Plus, one of our platinum sponsors. So just the video will run shortly.
Dear doctor, pregnancy is a beautiful journey in a woman's life. A journey where she needs care and your expert advice. As her body goes through a 9-month-long transformation, she requires extensive nutrition. Nutrition that nurtures her growing baby and helps her navigate through some unpleasant experiences of pregnancy. Introducing TrimaCare, 9 months of extraordinary care for an extraordinary role. A prenatal pill designed to fulfill complete nutritional needs of Indian pregnant mothers. TrimaCare 1, 2 and 3 are specially designed for each trimester of pregnancy and the growing needs of mother and child at each stage. TrimaCare is formulated by experts following the ICMR guidelines. It's made with iron, folate, calcium, vitamin D, omega, and more than 25 nutrients essential for a healthy pregnancy. TrimaCare adheres to multi-micronutrient supplementation known to reduce risks of low birth weight, preterm births, and babies born small for gestational age, and also helps in fetal neurodevelopment. With the right ingredients, TrimaCare helps reduce commonly experienced symptoms in pregnancy like nausea, vomiting, morning sickness, constipation, UTI, leg cramps, and hypertension. TrimaCare is free from allergens, is non-GMO, has higher absorption value, is gentle on the stomach, is 100% vegetarian, and is made with premium ingredients. Dear doctor, now no more trouble of prescribing multiple pills to your pregnant patients. Choose trimester-wise care. Choose the right nutrition for Indian pregnant mothers. Choose TrimaCare.
Our last speaker, Dr. Shashilata Kabra, unfortunately couldn't join in. So we conclude the day and today's session, and I thank all the chairpersons and speakers of this session. And we will be now live tomorrow. I request all to visit the stalls and e-posters. The link will be live from 11 a.m. onwards. So please visit the stalls, and we conclude the today's session today. Thank you. Thanks for joining. And the link for GBM is open in a separate hall. All the AOGD members may join in. Thank you.
Thank you, ma'am.
We conclude.
Yeah, it's done, ma'am. We are not live now. So the same link will be used for test run for tomorrow's coordinators. So people who want to leave can leave. Thank you.
Yeah. Okay.